prevention, but on the day-to-day, people don't need us to sleep the appropriate number of hours a night and eat right and exercise and wear seatbelts. But yes, we always remind them about doing it. Secondary prevention is about screening and intervening. It's about finding disease processes very early on in their asymptomatic or preclinical state so that we can intervene before it becomes clinically significant. Think about the things that we screen for. Some examples are listed here on your slide. We screen for high blood pressure so that we can intervene as soon as we identify it before target organ damage develops. We do mammograms and colonoscopies to find cancer in their very earliest states and intervene before they become metastatic. And then tertiary prevention is about after a disease state or problem occurs, trying to minimize its consequences. We want to optimize function and minimize deterioration. So this is treating something after it occurs to try to keep it from getting any worse and maximize the patient's functional status. This is rehab after the stroke. This is controlling lipids after the cardiovascular event occurs. This is optimizing blood sugar after diabetes occurs. And yes, some people do see it as a failure of primary prevention, although that's hardly fair. I mean, it's not, I don't think it's appropriate to say that if everybody lives right, eats right, sleeps right, etc., they will never develop a disease state. Like, I mean, if only that was true. But sometimes, despite our best efforts, largely as a function of our gene pool and the environment we live in, diseases will happen, and then tertiary preventative strategies become important to try to maximize circumstances for that patient. But whatever, that's a philosophical conversation, not appropriate for us right now. What's most important is that you really can identify the differences among primary, secondary, and tertiary prevention. Because, like I said, you just want that to be second nature. It's kind of like you can't really form words or write a sentence until you know the alphabet, but you don't think about the alphabet when you're forming sentences. That's just kind of second nature. And that's the way it is with levels of prevention. They're the alphabet, they should just be second nature as you are developing your approach to the patient. So, in a 46-year-old woman with hypertension and dyslipidemia, if you counsel this lady about reducing risk for sexually transmitted infection, primary, secondary, or tertiary, and it's primary strategy, we're trying to keep her from getting one. On this same patient, if we do a skin survey for precancerous lesions, secondary prevention, we are screening and intervening. We want to find those lesions that look suspicious and get rid of them before they could become invasive cancer. In a 66-year-old woman with type 2 diabetes, if we order a flu vaccine, again, we're trying to keep her from getting the flu, primary prevention. If we adjust therapy in this lady with diabetes to enhance glycemic control, that's tertiary. She's already got diabetes, but we want to try to minimize vascular consequences. In a 25-year-old well woman with a strong family history of type 2, if we check her lipid profile, screen and intervene, secondary prevention. If we take this 25-year-old well woman with a strong family history of type 2 and we teach her about the benefits of a moderate intensity exercise program, that's primary prevention. Remember, she's well and we want to keep her that way by teaching about exercise. And finally, in a 76-year-old man with COPD, if we counsel this gentleman to ensure adequate illumination at home, we are trying to prevent accidents. Remember, in the older adult population, accidents are a leading cause of morbidity. And many times, those accidents, the risk is exacerbated by just like the normal decline in sensory function at that age. So, most accidents in the older adult happen at home, and just not having optimal vision, age-related cataracts can contribute to that. So anyway, counseling people to ensure adequate illumination, we're trying to prevent accidents. It's primary prevention. Screening this gentleman for physical, emotional, or financial abuse, or screening him for anything else for which he is at risk, is screening and intervening. That's secondary prevention. Primary, secondary, and tertiary prevention. You want the words to just, or the concepts really, not just the words, but the concepts to just roll off the tongue without a second thought. Now, with respect to primary prevention and immunization, because immunization really is that piece of primary prevention that people will have to come to you about, even if you don't actually administer vaccines in your practice, if you develop relationships with people, they will ask you what you think. They will ask your opinion. There's so much information and misinformation out there, and as their primary care provider, you're often the one they will turn to say like, "Hey, should the pediatrician wants to give my baby 5 vaccines at one shot. Should I let them do it? What do you think?" So, when they ask you if their kids should get a polio vaccine, the answer is yes. The evidence is clear and unambiguous. Before we had a polio vaccine in the United States, 10,000 children were paralyzed every year in the United States from polio, 3,000 dead before we had a polio vaccine. So if the patient is seeing information on a blog or a website or some famous star says you shouldn't do it because it will cause autism, it's wrong. And this is how we can share that information. Same thing with German measles. If the patient says, "Oh, I saw like on the web that lady from The Masked Singer, she says that you shouldn't give your kids these vaccines because it'll cause autism." The answer is no, that's not true. There's no evidence to support that. We do, however, know that before we had a rubella vaccine, 20,000 newborns in the United States every year were born with serious permanent congenital consequences. And now that we have a rubella vaccine, that rarely happens. Measles. Every time I see this, I just want to cry because, like, the measles was considered eradicated in the United States 40 years ago, and now it's back because of anti vaxxers. If it is estimated that if we did not have a measles vaccine, there would be 12,000 measles deaths. Measles isn't just like an annoying rash, measles kills people. And if we didn't have a vaccine, it is estimated that in the United States alone, every year 12,000 people would die. Worldwide, almost 3 million would die. So when people say, "Should my kid get the measles vaccine?" the answer is absolute, unambiguous yes. Even the flu vaccine, people have so many excuses for why they don't want to get a flu shot, and nurses used to be the worst of it. I mean, now many facilities require that you have a flu vaccine to work there, but well, like when I was first a nurse in a hospital, we didn't weren't required to have a flu shot, and myself included, nurses, we were like the worst. We always had all these reasons like, "Oh, the flu shot gives me the flu," or "I never get the flu," or "I got it once and I got the flu," all of which is like just totally not true. The flu vaccine is an inactive vaccine. It cannot make you sick. It just can't give you the flu. It can give you a minor reaction, which is way better than having the flu, but the flu vaccine does not give you the flu. Absolutely no way does it give you the flu. If the population was optimally vaccinated, like everybody who is eligible for a flu vaccine got it every year, it would help avoid 7 million cases. It would help avoid over 100,000 hospitalizations and even 9,000 deaths. If you don't work with a high risk or vulnerable population, it's easy to forget how many people die every year. Totally preventable deaths. They die because they get the flu and they were already vulnerable or in suboptimal health, and the flu kills them. Flu vaccine is hugely important. It may not keep you from getting the flu. Not every year does the flu vaccine have that level of efficacy. But even in people who get it, it can make it much less profound, much less intense, and much shorter duration. Pneumococcal vaccine is another one. It is estimated that there are 40,000 deaths from pneumococcus every year in the United States. I mean, it's not just about pneumonia. There's also meningitis, sepsis, septicemia. It is estimated that if the population was optimally vaccinated, in other words, everybody eligible for pneumococcal vaccine had it, we could cut that number in half. Even the COVID vaccine. Now, I know this is like the elephant in the room. It remains debatable. People have different opinions on this. I'm not sure I agree with this assertion, but the official position of the CDC is that COVID-19 vaccination provides more than 90% protection against hospitalization and death. and up to 50% reduced risk of long COVID. So they have acknowledged that the COVID vaccine does not protect the entire population. It doesn't contribute to herd immunity, but it can markedly reduce the risk of the person who gets the vaccine. So I know this is still a hot topic. And fortunately, again, we don't have to deal with hot topics here. This isn't an ethics course. This is preparing for entry level boards. And so part of our job as an MP, period, but you have to start it at the entry level, is that it's our job to share with the patient evidence based information. And this is what the evidence currently supports about this vaccine. So when a patient asks you, should I get the COVID vaccine? I was seeing online that it can give you myocarditis and this and that and the other thing. Our evidence-based answer is that the protection it provides is markedly better than the risk of getting COVID. And I will say, like, I'm not here to champion the COVID vaccine by any means, but I will tell you that one of the biggest problems with all of these assertions about myocarditis and cardiac deaths, and I know you see famous names out there asserting this, but what they don't share with you are the data on people that didn't get the vaccine and have those things. And, while myocarditis is relatively uncommon, thankfully, it does have a tendency to occur more often in younger men and adolescent boys. And so when you see a stat that like X percent of adolescent and young adult males who got the COVID vaccine got myocarditis, nobody shares with you the percentage of that same population who didn't get the vaccine and got myocarditis, and the number is analogous. In other words, it really doesn't seem that the vaccine has anything to do with it, that a certain percentage of that population will get myocarditis, vaccine or not. So that's a problem with a lot of what's asserted about this vaccine. And like I said, I'm not here to champion the vaccine or try to talk you into it or out of it. That's just a side note. But what I am here to tell you that it's our professional ethical responsibility to give the patient evidence-based information about primary prevention. And that's the current evidence-based position on the COVID vaccine. So as a result, evidence-based practice advises that vaccine-related risk, and this is all vaccines, not just COVID, vaccine risk is hugely less than disease-related risk, that the cost of vaccines is enormously outweighed by the expense of treating these diseases when they occur. With everything except COVID, higher immunization rates contributes to herd immunity, or community immunity is really supposed to be the more appropriate term. I guess people don't like being referred to as part of a herd, but immunity is the better term, but a lot of people still say herd. So we just show them both here to make sure you understand what we're talking about. If you have an entire community or an entire herd that's vaccinated against measles, except for like the 0.1 cent that has a true contraindication to the vaccine, well, since they're surrounded by people who are immunized, their likelihood of getting it went down. That's what herd or community immunity is. And so, advocating that patients of all ages always be offered protection against any vaccine preventable disease for which they are eligible is just an important part of what we do. And it's how we're supposed to counsel people. We also have table 2.3, some immunization principles. And the first one is about removing geographic and clinical practice barriers. Remember, again, it's our professional responsibility to counsel people in accordance with the evidence and to promote population health, not just in the exam room with one patient, but it's part of our role as advanced practice nurses to try to promote population health. So whenever you have the opportunity, whether it's, a work project, an organization project, or a local healthcare association that you belong to, helping reach out to populations in need. I mean, we've seen what the federal government can do when it needs to rapidly mobilize an immunization program, and contributing to that and contributing to good information and not misinformation is also an important part of what we do. Also, when in doubt, re-immunize. There is no particular risk to having a quote extra dose of a vaccine. Better to give an extra vaccine than to give none at all. So, if the patient's in the office and your MA is telling them what they're eligible for, and then you walk in and the patient's like, well, I don't know, I think maybe I might have actually had this vaccine already. And you can say, great, let me know where you got it, and we'll call and just confirm with the records. And then the patient says, well, I'm not sure if it was this year or last year. I mean, I don't remember. And the immunization, the online state-based web IZ doesn't confirm this. Whatever, just give it again. When you're not sure, better to give an extra dose. The only risk with a quote extra dose is the infinitesimal risk of a vaccine reaction. And we know that if you let people out without a vaccine, the likelihood that they'll come back and get it just dropped enormously. Immunizations deferred are immunizations denied. So if you think somebody should have a vaccine and for any reason you don't give it, the chance that they'll come back just plummeted. There's only a very few reasons to defer a vaccine. Minor illness is not one of them. You don't need to hold off on a vaccine for a little kid with an ear infection because they have an ear infection. That's not a reason to defer the vaccine for whatever reason, or bronchitis, or all the reasons that people tell you. If you let them out alive without the vaccine, chances that they'll come back are minimal. That's why no letting them out alive. That's what I say. We have 2 arms, 2 legs, and 2 gluteus maximi. We can shoot people up 6 different ways, literally, with vaccines on every visit. Now, I realize you can't tie them down and make them take a vaccine they don't want. But if there's any hesitancy, any ambiguity, and they're not sure should they get it, the answer is yes. Just give it to them again. I'll never forget years ago. In fact, it was 2014. My medical assistant, we were working in a very rural area, and the medical assistant walks in my room and she says, "What should I do? I just drew this up, and I thought he needed it, but he didn't." And she had a Tdap in her hand that she was going to give the patient, but then she realized he didn't need it. And I said, "Give it to me, right here." Right deltoid. Like, I didn't remember when my last Tdap was. I'm sure it was probably within the last 10 years, but I couldn't remember. So I said, give it to me and we'll put it in WebIZ and then I'll know for sure. And that's exactly what she did. Shoot it up in my arm rather than waste it. And as it turned out, it's a good thing because I don't know when my last one was, but I remembered that 2014 because then in 2024, I knew that it was time to do another one. So, point made. Don't waste vaccines. Or the real point is immunization deferred is immunization denied. So if there's any question, just give it again. It's not gonna cause any problems except for like the 1 in 1 million chance of a reaction. Also, with respect to vaccine principles, you want to know the difference between active immunity vaccines and passive immunity vaccines. Active immunity vaccine is when the patient, him or herself, develops the antibody in response to the vaccine. So there's pros and cons here. The pro is that this is an antibody the patient, him or herself, develops endogenously, so it tends to last a very long time. There are exceptions, but protection is usually very long. The downside is the patient does have to develop the antibody, and it takes some time. So they're not protected immediately upon getting the vaccine. It can take many weeks or even a month to develop that antibody. This is like where this whole myth of the flu shot gave me the flu seems to come from. It sounds like what happens is people don't want to get a flu shot, and then all of a sudden everybody around them gets the flu and they see how sick they are and they say, "Ooh, I don't want that." So then they come in to get a flu shot and they get a flu shot and then they get sick the next week. And they think it's from the flu shot when in fact the flu shot hasn't really done anything yet. The problem is they were already exposed by being around all the sick people. They were already exposed before they were immunized, and that's where the flu came from. So it takes a while, but once they get antibodies, they generally tend to last a while. Now, I just used the flu as an example, and of course, you need a flu shot every year. It's not that the antibodies that you make disappear, it's that the flu mutates. So if you've been getting flu shots every year for the last 45 years, you probably have 45 cents of flu antibodies floating around. It's just that next year the flu will mutate and become a 46 type, and then you need to develop antibodies against that. And they do. I mean, there certainly are flu vaccines that are effective against more than one type. So if you've got a bunch of flu shots on board every year, you get the vaccine and make all these antibodies, chances are one of those things floating around might protect you from the version that comes out next year. But you just never know for sure. So your best bet always is to get the most current vaccine. Now, passive immunity vaccines are a little bit different. These are not grown in the patient's blood. Passive immunity vaccines, usually in the form of immune globulin, these are cultured in banked blood and they're stored and they just wait for somebody to need them. These are used for post exposure protection or if an exposure is imminent. Like if someone has not been immunized against Hep B, and then rather unexpectedly, they have the opportunity to go to a country where Hep B is endemic, but they don't have time to get the whole Hep B series. They can get Hep B immune globulin passive immunity vaccine that will protect them within a few hours of being administered because it's already mature when it's administered. And these are not mutually exclusive. I mean, they have different roles and sometimes are used together. One of the best examples I can give you, I learned a lot working in a rural clinic. I mean, I'm from the Philadelphia area and I never knew anything about rural health until I moved to Nevada because most of the state is actually rural. And I was working as a locum tenens FNP in a very rural clinic. And one day, like, you can see I'm very time oriented. Like I start on time and stop on time and everything's time, 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 almost to the point of needing medication. And so like I could never work in a walk-in urgent care. It would drive me nuts. But when I was working in this rural clinic, we did get walk-in patients sometimes, which did drive me nuts, but that's besides the point. Anyway, I was fairly new there and it was just me and the MA and the front desk person. And both the MA and the front desk person were local to the community. They worked in that clinic for decades. So one day I'm sitting in my little office in my little um, clinic that I think it was a big trailer if I remember right. Anyway, I'm sitting at my desk and I hear the phone ring and then I hear the medical assistant say, "Oh yeah, come on in." So when she hung up, I said, "What's going on?" She's like, "Oh, Joe Smith needs a tetanus shot. He stepped on a nail." And I was like, "Oh man." My first thought was, "Wow, people really do step on rusty nails." Because when I was in nursing school, we were always taught about stepping on a rusty nail and getting tetanus and getting lockjaw, and it's so bad, and that you should have a tetanus vaccine so you don't get lockjaw. Anyway, and then for the next, I don't know, 20 years, I never had a patient step on a rusty nail. So I was really kind of surprised when the patient stepped on a nail. But then the next thing I said to her is, wow, we have immune globulin. We have tetanus immune globulin because tetanus immune globulin, the passive immunity vaccine, is actually pretty expensive and most small practices don't have it. So usually you have to go to an ER for it. And I was kind of surprised we even had it. And she's like, well, no, we just have Tdap. And I said, "Oh, well, did you tell him that Tdap isn't going to protect him from this stepping on the nail today?" And she kind of looked at me like I had three heads and said, "Well, every other provider just says to give the Tdap." So I'm like, "Great. Now I have to do that thing that nobody ever wants to do. You have to be the one who does something different in a small clinic where everybody else always did the same thing." So I start like trying to download from the internet some information about the difference between Tdap as an active immunity vaccine and tetanus immune globulin as a passive immunity vaccine so that she could understand the difference because this lady was not dumb. She had just never been told before. If you step on a rusty nail or have any sort of puncture or laceration, whatever, and you don't know when your last tetanus shot was, you're not sure if you're immune, you need tetanus immune globulin, the passive immunity vaccine that will protect you right now with an administered mature immune globulin. You do also need a Tdap because you need to develop antibodies to protect you from every other nail you ever step on. But if you take a Tdap, tetanus, diphtheria, cellular pertussis, you're not going to have antibodies of your own for a month. So it's not going to help you today. So the real answer for somebody like that is they need both. They need a tetanus immune globulin in one arm and a Tdap in the other arm. And just nobody had ever told her that before. So lucky me, I got to be the one to do it. They're not mutually exclusive. Sometimes they need to be given simultaneously. So Joseph is a 28-year-old man who presents to your practice with a 2-hour history of superficial laceration on his forearm that is approximately 2 centimeters in length. This happened when he was replacing a window pane and was cut by the glass. Physical exam is consistent with history. His record notes a Tdap vaccine given approximately 2 years ago and documentation of a primary tetanus series. When considering his immunization needs today, the NP appreciates that Joseph should receive what? Should he have a tetanus diphtheria booster? Should he have a tetanus diphtheria acellular pertussis booster? Should he have a dose of tetanus immune globulin or no tetanus vaccine at all? Well, he had a primary series and he had a booster 2 years ago. He's immune. What he needs is a discussion of accident prevention, but he doesn't need any tetanus vaccine today. So that's the moral of the story for active versus passive immunity vaccines. Table 2.5 in your handout gives you a little bit more information about tetanus prophylaxis. Sometimes for a dirty wound, we approach this a little bit more aggressively. But if you're okay with the concepts as we just discussed them, then you'll be fine answering any vaccine question. Test success tip number 100. True vaccine contraindications are rare. Localized vaccine reactions are common and self-limiting. True story. When people tell you vaccines, oh, they make them so sick, it's just not true. Like I said, with the flu, they usually wind up getting the flu because they wait too long for the flu shot. There's a very small fraction of people that actually have an anaphylactic reaction to a vaccine component. And you see some examples here on the table, and it's not here for you to memorize it. I swear, like, I don't know this. I do remember Baker's yeast and hepatitis B. I don't know why. But all these other ones, I totally would not remember which thing causes anaphylaxis in which vaccine. You don't have to know all that detail for your exam either. Remember, this is a test of concepts. What you do need to know is that there are some allergies that contraindicate a vaccine. So the concept is when the patient comes to you and says, your patient in room 2 is ready, they're eligible for these 3 vaccines today. Can I give them? You have to know whether they can be safely given or not. And one of the things that you need to do is look at the allergy list. If the patient has no allergies, just confirm no allergies, and that's the end of that. If the patient does show allergies on their allergy list, then you should remember that you need to investigate whether or not that allergy contraindicates that vaccine. That's the principle that you need to take away, is that there are certain allergies that, when they are anaphylactic, preclude administration of a vaccine. So before you safely order a vaccine for a patient, you want to make sure that none of their allergies contraindicate that particular vaccine, because it's a very minor risk, but anaphylaxis can be fatal. So because anaphylaxis is a safety issue, it's not common, but it's a safety issue, so we have to take a few minutes to talk about it. So number 1, in terms of incidence, the risk of anaphylaxis is exceedingly low for vaccines. The stat is 1 to 2 events per 1 million vaccines given. So most of you will never see anaphylaxis as a vaccine response in your career. But if you do, you want to know what to do about it. You want to recognize it and know what to do about it. Now, you might see anaphylaxis for another reason, but to see it in response to a vaccine is very rare. However, you do want to recognize it. And so by definition, anaphylaxis is just like the slide says, acute and life-threatening. And what it really boils down to is it's not just edema and it's not just hives. Often they will be there, but what makes it anaphylaxis is that the patient also has either IgE-mediated bronchoconstriction and they can't breathe, and or IgE-mediated vasodilation, where their blood pressure drops so low they go into septic shock, or not septic, they go into shock. They go into a distributive shock. And there are people that actually do get gastrointestinal symptoms as a consequence of anaphylaxis. I know when somebody tells us that they're allergic to this drug because it makes them puke, we tend to think, yeah, right, it's not an allergy. And that probably isn't an allergy, but there are overt GI phenomenon that can rarely present as anaphylaxis. But the real takeaway is anaphylaxis is not just an allergy. It's allergy response, including either bronchoconstriction and or vasodilation. So like here, you see this little guy on the left, he's having angioedema. It could very well be allergic, but obviously he's not having anaphylaxis because somebody said, "Hey, sit down and we'll take your picture and put it on the internet." Where if he was having anaphylaxis, they should be busy like managing his airway and calling 911. Same thing with the urticaria. This rash is very classic of an allergic response, but if the patient were having anaphylaxis, he probably wouldn't be posing for an internet shot. So, angioedema and urticaria are often allergic reactions and they do occur, and in themselves, while annoying, they are not emergent. They only become emergent and become anaphylaxis when there is coincident bronchoconstriction and or vasodilation to the extent that they can't breathe or they can't perfuse the brain. So what do you do if you see anaphylaxis in your office? Well, again, we're talking about primary care here. You probably don't have a ventilator on standby. In the primary care setting, if you deduce the patient is having anaphylaxis, again, this is an unstable patient. So intervention is first. And really down to the basics, airway, breathing, and circulation. If the patient feels like their throat is closing up or their tongue is swelling, or you have any concerns at all about respiration, protect the airway as best you can. If you have a oropharyngeal airway taped inside a closet somewhere, grab it, wipe the dust off it, and shove it in their oropharynx. If you have oxygen in the office, put it on. If you don't have any of these things, you can at least position them for optimal breathing, with head positioning. You also, of course, want to check blood pressure if they have vasodilation. The concern is that systolic pressure can fall below 70, or yeah, fall below 70, and you have to position them for optimal perfusion of the brain. If you have the ability to start an IV, if you have IV supplies in the office, start it now before their vessels collapse. Of course, simultaneously, your front desk is calling 911 and your medical assistant is going off to find the epinephrine because if you give injections in your office, for that matter, any office really should have epinephrine available. But if you're giving injections, you definitely want to have, at a minimum, epinephrine readily available, and your MA rushes off to get that so you can inject it. Those are the immediate interventions for anaphylaxis in the primary care office. If you happen to have an antihistamine like Benadryl laying around and the patient can swallow, have them take it. If you can inject it, and then you just continue to support these vital functions and wait for the ambulance to get there. Then they go to the hospital, and the hospital will do what hospitals do, which is in your handout, but we don't review it here because we're not studying for the emergency nurse practitioner exam. When you study for the ENP exam, you'll come back and talk about this piece. But what we do have to look at is what happens when they come home. Because everybody, excuse me, everybody who goes to a hospital for any reason, whether it's a couple hours in the ER or a 30-day hospital stay, and the last thing anybody says to them before they leave is follow up with your primary care provider. So if a patient comes back to you and says, "Hey, I was in the hospital because I had allergic thing and I couldn't breathe and it was really scary, and but now I'm home and they told me to follow up with you." There are two priorities of care. I know the slide here has a lot of stuff on it. It narrows down to two priorities of care. Number one, figure out what they're allergic to if they don't know. If they know what they're allergic to, the question is, how did you get exposed to it? And how can we make that not happen again? But if they don't know what they're allergic to and they had an anaphylactic reaction, we have to find out. The best practices approach would be to refer them to allergy and immunology. And if you can, great. If for some reason they can't go to an allergist, then you need to start working up the patient now, like with a good history of the event. What were any exposures before it happened? Were there any new exposures? You can do blood testing for some allergens. You can do skin testing. You just try to do the best you can. But the basic principle is if someone has had an anaphylactic reaction and they don't know why, you got to figure it out. And then the other thing is that everybody with a history of anaphylaxis should have an EpiPen or some, whether it's Neffy, they know the new inhaled one, or an EpiPen. Everybody with an anaphylactic history should have epinephrine immediately available and know how and when to use it. So those are the two principles to keep in mind of post-hospitalization for anaphylaxis. Find out what they're allergic to, and everybody has epinephrine and knows how and when to use it. And so, switching gears just a bit, in a community undergoing a disaster, The use of select vaccines will be prioritized. Match the type of disaster with the priority vaccine. So, again, we're prioritizing, which remember I said is an important skill for your boards. There might be reasons to give any one of these people several vaccines, but we have to prioritize. So, we have three options: tetanus, influenza, and Hep A. Which one is the priority for uninjured adults and children evacuated to a crowded group setting? If you had to pick one, what's it going to be? It's going to be immunization against the airborne illness, influenza. Whereas adults with multiple deep lacerations from flying debris, like after, an explosion or a tornado or something like that, it's for tetanus because of those lacerations. And finally, the last one is the last one, so I guess it's not a mystery. But remember that hepatitis A is transmitted via the oral fecal route. And so patients who are exposed to an unsafe water supply are at high risk for Hep A. People that are in high flood areas or, were subject to major flooding after a big hurricane or something, um, they need to be immunized against Hep A. So that's how we prioritize. All right, true or false? True or false? Immune globulin is a concentrated solution of antibodies derived from pooled donated blood. True or false? That's true. Remember, that's passive immunity. It's cultured in banked blood. True or false? Given that contraindications to flu and COVID-19 vaccines are rare, nearly everyone 6 months of age should be encouraged to receive them. And that is true. That is true. That's the current evidence-based recommendation. True or false? Influenza and COVID-19 vaccines should be separated by at least 4 weeks. False. You can totally give them at the same visit. You can't give them in the same syringe. We're talking 2 separate injections here, but you can give them on the same day. Remember, 2 arms, 2 legs, and 2 gluteus maximi. So you can poke people up with 6 different vaccines if you want. Another vaccine thing that we need to consider is that some vaccines are live attenuated viruses. In the United States, we now have multiple types of vaccines. We have the wholly inactivated, we have the live attenuated, we have recombinant DNA, we have mRNA, we have all sorts of different types of vaccines. The only one that's living are the live attenuated viruses, and they're the only ones that can actually give people the disease. Everything else can't. Every other vaccine, it can certainly make you have a fever as your immune response is incited. I mean, that's the point of it. Part of generating antibodies is heat. It's a protective mechanism. You can get sore injection site and you can get fever, and it can be uncomfortable for a day or two, but it's not the disease. Whereas live attenuated viruses, they actually are living virus that are weakened by being passed through an animal host. And for most people, it's perfectly safe. They're living, but they're weakened to the extent that they can't cause illness. They can just cause antibody production, but there are certain groups of people that can't take live virus vaccines, and they're listed on the slide in front of you. So on the left, you see the live virus vaccines that are licensed in the United States today. And on the right, you see the people that can't take them. And it really just comes down to pregnancy or people that are immune compromised. Whether they're immune compromised due to a disease state like HIV or immune compromised as a medication complication like chemotherapy or long term steroid use or what do you call it? The immune modulators that we use for autoimmune diseases. Like those are all people that shouldn't get live virus vaccines. HIV, of course, presents its own particular interesting clinical phenomenon because definitely we want people with HIV to be optimally vaccinated. The last thing we want is for them to get an infection because, their problem is that they can't mount a good immune response. But at the same time, we don't want to give them a vaccine that could make them sick. So that's really up to the infectious disease provider to decide. If someone has HIV and they are being managed by infectious diseases will decide what vaccines they need. But for everybody else, people that are on high doses of steroids or immune modulators, like I said, their immune system is suboptimal. And no live viruses for them, and of course, never in pregnancy. The rotavirus vaccine is mentioned here. It's a little bit unique because it's only for very, very young babies. I think you have to finish the entire series by 6 months old. So if you don't start it on time, we just don't give it. But it is a live virus vaccine and it's given orally. And so, two things to remember. Number one, we don't give it to severely immunocompromised infants. Now, I don't know about you. I'll take on a lot. I mean, I'm very comfortable in my skill set across the lifespan in many areas, but one thing I will not manage are severely immunocompromised infants under the age of 6 months old. I refer them to the severely immunocompromised infant provider, which is not me. So that's certainly a decision that they would make. But the other thing to keep in mind is that sometimes we have parents who are concerned that if the vaccine goes in the mouth, what's coming out the other end? Like if you're putting a live virus in, what's coming out, and could people catch it from changing diapers? And the answer is no. What comes out in the stool is harmless. It's not going to hurt anybody any more than just touching stool would. So good old fashioned diaper hygiene, regular garden variety universal precautions is the order of the day. No other particular protections are required. In your workbook, let's see, you got tables. We always have tables. We have table 2.9, Advisory Committee on Immunization Practices. So these are lots of recommendations about vaccines. Then table 2.10 is a big table of all potential, what do you call it, reactions to vaccines. Please don't try to memorize all of these again. These are just for your general wealth of information. Um, in the immunization schedule, which is available at the CDC, again, I've had people ask me if they have to memorize that entire grid. In fact, I understand in school, some of you have to memorize the entire CDC grid. You don't need to memorize it for your boards. I don't know it. I mean, there's a few things I could tell you off the top of my head that I just remember from having done it in practice so often that like the hepatitis B vaccine begins at birth. The rest of the vaccines like tetanus, diphtheria, pertussis, they begin at 2 months old. The live virus vaccines like MMR and or not shingles, MMR and chickenpox vaccine, they begin at age 1. Um, that we need to start meningococcal vaccines in early adolescence, that the HPV vaccine begins at age 9. And I think off the top of my head, that's all I could tell you off the top of my head. Um, on your boards, it's not about memorizing the entire vaccine schedule. It's about knowing who can safely take it, as we've discussed, and about recognizing serious reactions like anaphylaxis, which we have also discussed. So the vaccine schedule is there for your perusal if you're so inclined, but please don't try to memorize it for your boards. Now we have to talk about secondary prevention. Screen and intervene. Counseling about and providing opportunity for secondary prevention really is an extremely important part of what we do. This is really different from bedside nursing and acute care. We don't have the same kind of patient relationships. I mean, you hope to bond with your patient for the short time that they're in the hospital, then you want them to leave and you never want to see them again because you don't want them to get that sick. But in primary care, we do, like it or not, have long-term relationships with patients, and we are the professionals, so we have to take the lead on it, and counseling them about screening and secondary prevention really is important. So when you start to tell people, hey, it's time to think about a mammogram, you really should do colon cancer screening, we need to check your lipids, and they say, why? I don't want to do that. My grandmother got mammograms faithfully. Every year, they always told her she was fine, and then she got breast cancer and died. Or my mother got mammograms every year, and they told her they found something, and they did an ultrasound, and they had to do a biopsy, and then it got infected, and she had to be on antibiotics and blah, 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 and there was never anything wrong. Like that kind of stuff does happen, and people are like, why? Why do I really need this screening? There are people who think it's like a, what do you call it, government generated conspiracy to make $1 million. I don't know who's getting $1 million, definitely not us. But you want to know how to talk to people when they say, why should I do this? Why should I do that? To just say, oh, the guidelines say, isn't really impressive to anybody because then they're like, well, whose guidelines? What? Where does that come from? Is this the let's make money guideline? And it's not. There really are secondary prevention principles that, if people understand them, they may be more inclined to follow them. So number one, you want to make sure people understand that secondary prevention, it is not a fail-safe. It's not 100%. Yes, there are people who have negative mammograms and go on to get breast cancer. or negative colonoscopies and go on to get colon cancer. Having a screening doesn't completely eliminate the risk, it just means the likelihood is lesser because there's a greater chance we will find it early. So we can't promise anybody that getting mammograms will guarantee they don't get breast cancer, but it does decrease the likelihood hugely because most cases you can find it early and then intervene. So manage expectations. You want them to know what a screening does and what it cannot do. Screening is about you, the patient, belong to a risk group where the risk of this condition is very high. So we're just going to screen you for it and just see if it happens to be there. It's not about working up a complaint or a lump or a blump or blood in stool. That's a diagnostic evaluation and that's different. Screening is, oh, you belong to this group. So you are at high enough risk for this thing that we're going to test you for it. And there are certain secondary prevention principles that go into the development of guidelines about who should be screened for what when. And these are the things that you should know so that you're confident in what you're counseling people and that you can explain to people who really want to know, do you really think they should have this screening? So, for instance, mammography. The prevalence of the disease justifies screening. So we know that mammography is universally recommended in women over 50. And I know some of you are thinking it's women over 40. No, it's not. It's women over 50. We have the American Cancer Society, the USPS Task Force, the American College of Obstetricians and Gynecologists, and there's several different groups of people that make recommendations about breast cancer screening. While there's differing opinions sometimes from one group to the other, everybody agrees that all women over 50 should have annual mammograms. And then at a certain point, you can go to biannually. The 40 to 49 thing, it depends on whose recommendations you read. Generally speaking, most groups will suggest that women 40 to 44, the decision to do a mammogram or not is an individual one. There's no strong evidence for a routine across the board recommendation, but some women will choose to do so and should talk to their provider. From 45 to 49, I think the USPS task force does recommend that women over 45 start getting annual mammograms. But again, like the American Cancer Society still sees this as an individual patient-provider discussion without firm evidence to support a routine recommendation, but everybody over 50 should have one. And the rationale is that breast cancer is so common in women over 50 that it's worth screening every single woman um, over 50. Men get breast cancer. Women even under 40 get breast cancer, but not in nearly high enough numbers to warrant screening everyone. So, secondary prevention principles are about the risk group and screening everyone in that group. Number two, the health problem has significant effect on quality or quantity of life. There does. There needs to be a consequence to this thing if we don't find it. Look at all the things we screen for. These are things that can cause death, stroke, heart attack, vascular damage, amputation, renal failure, etc. We don't screen for things, even if they're very common, we don't screen for things that aren't going to hurt you. Like, for instance, lipomas. Lipomas are like little fat accumulations. Uh, I mean, almost everybody over 50 has one, even if you don't know it. If you're over 50, somewhere you probably have a lipoma lurking. Um, it's like a rite of passage of age. Now, we don't see free lipoma screenings. You certainly don't want to try to bill for a lipoma screening because you won't get paid for it. You won't see a lipoma van running around, offering to do free lipoma screenings because even though they're very common, there's no consequence to it. All it is a little accumulation of fat. Also, the target disease has to have a long asymptomatic period. There has to be a reason to screen for it. We have to find it early enough to do something about it. And again, if you think about the things that we screen for, like diabetes, certain cancers, these are things that can go on for years and years, and you never even know they're there unless we actually screen for it. In addition to a long asymptomatic period, there needs to be a treatment. You'll never see a routine recommendation to screen for something that we don't have a treatment for. Doesn't mean that some individuals might not decide they want to be screened, but you won't see routine recommendations for something we don't have a treatment for. Like, for instance, Huntington's chorea. We know that if you have a parent with Huntington's, there's a 50% chance that you carry that gene. And we can test for the gene, but there's no treatment for Huntington's. So, like, there's no routine recommendation for the American Academy of Neurology. Oh, everybody with a parent with Huntington's should be screened for it because we can't do anything about it. Individual patients may decide that individually, for whatever reason, they want to be screened. They want to know, but there's no across the board screening. So these are secondary prevention principles. So when patients say, well, why should I be tested for this? Why do you think I should be screened for that? Because a professional study group has come together, evaluated the literature, and determined that in your age or your gender or your family history or whatever, this thing is so prevalent, the likelihood of having it is high enough that you should be screened. We can find it early, we can do something about it, we can improve your outcomes, and we have to have a population acceptable screening test. You have a test that has a reasonable sensitivity and specificity and is reasonably safe. All of those things come together, are analyzed by professional study groups, and that's how recommendations are developed. And sometimes the more people understand, the more that they are willing to do it. They get it if there's a real rationale for something rather than just, oh, some amorphous guideline said that you should. All right, test success tip. Well-recognized guidelines often have minor differences in recommendations, and that's true. When guidelines differ in recommendations, focus your study on the overlap, not the difference. And that's true too. And I know it's easy for me to say because I'm not the one that's getting ready to take my test. But honestly, your exam will not ask you to split the baby between subtle differences in two guidelines, I promise. It is much more often there's a preponderance of evidence to support something. And that's the recommendation. And the way the questions are worded, it's not like you have to split the difference between two guidelines. One answer will be guideline driven, and that's the one that you will want to pick. Like, for instance, the one shown on your handout. There's several different recommendations from organizations about PAP and HPV testing. Some groups say you don't have to start till the patient's 25. One group is even looking at pushing the age back to 30. The USPS task force still recommends beginning at the age of 21. So what we can recognize is that there is absolutely no group that recommends PAP or HPV testing under the age of 21. Like, that's the commonality. We can also agree that everybody recommends doing PAPs over the age of 25 at this point. So it's really the commonalities, not the differences that you want to keep you want to just be abreast of. All right, question 8. A 51-year-old woman of European ancestry who has had no primary care for more than 10 years presents to your practice. She has a 40-pack year smoke history, currently smokes 1 pack a day, and reports drinking 1 to 2 12-ounce beers per week. Her history is otherwise unremarkable, as is her physical exam. You order the following screening test: hemoglobin electrophoresis, mammogram, chest x-ray, or fasting serum triglycerides. All right, so you're going to say, oh, you haven't had anything in 10 years? It's time for your hemoglobin electrophoresis screening. And the answer to that one is no. The only thing here that she's a woman, she's over 50, no care in 10 years. That's all you need to know. She needs a mammogram. That's all you need to know. Hemoglobin electrophoresis actually is used to screen population at high risk for hemoglobinopathies, which are patients that have like at least one parent that has a hemoglobinopathy. And that's not discussed in this question at all. It's also unlikely. I mean, it could happen, but it's unlikely that somebody gets to the age of 50 and doesn't know it. So A isn't going to work. Some of you may have been distracted by the chest x-ray because she smokes, but chest x-ray is not used for screening. Chest x-ray does not have sensitivity and specificity sufficient for lung cancer screening. If you decided this patient needed lung cancer screening, it would be with low-dose CT scanning, not with a chest x-ray. And similarly, some of you might have been distracted by thinking, "Oh, doesn't she need to start having a lipid screening?" And the answer is actually yes, she does need a lipid screening, but that's not what this question said. This answer choice rather said fasting serum triglyceride, and there is no routine recommendation for a fasting serum triglyceride. So, it's one of those examples where if you think it's a trick or not fair, it's because you're just not reading it correctly and you're not answering the question that is asked of you. This lady, with the circumstances given, there's only one test here that she should have for screening, and that would be mammogram. If you want to peruse her risk for lung cancer, which you might, and we'll talk about a little bit more at the end of the chapter, but remember, we always have to find that place where the risk justifies the screening modality. And low dose CT is the only study that's been demonstrated to have enough sensitivity to find a cancer early enough to do anything about it. But CT, of course, also has a high radiation risk. So it's always the fine tuning, like where does the benefit outweigh the risk? And one of the things that we have to consider is the patient's pack years, their exposure to cigarette smoke. So we calculate pack years with the example shown on the handout, number of packs a day times number of years smoked. And the pack year calculation is part of what we're going to do in our lung cancer risk assessment when trying to decide if somebody should have a low dose CT or not. So you can see by the slide, a 2-pack a day smoker for 30 years has a 60-pack year burden. Half a pack a day for 10 years is a 5-pack year burden. Number of packs a day times number of years smoked. Now, another thing to consider, especially in this time of cultural competency and cultural sensitivity, has become a really important topic in healthcare education and healthcare provision to the patient in general. And so sometimes the patient's race or ethnicity does influence, like it changes when we should screen for something, because some certain racial and ethnic groups are at higher risk for conditions than others. So sometimes race and ethnicity matters, and sometimes it doesn't with respect to who should be screened when. So you want to consider it when you look at your test questions, but also don't overthink it. Don't assign a significance that's not there. So a 65-year-old man of indigenous ancestry presents for a quote physical. He feels well, denies tobacco or alcohol use, and has not seen a healthcare provider in more than 10 years. The patient states, "I'm a really healthy person. I wouldn't come in except my wife and daughter told me I should have a checkup." It usually is the women in the family who decide who's going for a checkup. Anyway, as part of today's visit, he should be screened for what? Pancreatic cancer, hemolytic anemia, hepatic sclerosis, or visual defect. Well, this is where you might be going, okay, I'm not sure. Well, he's indigenous, and we know that there's a higher risk of alcoholism, but he says, excuse me, he says he doesn't drink, but does he really not? And pancreas, and is it drink? And you can find yourself going off on this tangent when you're not sure. When the answer is there is no screening for pancreatic cancer, so scratch that. Hemolytic anemia, again, we don't screen for hemolytic anemia. We test for hemolysis when somebody demonstrates symptoms of hemolytic anemia. And then you might go, hepatic sclerosis. Wait, what's that? I don't know, but it's liver and alcohol. And is his indigenous ancestry mean he's an alcoholic? And people just go down these rabbit holes when they don't really know what they're thinking about. Whereas A, B, and C are just all distractors. Regardless of ethnicity, every wellness exam, every patient, every wellness exam should have a screening for a visual defect. Somebody his age is going to get plunked 20 feet from a Snellen chart and told to read the smallest line he can read. And when he can get down to a line where he only misses 2 or less, then that would be his vision. So yeah, in this case, ethnicity didn't matter. All right, suicide, true or false? True or false? Males represent nearly 80% of all completed suicides, true or false? And that's true. True statement. True or false? When compared with male suicide attempts, female attempts at suicide are 2 to 3 times more common. This also is true. Women attempt suicide more, men complete it much more. True or false? The highest rate of completed suicide is found in teenage males. False. Now, the highest rate of completed suicide is found in older men. More teenage boys commit suicide than teenage girls, but teenage males actually have the lowest suicide of all male age groups. Men 75 and over have the highest risk of suicide. True or false, inquiring about suicidal ideation could precipitate the act. And this also is false. Asking people whether or not they're suicidal is certainly not going to give them any ideas or precipitate the act. Like a lot of new clinicians, especially, are uncomfortable asking that question very directly, but you really have to. I promise you, it's not going to be like you say to the patient, "Are you suicidal today?" And the patient says, "Huh, I don't know. Well, now that you mention it, like I wasn't suicidal, but now that you mention it, things haven't been going too well. Like this is not going to happen." So you do want to ask very directly if the patient's suicidal. Many times they're not overtly actively suicidal, but it might prompt a discussion, that needs to be had about their mood and what's going on behind the surface there. All right, this just reinforces what I said a minute ago. You can see suicide rates by age group. So you can see that the male of the species is represented in blue and the female of the species is represented in, I don't know exactly what that color is, but it's something on the red color spectrum, I guess. And you'll notice that in every age group, males complete suicide more often than females, but that in the men 75 and over group is clearly the highest rate. Like I said, more teenage boys commit suicide than teenage girls, but teenage boys have the lowest group of all the boys, or lowest number of all the boys. All right, Miss Kane is a 25-year-old woman who presents with finger-shaped ecchymotic areas on her right shoulder that are incidental findings during a physical examination. She denies abuse or assault. The NP's most appropriate response is what? Are you going to say, "Your bruises look as if they were caused by someone grabbing you"? Or, "Was this an accident?" Or, "I noticed the bruises are in the shape of a hand." Or, "How did you fall?" Well, she's got a finger-shaped bruise on her shoulder. So somebody grabbed her shoulder hard enough to make a bruise. So you definitely need to have a conversation about this. But she said she was not abused or assaulted. So you can eliminate B and D because B and D both just allow this to get brushed under the rug and not discussed at all, and that's not a good idea. But you also have to consider that you just asked her if she was abused or assaulted and she said no. So if you say your bruises look as if they were caused by someone grabbing you, I mean, it could be perceived as you are suggesting she's not telling the truth, which, I mean, if she is telling the truth, that's insulting. And if she's not telling the truth, it's because she doesn't feel trusting enough yet to have this conversation with you. So pushing it that way is probably not a good idea. So what we're left with is, "I notice the bruises are in the shape of a hand." So you are still talking about the fact that somebody has caused a bruise, but you're not making any suggestions or assertions. It's just like, "Hey, look, wow, this is in the shape of a hand." I tell you, I swear this happened to me. I'm not making this up to make a point here. I had a patient, I was actually doing a well woman exam. I was getting ready to do a pap smear. And so she's, laying on the thing, she's laying back and her legs are in the stirrups and she got the drape over her. And when I pulled the drape back, on the inside of her thigh was like this perfect hand-shaped bruise. And I said, "Oh my gosh," like I was just shocked. I was surprised. I said, "Oh man, look at that. Like, how did that happen?" And she went on to tell me that she was a mountain biker and she had been out mountain biking with a friend and she fell. She went off the trail and sort of fell down the side of the hill and got stuck in this weird, I guess, this weird position. And her friend, in an effort to try to pull her out, grabbed her leg hard enough to make the bruise. So she said, she was not abused or assaulted, but there was definitely a conversation to be had there about accident prevention, since accidents are the leading cause of death in that age group. So just an example of how sometimes they really aren't abused or assaulted, but that still means doesn't mean that you don't want to talk about it. There's still a conversation to be had. The MP is evaluating a 75-year-old woman with major neurocognitive disorder at a geriatric center who is being cared for by her adult daughter. Mind you, major neurocognitive disorder is what we used to call dementia. Oh, and this is a poll question. I didn't mention this to you. I'm very excited. So this is a question now where actually on your screen, I believe that you can see the opportunity to answer it. So let's look at the question. The MP is evaluating a 75-year-old woman with major neurocognitive disorder at a geriatric center who is being cared for by her adult daughter. The MP notices finger-shaped bruises on both arms. The patient is unable to describe what happened, and the daughter states that she had to grab her mother when she was about to fall down some stairs. The patient is otherwise well nourished and appropriately groomed and dressed. The NP's most appropriate next step is to do what? Now, depending on how your computer is set up, you might have to scroll up a little bit to see the fourth answer choice, but all the answer choices are available to you here. So now you have to pick one. Would you say the most appropriate next step is to schedule a follow-up visit in 6 months? Arrange a consult with a geriatric specialist? Ask the daughter for contact information for additional family members? Or report the incident to the local Elder Protective Services agency? Which one of those do you think is correct? And I'm going to ask you to go ahead on your computer and select what you think is the appropriate answer. I wish we had Jeopardy music. So I can see so far only 34% of the group has participated. Oh, our numbers are going up a little bit here. See, we could play the Jeopardy music and the numbers would go up, up, up. Pick an answer choice. Keep going. We still have 35% outstanding. Oh, 25% outstanding. 19% outstanding. Awesome. So 81% so far have selected an answer. Here's a few more coming in. It's funny. Almost always there's somebody who's like totally not paying attention at all and doesn't know we're doing a practice question. So we rarely get 100% participation. But these last few are trickling in here. So do 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 do. All right, I'm gonna wait 10 more seconds for the last few people that haven't answered yet to answer. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. All right, we've got all the answers I think we're gonna get, and we do have just about 90% participation. So let's go ahead. Okay, oh, do I do share results? I'm gonna click share and we'll see. Interesting here. All right, I'm gonna click it. I hope the computer doesn't blow up. All right, so hopefully you can see the results here. So yeah, this is actually interesting. 26% of you went for choice A, 15% for choice B, 6% for choice C, and 53% for choice D. Awesome. Let's take a look at these answer choices here. Okay, I think I'm going to stop sharing that. I'm going to close this out, and let's just actually look at the answers. And you know, everybody remember what you picked. The best answer here, and I'll listen, full disclosure, I don't necessarily love it. In fact, none of these are the next thing that I would do, but sometimes that's the way it goes on boards. We have to pick the best answer of those provided. Best answer here is report the incident to the local Elder Protective Services agency. So just barely, did we get just over half of the group did select choice B, and everybody else went with something else, which I totally understand. There's not a bunch of great answer choices here, but let's look at it from a question analysis perspective. This is like exactly what you do when you're not sure of the answer. All right, you have a scenario. She got finger-shaped bruises on both arms. She clearly has major neurocognitive disorder. The patient doesn't know what happened. The daughter says she had to grab her because she was going to fall down the stairs. The patient looks otherwise very well taken care of, right? So, would you schedule a follow-up in 6 months? Well, ask yourself what's that going to offer you? What's that going to contribute to the circumstance here? Another visit in 6 months. So we're going to see if it never happens again. We're going to hope it doesn't happen again. We hope it's a one-time thing. What does a visit in 6 months get you? What does it add to this scenario? Arranging a consult with a geriatric specialist. Remember how we talked about not referring unless they can do something we can't, or it's a complex thing that they need to weigh in on, or that it's something complex they need to manage, or that we've exhausted every opportunity in primary care. Those are the reasons to refer, none of which are the case here. We don't need a specialist here. We've got a scenario where a patient with major neurocognitive disorder almost falls down some stairs and has a bruise. We can certainly follow up on this. We don't need to refer it yet. And asking the daughter for the contact info for additional family members, again, what are they going to tell you that the woman with whom the patient lives won't? You're not going to get a lot out of A, B, and C. D says report it to the local Elder Protective Services agency, which I get some of you don't like because this has a punitive connotation to it, but that's not what this is. Again, from an evidence-based perspective, Elder Protective Services is a protective agency. They're there. The counties have an Elder Protective Agency or some name similar to that to protect the older population. And if you think that an older adult may be in some danger, this is exactly what you should do. That doesn't mean that the daughter is abusing her or we think the daughter is doing anything wrong, but the lady almost fell to the extent that she had to be grabbed hard enough to bruise. So clearly there's a need here in the household. It really might just be for education. What would happen if you call Elder Protective Services, again, theoretically from an evidence-based perspective, is a representative would go out and do a home inspection and then would make recommendations if necessary to improve the safety of the older adult. They don't go there to take people out of the home. In fact, they don't really want to take them out of the home because they usually don't have any place good to put them. They will remove people from the home if the home is flat out unsafe, but that doesn't sound like what's going on here. Maybe here they need some protective equipment. Maybe mom's room is on the second floor, but now they're going to need to move it to the first floor so they can provide some help with that. Or maybe if that's not a possibility, they have to put a gate on the second floor where the lady can't go out until somebody opens it and she's supervised, like that kind of stuff. That's theoretically what Elder Protective Services is for. Now, maybe like some of you, I have had some less than optimal results in reporting to Elder Protective Services, so I tend to be very skittish about it. But if we look at this from an evidence-based perspective, that's why it's the best answer. So just for your general wealth of information for reporting, there's some links here. Now remember, reporting child abuse is absolutely required in all 50 states, even if we are suspecting neglect. Any potential child abuse or any suspicion, we should report it. The laws on reporting elder abuse are a little bit less global, and if you're managing an older population, you want to check the laws in the state in which you are working to see what's required of you. But in that circumstance, reporting, because it's safety, the concern is safety of the older adult, and that's why we would report the situation to Elder Protective Services and have them do a home evaluation. All right, Mr. Jacobs is a 65-year-old man with COPD and a 60-pack year history who is currently smoking 1.5 packs of cigarettes a day. He is reading a pamphlet in your office about smoking cessation. You ask him if he has any questions, and he states, I don't plan to quit smoking at my age. I'm too old to quit now. Why bother? The MP's most appropriate response is, well, since you have COPD, you should really quit. Or, your lungs will get more damage if you continue to smoke. Or, tell me what you mean by I'm too old to quit. Or, I can provide medication that will help you quit smoking. What are you going to say when this guy says, I'm too old to quit? Your appropriate response is, why do you think that? Like, where did you get that information? It was probably on some web page somewhere, some blog. This is your opportunity to provide accurate information. He's reading the pamphlet because he's waiting for you. Maybe he's interested or maybe he's just passing time. We don't know yet. But when you start the convo, if he says, I'm too old to quit, he's clearly got some misinformation there, and this is our opportunity to correct it. Table 213 in your handout is a table of the 5 A's. The 5 A's was originally designed just as a quick reminder of a methodology to help people with smoking cessation. Now it's pretty much been used for pretty much any substance use concern. But that's what it is the 5 A's for smoking cessation. Excuse me. And now we have a test success tip. And it says knowledge of greatest risk in different age groups helps to direct care, in particular by possibly avoiding untimely death. Avoiding untimely death is certainly a good goal, and it's important patient education phenomenon. What this really comes down to is truly in real day to day primary care practice, if we're lucky, we get a minute or two for patient education. Unless you work in like a very high end practice where patients are paying out of pocket and you can afford to schedule your appointments, every half hour or so, you get some real time for health promotion. But other than that, in our current insurance-driven model, for a sick visit, you barely get enough time to see the patient and write your note. In a wellness visit, you get a little bit more time. But whatever the case, we really have to prioritize our time for patient education. So, yes, preventing death is good, and knowing what they're at greatest risk for can really help guide how we use those 1 or 2 minutes for patient education. So, for instance, look at the leading causes of death shown on this table. Notice that from the ages of 10 to 44, the leading cause of death is unintentional injury. Not many people die annually, thankfully, but it is the leading cause of death in the young age group. So, in that age group, your primary educational strategies are things like accident prevention. Whatever that patient are at risk for based on their age group or their habits. Let's take a minute or two to make sure you're being safe. Now, notice at the age of 45, things change a little bit. At the age of 45, now we're starting to become more aware of our age and afraid to do all those fun things that can lead to accidents. So, the causes of death change a little bit. In the 45 to 54 age group, the leading cause of death, most recently published by the CDC, is COVID 19. 36,881 deaths, number one cause of death in the 45 to 54 age group. Um, num- when you look at 55 to 64, malignant neoplasm hugely steps up. Death in general tends to increase over the age of 55. Notice that the number goes from 36,881 in the 45 to 54 age group to 1,108,023 in the next higher age group. And cancer just rears its head. It's like over the age of 55, somebody flips a switch and cancer just jumps to the top. Very often, when patients develop cancer, that's the age group at which they will be diagnosed. So now, if you only have a minute or two for patient education, info and encouragement for cancer screening becomes exceedingly important. And then over 65 and all ages combined, because in the United States, most people die over the age of 65. So over 65 and all ages averages the same thing. Heart disease is the number one cause of death. So now, if you only have a minute or two for patient education, heart health, controlling blood pressure, lipid screening, all of those things become enormously important. Of course, cancer is right behind it as a very strong number two cause of death. So we still want to encourage those cancer screenings. But the real takeaway is just prioritizing patient education based upon risk. Now, when you look at cancer, the next two figures on the next page are about cancer stats. The top figure is about cancer cases or cancer morbidity. We're talking about in 2024, the estimates for cases of cancer. And you'll notice that the number one cause of cancer is what we think of as the gender cancers: prostate cancer in men, breast cancer in women. Number two in both genders is lung and bronchogenic, and then number three is colorectal. So in the United States this year, the most cancer cases that will be diagnosed are prostate and breast, right? The number two will be lung and bronchogenic, and actually, lung and bronchogenic cancers are less than half as common. We're looking for for prostate and breast cancers on average about 300,000 cases a year. For lung and bronchogenic, it's less than half of that, about what, 100 and maybe 120,000, give or take a few. But when you look at cancer deaths, when you look at estimated cancer deaths, notice how the numbers 1 and 2 position flip, so that something like 60 to 65,000 patients will die, men and women each, 60 to 65 of lung and bronchogenic cancer. Half of all diagnosed cases of lung cancer will die of lung cancer. Whereas when you look at prostate and breast, the number of deaths drop way, way down from those diagnosed. If 300,000 men are diagnosed with prostate cancer, only 10% or just over 10% will die of it. Same the women with breast cancer, 300,000 will be diagnosed, but 42,000 die of breast cancer. So that suggests we're doing a much better a much better job of screening for breast and prostate cancer than we are for lung cancer. We have to do a better job of screening for lung cancer. And then again, remember, when guidelines have conflicting info, focus your study on the common themes, not the differences. You really do want to know those commonalities about who should be screened for what. So, question 14. According to current nationally recognized recommendations, are the following cancer screenings indicated, yes or no? Yes or no? Annual digital rectal exam as colorectal screening in a 63-year-old man? No. Annual digital rectal exam has never recommended for colorectal screening. Now, there was a time when we did it for prostate screening, but for colorectal screening, unless you have a 20-foot finger with a camera on the end of it, it's not going to tell you very much. How about an initial pap test with HPV co-testing in a 19-year-old woman 1 year post-coitarchy? And that would be a hard no. Doesn't matter how many ARCIs she's had. If she's under 21, she doesn't need a pap with HPV co-testing. Remember, in that population, almost always it's self-limiting and self-resolving, and we don't test for things that we're not going to treat. How about pelvic ultrasound with endometrial biopsy in a 52-year-old woman who is 2 years post last menstrual period and denies vaginal bleeding? Yes or no? Again, a hard no. We don't say, oh, it's been 2 years since your last period? Oh, let's just do your screening, biopsy, and ultrasound. We don't do screenings of those things for people that are in a normal menopausal trajectory. How about annual prostate-specific antigen testing in an 81-year-old man who has hypertension and BPH? And again, this is a no. You might be thinking, do we do PSA testing? Does the hypertension and the hypertrophy matter? And the answer that really matters here is that over the age of 80, all routine recommendations for cancer screening cease, because one of the basic rules of cancer screening is that we don't screen for a cancer when the life expectancy of the cancer is longer than the life expectancy of the patient. And prostate cancer without treatment has an average survival of 10 years. An 81-year-old has an average life expectancy of 6 years. So there's no recommendation for routine testing. Now, again, are there people who choose to be screened? Sure, but it's a very individual topic. How about lung cancer screening with low-dose CT for a 60-year-old who is generally in good health and has a 35-pack year smoke history and quit 5 years ago? And that would be a yes. I am going to point out the lung cancer screening guidelines to you as we close out this chapter. Excuse me. So we'll talk more about that in just a second. But finally, a 30-year-old woman of Asian ancestry presents for routine health visit and requests BRCA gene mutation testing. And this also is a no. A 30-year-old Asian woman doesn't need BRCA gene mutation testing just on the face of her ancestry or her ethnicity. If someone comes in and says they want BRCA gene mutation testing, the appropriate answer is a much less expensive, less invasive screening tool. There are several screening questionnaires that are approved. One of them is the FHS 7 or Family Health Screening 7, where you ask questions and the answers have a point value assigned. And if the patient score is high enough, then we know that the risk of BRCA gene mutation is high enough to warrant this very expensive testing. But we just don't offer it to somebody because they come in and ask for it. Again, least expensive, least invasive way to know that the thing that you need to know. And so that's it for the chapter. But I do want to point out, because I promised, you have a couple tables at the end, and one of them is table 217. It begins on the next page, page 37 of your handout. And this is like a comparison, really, of the American Cancer Society and USPS Task Force Cancer Detection Guidelines. And you can see colon cancer, the top of the next page, endometrial, and then you see lung, the bottom of page 38. With lung, it's always a challenge because, like I said, even low dose CT is highly irradiating, and we don't want to do it unless we really think it's going to be useful. Chest x-rays are just not adequate for screening. Nothing shows up until it's really too late to do much about it. So the CT is the test, and it is indicated in pretty precise groups of people. USPS Task Force and American Cancer Society, they might differ just a little, but basically they're the same. It's recommended for people age 50 to 80 who have a 20-pack year smoking history or more and quit at least like no more than 15 years ago. Either they still smoke or they quit less than 15 years ago and are in fair health. They have a reasonable expectation of fair health following treatment. So that's all I have about that. There's more stuff here you can read about. Oh, God, on the next page, breast cancer guidelines, and then you've got cervical screening guidelines, some resources. But I think we've reviewed everything that we really wanted to review in this chapter of Live. That takes us finally to body systems and actual like diseases and conditions and stuff like that. So we're going to go ahead here to page 49 in your handout. While you're going to page 49, I'm going to get a quick drink of water. Well, it might not have seemed that quick, but talking is thirsty work. So, how to have a drink of water. All right, now let's talk about assessment and intervention in select hematologic disorders. And it begins with a diagram. And again, I've never seen this diagram on your boards, so please don't worry about trying to memorize it. Just trying to like frame the conversation here. So, we're talking about anemia. And anemia is a condition basically that is characterized by insufficient circulating hemoglobin. That's how we first make the diagnosis. We do a complete blood count and we see that the patient's hemoglobin is below a certain established reference range. And that reference range, it varies a bit from lab to lab. I use World Health Organization values just because they're easy and clean, and I use it to illustrate the conversation. According to the World Health Organization, a woman's hemoglobin should be above 12 and a man's should be above 13.5. And if you're lower than that, you're anemic. Now, yeah, like I said, some labs have different values and it varies a little bit based on age of the patient. But just for the sake of conversation, we're going to use 12 for women and 13.5 for men. If your exam wants you to know that a patient is anemic, the hemoglobin will either be low enough that it's without question, or the question will actually say the patient is anemic. You're reviewing Mrs. Jones' CBC and you note that she is anemic. So if anemia is not enough mature circulating hemoglobin, then the next thing you're going to ask yourself is why? How? What? Why? How? What did this happen? How did the patient develop this circumstance where they don't have enough circulating mature hemoglobin? And that's where it's helpful to take just a quick review of where hemoglobin comes from. Remember, in the beginning, we have bone marrow, and bone marrow produces stem cells, aka progenitor cells, undifferentiated cells, and they're also known as hemocytoblasts. These are cells that can differentiate into any type of blood cell. Some will differentiate and ultimately become platelets. Others will differentiate into white cell precursors and ultimately become white blood cells. And some will differentiate into red cell precursors and become red blood cells. This is where we're interested today because we're talking about anemia, which is a condition characterized by not enough mature circulating hemoglobin. And circulating hemoglobin is carried around in mature red blood cells. And in fact, hemoglobin is pretty much the only thing in a red blood cell. Remember, a mature red blood cell, it doesn't have a nucleus, it doesn't have much in the way of functional organelles. There's just not a lot there except hemoglobin. So red blood cells are basically like bags of hemoglobin. If a patient doesn't have enough mature circulating hemoglobin, they either have a problem with hemoglobin synthesis or with red blood cell synthesis because they are two separate procedures. I mean, obviously they work together, but in terms of maturation, the first thing that happens is the patient's hemocytoblast will differentiate into red cell precursors, also known as erythroblast. And this all happens within a matter of days. The maturation cycle here is just a matter of days. So the proerythroblast is an immature red blood cell. You can see it has a nucleus, and then it will continue to mature. It goes through a couple of different maturation stages. But as long as a nucleus is there, this cell is capable of division. And that's important because an adult has typically between 4 and 5 million circulating red blood cells. And to get to 4 or 5 million in a matter of days, these things have to divide really, really fast, which they do. Red blood cells in their immature form, when they still have a nucleus, will divide, divide, divide. And they just divide, divide, divide until they no longer have a nucleus. At some point in the maturation stage, and it doesn't show it here, which is unfortunate. I don't know why it's not labeled, but at some point in the maturation stage, just before full maturation, red blood cells will eject their nucleus and then hemoglobin synthesis starts. And without a nucleus, the cells can't divide anymore. So once hemoglobin synthesis starts, hemoglobin synthesis is protein synthesis. You're building a protein, and protein synthesis goes through various steps. First, you have to make heme, then you make globin, then the heme and the globin are assembled. Then you've got mature hemoglobin. Then you've got a grown-up red cell with mature hemoglobin in it, and that goes out into circulation and carries oxygen around. So if you're anemic, you either have a problem with red blood cell division or you have a problem with hemoglobin synthesis. Those are the primary causes of anemia, and we have to figure it out because once we know the patient's anemic, we want to know how to treat it, and we can't know how to treat it until we know why they're anemic. So it's helpful to understand these steps. Divide, divide, divide until there's no more nucleus. Then there's massive hemoglobin synthesis, and then you've got a mature cell running around the body, oxygenating stuff. So yes, the first step in determining and the first step in treatment involves determining the anemia's etiology. This is accomplished with careful assessment of clinical presentation, risk factors, and data. In other words, the diagnostic process. I mean, this is what we do with every disease with which we are faced. We have to think about the whys, the hows, and the whats. So table 3.1 is the first table that starts to break down the different causes of anemia. And you see a definition here that says a complex condition characterized decrease in red blood cells, hemoglobin, etc., which is pretty much what I just talked about with you. And it's true that it is a complex condition because there's a lot to consider in terms of symptom presentation. Anemia, again, by definition, is not enough circulating hemoglobin. And hemoglobin is the oxygen carrying protein of blood. So if you don't have enough hemoglobin, you can't carry oxygen efficiently and you can't oxygenate tissues efficiently, which means there is the potential for easy fatigability, dyspnea with exertion, all those things that we've already mentioned in another setting. Remember, we were talking about when you have mitral regurg and you don't get enough blood out in circulation, you get hypoxic, tissue hypoxia. Same thing here. So anybody who's anemic is at risk for activity intolerance, easy fatigability, dyspnea with exertion. But then there's several different things that can cause anemia, and each type of anemia has some symptoms of its own that are unique to that anemia and not shared by the others. So it is an important symptom assessment as well as a laboratory assessment that's really going to help us figure out that underlying cause. Anemia is definitely not a one-size-fits-all phenomenon here. So the number one most common cause of anemia of adults in the United States is chronic low volume blood loss. Chronic low volume being the key phrase here. The patient is losing blood slowly and steadily and insidiously and doesn't even know it. GI loss is the number one most common, and menorrhagia, heavy periods, that's the second most common. And what happens here is that, remember, everything in the body is dynamic, right? Everything in the body is either serving a purpose or being recycled for repurposing. Things don't just stand still or stop working. So when we make red blood cells and then we make hemoglobin and they go out in the world, and for 3 or 4 months they work carrying oxygen around, but then they age out. They time out, they become senior citizen red blood cells. And so then we have to recycle them. So they are cycled back to the liver They're broken down, their component parts are extracted and used again. And one of the component parts that's extracted is iron. And the iron is used by new red blood cells in the synthesis of new hemoglobin. So, if you need recycled old red blood cells to get iron to make new hemoglobin, but you have this slow, steady, insidious blood loss going on, you're losing one of your most important sources of iron for new hemoglobin and not even knowing it. And so, somebody who has gastritis or a leaking ulcer or even a GI malignancy or a woman with like fibroids and very heavy periods, they're losing blood regularly, but really not realizing it or not realizing it's a problem. So they just keep losing it. So they have less and less iron with which to make new hemoglobin. And that's what perpetuates their anemia. And this is the most common cause of anemia, excuse me, of adults in the United States. Then we have reduced red blood cell production. So this has nothing to do with iron. I know under mechanism of etiology, you see the word iron there. Just ignore it. That really shouldn't be there. The thing that matters with reduced red blood cell production is B12 deficiency and folic acid deficiency. Now you can't make enough red blood cells. Now I'm actually going to turn on my video here for a very high-tech video representation of what's going on. So I'm sure you will find it stunningly useful. Remember I said the undifferentiated stem cell becomes a red blood cell precursor, and then as long as it has a nucleus, it makes more red blood cells. And the way that happens is that when a cell is going to divide and become two, double its count, the nucleus, which remember contains the DNA is that double-stranded Watson-Crick double helix that contains the DNA or the master code of the cell. And when a cell wants to divide, that helix has to unwind and then separate, and then you make a new matching strand. Now remember, these strands are composed of base pairs, A, T, G, and C. So when the red blood cell's like, all right, it's time to reproduce, there will be enzymatic signaling that causes unwinding and then separation of the two strands of the DNA. And then a new matching strand will be made for each existing strand. And then you have two sets of DNA and they separate and become two cells. And then when they need more division, these unwind, they separate, they reproduce, and then you have four cells, but I can't make my fingers do that. And it just keeps going on and on and on. Well, in order to make those new matching strands, you need B12 and folate. B12 and folate are essential micronutrients in the production of bases that will form the new matching strands. If you don't have enough B12, you don't have enough folate, you don't make bases. And if you don't make bases, you don't make matching strands. If you don't make matching strands, you don't get new cells, you see, and you don't have red blood cell production. So some people's anemia has nothing to do with iron and bleeding. It has to do with not having enough B12 or folate to make those new strands. That was my high-tech video representation. And that is the next most common cause of anemia in primary care. Now, sometimes patients do make perfect red blood cells and perfect hemoglobin, and that perfection matures and goes out into the world, and then it gets destroyed by circumstances outside hematopoiesis. Some people have other diseases, other enzyme problems that causes destruction of these mature, healthy cells. And that's hemolysis, and it does happen, but it's not nearly as common. And then finally, we do have an acute blood loss phenomenon, which is not the same as chronic blood loss. With acute blood loss, the patient is obviously losing blood very acutely. They make it just fine. They make good red blood cells, they make good hemoglobin, and then they suddenly lose it all. They maybe have a traumatic accident and the blood's all over the floor. Maybe they have, I don't know, a perforated ulcer and they have bleeding all in their abdomen. The blood just very quickly is lost from circulation and accumulates somewhere it doesn't belong. And in this circumstance, like this is acute. So if somebody loses enough blood to be acutely anemic, everybody knows they're bleeding. Like they're tachycardic, they're hypotensive, they're pale. And, there's often blood all over the floor or something like that. So this usually isn't a shocker. This isn't like where you're going, look at that blood count. I wonder why the patient's anemic. This is more a matter of, Oh, crapo, there's acute blood loss here. In addition to all the other problems here, we're going to have tissue hypoxia because of reduced circulating hemoglobin. So those are the most common causes. And then, of course, we have to do a good history, a good physical, and a laboratory assessment to figure out why this is happening. That's what table 3.2 is all about. This is about the hemogram assessment because the first thing we're going to do is look at the complete blood count and the hemogram values. So obviously, first, we look at the H&H. This is how we determine the patient's even anemic. I mean, if your hemoglobin is low, you're anemic. If your hemoglobin is low, your hematocrit will also be low. Hemoglobin is the protein hemoglobin. And that's really precisely what we're measuring. Hematocrit speaks to all of the solutes in the blood, most of which is hemoglobin, but there are lots of other things. And so they exist in a ratio. If the patient's hemoglobin is 10, the hematocrit is approximately 30%. If the hemoglobin is 12, the hematocrit is approximately 36%. This exists in a ratio of like 1 to 3. And this is helpful because some practices will have in the office hematocrit spinners where you can just take a finger stick drop of the patient's blood, or a couple drops actually, and get a hematocrit right there in the office. And then you can make a judgment about what the hemoglobin is, and you can make a judgment call about anemia. But they do exist in a ratio, and that's how we tell if somebody's anemic or not. Then we say, oh, you're anemic, I wonder why. Well, the first step in figuring out why, after your history and physical exam, is to look at the red blood cell size. Red blood cell sizes are reported as the MCV, or the mean corpuscular volume, aka the mean cell volume. And the thing is, once a red blood cell is formed, its size doesn't change. Its size remains the same for its entire lifespan till it's recycled again. So we look to see the sizes of the cell because that will give us some indication about what's going on here. This is known as Weintraub's classification. So if the red blood cells are very small or microcytic, normal red blood cell size is between 80 and 96 femtoliters. If the red blood cells are less than 80 femtoliters, the cells are very small. This implies a hemoglobin problem. Right, because most of the cell is made up of hemoglobin. So if the cell is almost entirely hemoglobin and the cell's small, it makes sense it's a hemoglobin problem. On the other hand, if the cell is normal sized, normocytic between 80 and 96 femtoliters, then the problem is likely outside the hematopoietic system because the cell appears to be normal. You know, the size is normal. There's a normal hemoglobin production. So whatever's going wrong, it doesn't appear to be in the cell. Macrocytic anemias are when the cells are too large, and so macrocytic anemias are said to occur when the patient's MCV is greater than 96 femtoliters. What's going on here is the body is trying to compensate. Remember, the body will always compensate for deficiencies whenever it can, because a primary underlying goal of the human body is homeostasis. The body likes steady state. It likes things to be just the way they're supposed to be, like visualize a seesaw parallel to the floor. It'll tip a little bit in either direction, but always come back to midline. So if anything goes out of whack, when the body can, it will initiate a recovery mechanism. And in the case of a macrocytic anemia, what's happening is that there's a problem with red blood cell production, usually a B12 or folic acid deficiency. The patient can't make enough red blood cells. And if they can't make enough red blood cells, they don't have enough cells to carry hemoglobin around the body. And the body's like, oh no, we need hemoglobin. We need at least 80 femtoliters of hemoglobin. What are you going to do? And the only thing you can do is put more hemoglobin into each cell you have, and they will get very big. And if they get too big, they'll break, and then they're useless. Then their hemoglobin doesn't count. So you have some big cells, but not enough of them to carry hemoglobin around. So you still don't have enough mature circulating hemoglobin. So the patient's anemic. The analogy I always use, and I always mess it up, but I'll try not to. Imagine you have 100 apples on your kitchen table and you need to take them to the food bank because that's your contribution. So you want to get these 100 apples out. You do it every week. And normally you have 10 bags to carry them in. So if you have 10 bags and 100 apples, you put 10 apples in each bag, you comfortably carry them all out into out into the car and to get them to the food bank. Perfect. But what if today you only have 5 bags? If you only have 5 bags, but you're like, I still want to get 100 apples to the food bank, what are you going to do? You're going to put 20 in each bag. These bags will get very full and bloated, and they're bigger than they're supposed to be. And invariably, especially if they're those cheap plastic bags from the grocery aisle, some of them will break. And on the way to the car, the apples will fall out. So the ones that don't break will get to the car intact. They're oversized and over distended, but the ones that broke didn't make it. So in the end, what you've got is a lower number of cells, but the cells you have are very full and distended, but it's just not enough to get all the apples out there. So the patient will still be anemic. See where I'm going with that? Very creative, right? The bags are the red blood cell, the apples are the hemoglobin. If you don't have enough bags, you're just going to put more apples in each bag, which makes big bags, big cells. And then if they get too big, they're going to break and they won't carry any hemoglobin anywheres anyways. So that's what we use Weintraub's classification for, and it is the next thing you look at after the MCV. Now, the mean cell hemoglobin and mean cell hemoglobin concentration, honestly, I wouldn't even mention if they weren't in the handout, but they are, so I have to. So mean cell hemoglobin content and mean cell hemoglobin concentration really correlate very closely with the mean cell volume because most of the volume is hemoglobin. Hemoglobin is also what gives red blood cells their red color. So we refer to this as chromia. Mean cell hemoglobin or mean cell hemoglobin concentration, they suggest the concentration of hemoglobin that confers color on the cell. So if the cell's hemoglobin MCH or MCHC is low, the patient's cells will be pale. And their hemoglobin is low when their cell volume is low. So in other words, a low MCV means a low MCH, which means not only small cells, but pale cells because they don't have enough of their hemoglobin to confer color. Small red blood cells are always pale red blood cells. So there's a pictorial representation. So red blood cell size, the MCV is the important one. That's the most important thing after we deduce they're anemic. MCH and MCHC, not so much. I mean, I'm sure hematology would find it useful, but for us in entry-level primary care, first look at the H&H, then look at the MCV. Next thing that's useful is the red cell distribution width. The red cell distribution width, or RDW, is really an index of variability of cell size, which I know probably clears it right up. But the bottom line is you could substitute the word variability for RDW. What is the variability? This is a calculated value, and what we're looking at here is that, remember, you're making between 4 and 5 million red blood cells in a matter of days. This is like huge red blood cell generation. When you make 4 or 5 million of anything, the same way over a period of days, they're not all going to be perfectly identical. There's going to be some variability. That's to be expected. Like if you hit print for 4 million things on your printer, it probably looked very close, but there would be some variability in what it looked like when it came out. Some will be darker, some will be lighter, some might have like just a little tiny black speck somewhere. You know, some might just be a little tiny bit off center if you do 4 million of them. So there'd be a little bit of variability. Same thing with all these red blood cells. There will be some variability in their size. A normal variability is between 11.5% and 15%. In other words, if the average red cell size is 100, and it's not, but I'm just using it for a round number, if the average red cell size was 100, you could reasonably expect the smallest one to be 15% smaller, or 85, and you could expect the largest one to reasonably be 15% larger, or 115. So if you look at a peripheral smear and you see some cells that are 85 femtoliters and some are 115 and everybody else is in between, that's a 15% variability, and that's considered a normal variability. That suggests that your red blood cells are basically all being made with the same physiologic mechanism. But if the variability is higher than 15%, then that means you've got more extremes of the small and the high. That implies that something is changing in the way red blood cells are produced, and it just helps you figure out the cause of your anemia. Is your anemia a stable, unchanging circumstance, or is it an evolving, changing physiologic circumstance? That's what the RDW tells you. So, for instance, suppose 4 months ago everything was perfect, red cells, hemoglobin perfect, and then the patient develops a GI bleed, maybe a bleeding ulcer, they don't know it, gastritis, whatever, God forbid GI cancer, but they start to leak out red blood cells. So they have slightly less hemoglobin to make new protein. So cells start to just get a tiniest bit smaller. And nobody knows what's going on, so it keeps happening. Cells get smaller and smaller until today, 4 months later, this cell is appreciably smaller than this one. The variability is increased. As the cell got smaller with blood loss, the variability, the distance or the range between the smallest and the largest increased. Maybe the RDW is 20%. By the same token, maybe 4 months ago everything was perfect, no prob, and then the patient starts to develop a B12 absorption problem. Can't make enough bases to make new DNA. So can't make as many new cells as they're used to. So each red cell is starting to get jammed with more and more hemoglobin until finally, 4 months later, this cell is appreciably larger than this one. So as the cells get smaller, the variability will increase. And as the cells get bigger, the variability will increase. Variability only increases. You just don't see a circumstance where the red blood cells get like closer and closer to identical. That just doesn't happen. A variability greater than 15% implies that there is a changing physiologic process going on. And anemia without variability implies that whatever is making the patient anemic is stable and unchanging. And then the last thing that we can look at from the red cell differential is the reticulocyte percentage. Reticulocytes are immature red blood cells. In fact, they're that stage when the nucleus has been ejected, but the hemoglobin hasn't been made yet. That's the reticulocyte. And the reticulocyte will sprout iron receptors and pull iron in to start the process of making hemoglobin. Well, reticulocytes, being immature, they really shouldn't be out in circulation, but being adolescents, 1 or 2% of them will always sneak out. It is interesting how the life cycle just replicates itself, whether we're talking about the cellular level or the humanistic level. But just like with human young people, a very small few will always find a way to sneak out with a fake ID and get into the local bar. 1 to 2% of reticulocytes will sneak out into the adult world and try to act like a mature red blood cell, even though they're really not. So if you have a patient who is anemic and their reticulocytes are increased, well, the body's trying to compensate again, but what it tells you is it's still capable of making red blood cells. And that helps you start to rule out causes of anemia. If you're still capable of making red blood cells, that narrows things down a bit. By the same token, if the patient's anemic and there's no reticulocytes in circulation, you would expect there'd be some, right? If there's none, that suggests that there is a problem with red blood cell synthesis. So like the MCH and the MCHC, this is less precise, but it's here, so we talked about it. But from our perspective in the world and your boards, when you look at a hemoglobin question or anemia question, look at the H&H, the H&H, the MCV, and the RDW. And those are the things that's going to tell you what you need to know. All right, test success tip. With all anemias, next step testing is directed by hemogram results and proposed anemia mechanism. Yes. All right, I know you're starting to fantasize about food here. We're getting close, not quite. In fact, I'll tell you so you can just be aware and not worry about the end when we're going to stop. Sometimes being preoccupied about the end keeps you from paying attention. So I will tell you, we're going to cover table 3.3. And we're going to cover through the end of page 56. So we're very close. And then after 56, we'll take a rest, we'll take a lunch break, and then we'll come back and pick up with questions. All right, so first though, we got to figure out why somebody's anemic. First line intervention involves treating the underlying cause, of course, while we try to restore the red blood cell count. So table 3.3, identifying anemias. All right, remember we said the first thing we're going to look at after the H&H is the MCV. Is it normal, high, or low? If the MCV is normal, You have a normocytic anemia. Red blood cells and hemoglobin are being made just fine. The problem is outside the hematopoietic system. The most common cause of normocytic anemias are listed here, and this is what it looks like. Hemoglobin's low, patient's anemic. If the hemoglobin's low, look at the MCV. If the MCV is normal, it's a normocytic anemia. It is very likely either anemia of chronic disease, chronic kidney disease, or acute blood loss. So now we just need to figure out which one. It's not in the hematopoietic system. If that MCV and MCH, et cetera, RDW are all normal, then you know you've got a problem outside the hematopoietic system, which is usually anemia of chronic disease or acute blood loss. Now, you might have renal disease, chronic kidney disease, because remember, erythropoietin, which is the hormone that makes hemocytoblast differentiate to red blood cell precursors, 90% of your erythropoietin is produced in the kidney. So if you have advanced renal disease, that could lead to a problem stimulating red blood cell production as well. But for the most part, on your boards, if you see a normocytic anemia, it's going to be anemia of chronic disease or acute blood loss. How do you tell the difference? Well, it's pretty straightforward. Acute blood loss, the patient is acutely symptomatic. Anemia of chronic disease, either they have no idea what's wrong and they don't know they have a chronic disease, or they do and you can tell them about it. But here's what the blood count could look like. Hemoglobin is low, patient's anemic. MCV is normal, normocytic. Once you see that this is normal, you don't even have to look at the RDW. If MCV is normal, RDW will be normal. You've got a normocytic anemia. So we know it's likely anemia of chronic disease or acute blood loss. Look at the patient. It could be a 72-year-old man with an acute GI bleed, the stream of crimson coming out of his rectum, who would likely be hypotensive and tachycardic and symptomatic, or a 32-year-old woman with newly diagnosed lupus. But either way, the blood count will look the same. Now, microcytic anemias, we have two types of those as well. And, well, we have two types. On your slide here, it says iron deficiency and plumbism. And plumbism, I'm actually not counting as a type. So what's the deal with that? Well, microcytic anemias, remember, these are hemoglobin problems. These are patients with an MCV of less than 80. So there's not enough hemoglobin being produced. These cells tend to be very small and very pale. And in the setting of iron deficiency and plumbism or lead toxicity, the RDW will be elevated because new cells are being made with less iron than old. So the cells will be pale, like you see here. This is a sepia tone picture, so it's a little bit misleading. But most these red blood cells that you see here have very pale centers. Over here, the red blood cells don't. And the variability in terms of size, like some of these are way smaller. Look at this one and this one. This one is about half the size of the one just below it. So they're microcytic and hypochromic, small and pale. And the elevated RDW, I already mentioned the differences in size. Some of these are like appreciably different. Here's another one where one cell is much smaller than the other. Small, large. Yeah, I mean, there's examples all over the place. So the first microcytic anemias we're talking about are iron deficiency. Now, the reason plumbism is there is that plumbism is a condition where lead substitutes for iron in the heme process. And so you see plumbism when people are exposed to lead. The classic story is like little kids that run around old houses eating lead-based paint, although that's all but been eliminated these days. People that work with lead-based paint, people that work in the automotive industry, and do, body work and do painting, they can be exposed to lead. There are people that work in lead mines. If your exam has a question with a patient with plumbism, I guarantee you there will be lead somewhere in that question. We just don't really see that very often because we don't see the condition that often. In pediatrics, it's very common to screen them early, and in adults, it's just most unusual for it to actually become symptomatic. I mean, even in the body painting industry, OSHA is very strict about masks and protection. So you don't see plumbism as often, but you could, and it's because the lead substitutes for hemoglobin. So how are we going to figure this out? Well, if you see a patient whose hemoglobin is low and their MCV is low, You have a microcytic anemia. You're thinking, oh, is it iron deficiency? Is it plumbism? Let me look at the variability. If the variability is high, if new cells are being made with less hemoglobin than old cells, then the variability will be increased. Low, low, high. Your next step is to test for ferritin. Ferritin is an iron binding protein and is very sensitive to falls in iron levels. So if you see a low hemoglobin, a low MCV, and an elevated RDW, iron deficiency should be the first thing on your list here, your mental list. Check for ferritin. Low ferritin confirms your diagnosis. And it could look like this. Hemoglobin is low, patient's anemic. MCV is low, patient's microcytic. RDW a little elevated, evolving problem. Yes, it could be a man with gastritis or ulcer disease or even cancer, or it could be a woman with heavy periods or that 3-year-old that's running around eating paint chips. That's iron deficiency, and that's the most common cause of anemia in the world, actually. It's the most common cause in almost every subpopulation. Now, we have another microcytic anemia. This is the quote other one I was talking about when I said 2 types. I see iron deficiency as lead as one type. The other microcytic anemia is thalassemia. Thalassemia has nothing to do with iron, has nothing to do with lead, has nothing to do with bleeding or heavy periods. This is all about a DNA mutation in the DNA code for globin synthesis. Remember, first, a reticulocyte endocytoses iron and makes heme. And then once the heme is formed, it will synthesize globin. And then the heme and the globin will combine in the Golgi apparatus to make hemoglobin. With thalassemia, you got a globin problem. In iron deficiency, you have a heme problem. In thalassemia, you have a globin problem. And there are many types of thalassemia. There's minor forms and major forms. There's alpha and beta because the protein is actually a very complex protein. There's alpha chains and beta chains. The difference here is that if a patient has thalassemia, yes, it's still a hemoglobin problem. So the hemoglobin is low, the patient's anemic. The MCV is low because there's a hemoglobin problem. But in thalassemia, the RDW is normal, meaning new cells are being made exactly the same way as the old cells. This is not an evolving or changing problem because it's a DNA mutation. People that have thalassemia are born with it. It's in the gene pool. They're born with it, they have it all their lives, and they die with it. So you won't see an elevated RDW. And it's one of the important distinctions early on in your assessment. Now, if you see, and there are certain racial and ethnic groups that increase risk also, and they're shown in your handout. If you see a patient whose hemoglobin is low, MCV is low, and RDW is normal, especially if they belong to one of those at-risk ethnic groups, what you need to do is a hemoglobin electrophoresis to pherese out the different types of hemoglobin. With thalassemia, we have elevations of abnormal hemoglobin. Like most of us have, of all of our hemoglobin, 99% of it is hemoglobin A1. But in thalassemia, you might have an elevation of hemoglobin A2 or hemoglobin H or hemoglobin F or any sort of abnormal hemoglobin there that just doesn't carry oxygen as efficiently and makes for very small cells. So hemoglobin low, MCV low, RDW normal, particularly if you belong to a racial or ethnic at-risk group, the patient needs hemoglobin electrophoresis to look for hemoglobin variants. And here's what it could look like. And I know some of you ICU nurses are going, what's wrong with that hemoglobin? The patient's hemoglobin is 11.6, but he's a 27-year-old man of African ancestry. No 27-year-old man needs to have a hemoglobin of 11.6. He's not menstruating. His hemoglobin, this reference range says 14. He's a couple grams down. So his hemoglobin is low, he's anemic. The MCV is quite low. These are very small cells, which is consistent with thalassemia. But the RDW is normal. The variability is normal. All the cells are being made the same way. They're just very, very small. That's consistent with thalassemia. And the only treatment here is just to transfuse PRN. And then finally, in the last row, we have the macrocytic anemias. Now, macrocytic anemias almost always are a consequence of B12 deficiency and folic acid deficiency. On a side note, there are people that are macrocytic due to some other major physiologic insult that's not just about anemia. But if that's the case, the underlying problem is usually very dominant. So, like if you have somebody who's macrocytic and in stage 4 chronic kidney disease, it may be due to renal failure. Or if they are macrocytic and have, a circulating white count of over 100,000, this is probably leukemia. Like there are other things that can make you macrocytic, but absent anything else in the setting of anemia, it is a B12 deficiency or folic acid deficiency. So, yep, hemoglobin low, patient's anemic, MCV elevated, it's macroacidic, RDW is elevated. Well, there is definitely some variability there. So one example is a 72-year-old lady with untreated pernicious anemia, which is a B12 deficiency. Hemoglobin is 8.2. She's anemic. MCV is 125.5. She's macroacidic. And she's got a variability of almost 19%. So most consistent, obviously, with her B12 deficiency. Conversely, a folic acid deficiency very often does not become anemic until much later. This is just a much slower, subtle developing anemia. So many people with a folic acid deficiency will have macrocytosis, but the hemoglobin just barely compensates. It's just above normal. The most common causes of this are patients that are ingesting something else that blocks folate absorption. So alcohol is a really common one. You can see the number of drinks here on the table. When you drink that much a day, it does block folic acid absorption and can give you a folic acid deficiency. There's also a number of medications that can block folic acid absorption as well, and a few of them are listed here. But this patient is much more subtle. So the hemoglobin may be like just at 12 for a woman, just at 13.5 for a man. MCV is a little bit elevated, but not grossly so. And the RDW is usually normal because the RDW is just not that ugly. And we'll look at, I don't know why this picture is here, but because it's here, just by way of reminder, remember 3 drinks a day for women, 5 drinks a day for men can cause this folic acid problem. And this is just a reminder that, of course, beer is alcohol. When you say, do you drink? And the patient says, no, just beer. Well, okay. 5 or more beers a day for a man, 3 or more beers a day for a woman can give you this form of anemia. But let's go back to our patient here. We're talking about a folic acid absorption issue, and it usually is something that is interfering with folic acid absorption. So the next step test really is you do a B12 and a folate level. If you find that your folate level is low, then you're thinking this is what's going on here. And you look to the medication list and you look to their alcohol history. Here's what this can look like. A 32-year-old woman who is taking phenetin blocks the absorption of folic acid, or a 38-year-old woman who drinks 5 glasses of wine a day because she's thirsty. Either way, hemoglobin is 12. It's just at the lower limit of normal. MCV is a little bit elevated at 105.5, and the RDW is normal. So why isn't she anemic? It's because she doesn't block all of her folate absorption. Like instead of maybe going from 10 bags to 5 bags to carry apples in, maybe she went from 10 bags to 7. So now she can shove like, I don't know, maybe 13 or 14 apples in a bag. So they don't get all that big. So they're not that big. The variability is not that intense. But more importantly, if they're not that big, they don't break. So all the apples get to the car. So you're not quite anemic. Does that make sense? If you're if you have a really like a B12 deficiency and you're really not absorbing B12, you will make much less red blood cells. You have way fewer cells to work with. Your body will jam a whole bunch of hemoglobin in each one. They get really big and some of them break. But with a folic acid deficiency, you still are absorbing a fair amount of folic acid, just not optimally. So instead of only having 5 red blood cells or 5 bags in my example, you get 6 or 7, let's say 7 or 8 even. So you don't have to jam them as full of hemoglobin. You don't have to jam them as full of apples. If they don't get that big, the variability from baseline is not as impressive, and they don't break. So you still have 12 grams out in circulation. So this is a much more mild form of anemia. When the patient is macrocytic, if the MCV is very high and the hemoglobin is very low, it's probably B12 deficiency. On the other hand, if the MCV is just a little bit elevated and the patient isn't even anemic yet or just mildly anemic, folic acid deficiency is much more likely. And then we will end our discussion this morning with just a brief nod in what to do about it. When somebody has anemia and you identify that anemia and you identify the cause, treatment is always two-pronged. Treat the underlying cause if you can, and replace a micronutrient if one is missing. So, if you deduce that the patient has iron deficiency anemia, you want to find out where that blood's going. I mean, this is the time to find out they have colon cancer, gastritis, or heavy periods, or whatever. Identify the underlying cause, treat it if you can, and at least document it if you can. Like if the patient has thalassemia, you can't treat that. This is in their DNA. They're going to have it forever, but at least document it. So like, the next time around, another provider doesn't go put them through all the testing all over again. So identify the cause, treat it if you can, document it at the very least if you can't treat it. And then the other thing is if there is a micronutrient missing, replace it. If there's iron deficiency, replace the iron. If there's a folic acid deficiency, replace the folic acid. Now, if they have anemia of chronic disease, or they have thalassemia, there's nothing to replace, so you don't want to put anything in. So you just replace what's missing, treat the underlying cause if you can, and that's it, really. Erythropoietin alpha is shown here on the table, so we'll mention it. This isn't typically a primary care intervention. This usually comes from nephrology. Remember I said if the patient has advanced renal failure, I know the slide said GFR is less than 49, but usually the GFR is worse than that. If the patient has advanced renal disease and they just can't make enough erythropoietin, they don't differentiate enough hemocytoblasts to be red cells and will become anemic that way. And then we have to replace that erythropoietin um, exogenously by giving them an injection of Epigen or Procrit or whichever brand you use. But again, that's typically reserved for nephrology. And that is that. So I think this is a good time for us to take a break here. The time on deck is 18 minutes after the hour. Let me see if there's any questions. I don't see any questions in the Q&A box, so we're not going to do any questions now. We'll go ahead and take our break. We'll come back at 18 minutes after the next hour, and we'll pick up right where we left off. All right, folks. Well, here I am starting off a minute late, which of course will give me chest pain. I apologize for that. Had a little bit of an issue resharing my screen, but I am assuming that you can hear me now. I see my mic moving. So we're going to pick up right where we left off. You remember before the break, we were talking about anemias, and we talked about microcytic, macrocytic versus normocytic, and basically that there are two typical types of each. Microcytic anemias are a hemoglobin problem. Iron deficiency and thalassemia are the most common types. Normocytic anemias are neither a hemoglobin nor a red blood cell problem. They're a problem outside the hematopoietic system. And excuse me, anemia of chronic disease and acute blood loss are the two most common types. And then finally, we have the macrocytic anemias, B12 deficiency and folic acid deficiency are the two most common types. And all of these, I mean, once you get down to micro, macro, or normo, then they become different enough that you can figure it out with really, too much little fanfare. And once you figure out what's going on, then you decide how you're going to treat it. Document the underlying problem, treat it if you can, and just document it if you can't. And if there is a micronutrient missing, you want to replace it. And that's pretty much that in a nutshell. Now, of course, hematology would probably have a cow listening to me simplify it, but we're not studying for board certification in hematology. We're studying for board certification in entry level primary care. And so we really can break it down simply quite that just that way. I noticed right after I said, okay, lunchtime, there's no questions here. Somebody posted a question right after that. And I saw that it came in, but I had already let everybody go basically. And I don't want to address any questions in case anybody who wants to hear it is here. So it wasn't really anything that had anything specific to do with the rest of the program. So I'll address it at the end of the day, I promise. But for right now, let's talk about common diseases occurring commonly in the world of anemia. So what is the most common type of anemia in childhood? I know we haven't talked about it yet. In fact, you and I won't talk about it. The pediatric chapter is one that you will do on demand in the online learning portal, but then you'll see that it is also iron deficiency anemia. It's the same type of anemia, it's just the causation is different. Unlike adults, where blood loss is the most common cause, in children, it's usually dietary. How about the most common type of anemia in pregnancy? Ta-da! Iron deficiency again. Mom is making hemoglobin for two. The most common type of anemia in women of reproductive years, you know it, iron deficiency anemia because of menstruation, which is obviously why a 27-year-old male with a hemoglobin of 11.6 we worry about quite a bit. A woman age 27, assuming she is menstruating, a hemoglobin of 11.6, a little on the lower end than we'd like to see it, but definitely acceptable, and it's because of menstruation. Finally, the most common type of anemia in elderly, well, it's not iron deficiency anemia. Statistically speaking, the most common anemia in the older adult is anemia of chronic disease. This is just statistics. We always look at the blood cell differential to tell the story. But let's face it, as we age, the leading causes of blood loss like menorrhagia, gastritis, bleeding ulcer, these all tend to be more common in middle age. Of course, you can get any of those in older age, and you can also get GI cancers in older age. It's just statistically less common. But and anemia of chronic disease is more common. So it's a numbers game. But iron deficiency anemia is a very close second. And really, we're just talking stats here to frame your thinking. But really, you make the diagnosis beginning with the history, the physical, and then the blood cell differential. And then finally, because nothing works quite the way that it used to as we age, we also have an increased risk of pernicious anemia. And that's number 3 in the older adult. You advise a 28-year-old woman who follows a vegan diet to supplement that diet with what? Now, we didn't talk about this specifically because I knew we would right here, but either you know it or you don't, frankly. And so if you don't, you will in a minute. A 28-year-old woman who is a vegan is not eating any animal products at all. And B12 is an animal vitamin. It only comes from animal products. So if you're a vegan, which is of course the type of vegetarian that eats purely a plant-based diet, nothing derived of animal, no fish, no animal, no fowl, no cheese, no milk, no butter, no animal oils, no nothing. That person is at risk for a dietary deficiency of B12. Anybody who eats anything even remotely derived of an animal is not going to have a dietary deficiency. You can eat 1 egg a month and meet your B12 ingested requirement. So the only people really at risk for a dietary deficiency are true vegans, and the fact is, real vegans know that and they know how they have to supplement, and they generally know it better than I do. Like they tell me what they're going to supplement with. And then people who aren't really living the vegan lifestyle, but they're doing it this week because it's trendy, or like, I have this friend, I guess I won't say her name, but nobody you would know. She's not one of my peers in the MP world, but I have this friend who is like, whoever she adopts the lifestyle of whatever man she's interested in at that particular point in time. So this week she's a vegan, next week she's a cowboy, eating raw meat or whatever. But somebody like that, they really don't understand the diet well enough to be sure and avoid all animal products. So that kind of person is eating an egg in something, or oil or butter or whatever, and they will have enough B12. Bottom line, true deficiencies of B12 only a risk, dietary deficiency, I should say, in someone who eats nothing derived of animal, and that person usually knows how to supplement. Okay, test success tip. A secure knowledge base makes exam questions easier. Well, sure, I think we'd all agree with that. Okay, a 78-year-old woman presents with fatigue, spoon-shaped nails, and the following laboratory results. All right, you know what to do. Hemoglobin is 9, she's anemic. Come down to the MCV. That's the next thing that matters. MCV is 70. She is microcytic. This is iron deficiency anemia or thalassemia, because I doubt she's eating paint chips or working in auto body repair. So she's microcytic, she's anemic, and her RDW is elevated, which implies an ongoing or changing problem. So a critical causative diagnosis to consider as the origin of her anemia is, and you say, iron deficiency. And then you look at the answer choices, and iron deficiency is not there. That's because this is the highest level of analysis and application question. Iron deficiency is the likely cause of her anemia. Now we have to look at these and think which one is the best cause, the most likely cause. GI blood loss, micronutrient malabsorption, chronic ileitis, or folic acid deficiency. And the best answer is A. It could be anywhere in the GI tract that she's losing blood. Micronutrient malabsorption, this is really not ever a problem of iron malabsorption. That's not an issue. Micronutrient malabsorptions are B12 and folic acid. That would produce a macrocytic anemia. But people don't get iron deficient because they can't absorb iron. Chronic ileitis could work. I mean, inflammation of the ileum could lead to bleeding. It's just that A is better because it accounts for the whole GI tract, and a folic acid deficiency would make you macrocytic. So A and C both could work, but A is the better of the two. All right. Also, from a general question analysis perspective, sometimes we look for keywords like optimal or maximize, which makes total sense, right? All right, I'll bet those words are in the next question. Which of the following represents the optimal advice to a patient who is taking oral iron therapy to maximize the medication's effectiveness? So there we go. We have both words in this question. Optimal advice to maximize effectiveness. Clearly, we want to maximize this medication's effectiveness. So would we tell the patient to take iron with an antacid? And the answer is no. Antacids, their job is to bind things in the gut. They work by binding acid or hydrogen ions, but they'll bind any charged particle like iron. So that would be like a no. How about take your medication on an empty stomach? Hmm. Well, in terms of maximizing effectiveness, B is certainly better than A. B will facilitate maximal absorption. It's just that it will also facilitate maximal abdominal discomfort and maximal constipation, but it definitely will promote absorption, which of course has to happen for a medicine to be effective. So to answer this question, B is better than A. Let's see what C or D have to offer. C says take it with the largest meal of the day, which is not good advice for someone when you're trying to maximize effectiveness. The largest meal of the day is likely to have the greatest variety of other of electrolytes and charged particles and other things that will bind iron. So that would keep it from getting absorbed. So that's no good. And milk is full of calcium. which will bind iron and keep it from being absorbed. In fact, many antacids have a lot of calcium in it. So none of these answers are great, but the best answer to the question, if you want to maximize the medication's effectiveness, tell them to take it on an empty stomach and just, advise that it's gonna make Mr. Tummy sore. I mean, if you could pick your answer here, I'd say take it with a soluble fiber. Take it with like a piece of bread or something that's not going to change absorption at all, but just might line your stomach a little bit to sort of blunt the caustic effect. But we had to pick the best option, and the best answer to this question is B. A 68-year-old woman presents with a 6-month history of increasingly severe peripheral numbness and oral irritation. She denies lightheadedness or chest pain, but does notice she is short of breath when climbing a flight of stairs. Hemogram results are as follows. Again, you know what to do. Hemoglobin is 6.2. Hopefully that catches your attention. She is anemic. MCV is 132. She's macrocytic, and the RDW is elevated, so this is an evolving problem. Physical exam reveals pale conjunctiva, a grade 2 of 6 systolic ejection murmur over the precordium without radiation, and a smooth red tongue. Blood pressure is fine, resting pulse is 92, respirations are good. Got a lot of info here. You can see the irritation, the cheilitis, that tongue is that beefy red tongue. We call it glossitis, and these are all characteristic of a very particular type of anemia. The most likely cause of this anemia is, well, right off the bat from the CBC that her MCV is 132. It's macrocytic, and she's quite anemic with a hemoglobin of 6.2, which right there makes B12 deficiency most common. And then when you look at the symptoms of severe peripheral numbness, the oral irritation, these are all neurologic findings that we only see with a B12 deficiency. And there it is. After carefully reading all 4 answer choices, we come right back to A, vitamin B12 deficiency. The collection of everything there makes it B12. And really, there's more answer on this slide than you actually need. And because she's macrocytic, that narrows it down to B12 or folic acid deficiency. And B12 is the only one there, so there's that. But also remember I said B12 deficiencies, the anemias tend to be more profound. Folic acid deficiencies, they tend to be like a quieter, just a less intense anemia. And yes, everything else here on this slide is also true, but you had me at macrocytosis. It had to be B12 or folic acid, and only one of them was in the answer choice. And so I'm going to leave this here for just a minute or two because I suspect some of you might be writing it down. Or maybe a moment or 3. And then if anybody else wants me to come back and show this slide later, I'm happy to. Okay. The heart murmur noted in the above mentioned patient had not been present on previous examination. As a result, you consider that this is likely a what kind of murmur and will resolve with anemia treatment. Well, if you know the answer, you know it, and if you don't, we have to analyze. Well, the heart murmur in the above patient has not been present previously, so you can eliminate D, it's not congenital. You can also eliminate C because C isn't a murmur. A venous hum is something that you hear over the abdomen. And typically when there's engorgement of the portal bed, the vasculature down there around the liver and the spleen when it becomes engorged. So you're left with A or B. Is it a pathologic murmur or a hemic murmur? And if you said pathologic, that's not wrong. It's just not the best answer. A pathologic anything is something's wrong. Physiologic is benign. Like a physiologic murmur is a benign murmur. A pathologic murmur indicates that something is not right. And here, something is not right. But hemic murmur is exactly what this is. Hemic murmur is the best answer. A hemic murmur is a murmur that happens when the blood viscosity is very low, when the blood's really watery. And blood is either really watery because the hemoglobin is real low. If hemoglobin and hematocrit are low, blood is more like water. And you can also get it if somebody's overhydrated, like we give them too much IV fluid, put them into fluid overload. It's when the blood is really watery. you will develop a hemic murmur. You hear this noise as it pounds over the precordium, and it will resolve when you fix the problem. If the patient's anemic, treat the anemia. If they're fluid overloaded, get the fluid off them, and the murmur will go away. The reason I said pathologic murmur isn't wrong is because technically it's not wrong. Like I said, pathologic means there's a problem. And for this patient, there is a problem. But generally speaking, pathologic murmurs, that term is usually meant to refer to a murmur that's happening either because of a stenotic valve, a regurgitant valve, or a septal defect, like an atrial septal defect or a ventricular septal defect. That's classically what a pathologic murmur means. So even though technically A is not wrong, B is just the better option. Match the best next test to order in an adult with anemia based on the hemogram results. Okay. All right. First up, A. The MCV is low. This is a hemoglobin problem. If the MCV is low, the MCHC is low. So we'll just leave that there. MCV is low, hemoglobin problem, RDW elevated, evolving problem. That sounds most like iron deficiency, so you would check a ferritin. Whereas if the MCV is low, hemoglobin problem, but the RDW is normal, that's not an evolving problem, that's a stable problem, and that sounds like thalassemia, the other hemoglobin problem. So we do hemoglobin electrophoresis. And then finally, the last one is the last one, so I guess I can fill it in. But if the MCV is elevated, that's a macrocytic patient, and we know that if the patient is macrocytic, we're suspicious for either pernicious anemia, a B12 deficiency. I'm sorry, I'm looking at the screen and I shouldn't be. I should be looking at you. If the MCV is elevated, we have a macrocytic anemia, and that would be either a B12 deficiency or a folic acid deficiency. And that being the case, there's only, one option here that fits, and it's a B12 and folate level. B12 and actually, I did start to say that the right way. My brain is not creative. I have a very linear left brain, and the fact that B12 and folate are in the middle of this table is just killing me here. But the answers as they are presented are true. You've got two microcytic anemias, two hemoglobin problems here. The only difference is RDW up or not. If it's up, you think iron deficiency, order ferritin. If the RDW is normal, you think thalassemia, order hemoglobin electrophoresis. If the MCV is elevated, that's all you need to know. You're always going to order the B12 and folate together. In fact, most labs offer them as a match set that's discounted as compared to each one individually. I don't really understand that, but it's cheaper to order a B12 and folate together than it is to order either one of them separately. Okay, question 7. A 65-year-old woman with rheumatoid arthritis who is on optimized therapy and continues to have significant RA symptoms presents with the following hemogram. All right, you know how to look at the hemogram. The hemoglobin is low, she's anemic. Come down to the MCV, it's 82, she's normocytic. You're done. Anemia of chronic disease or acute blood loss. These findings are most consistent with what? Well, aside from the fact that anemia of chronic disease is the only answer here that is normocytic, also keep in mind the question tells us she has RA and she's still symptomatic, and it doesn't mention anything about exsanguinating. So we can safely assume that anemia of chronic disease is her underlying problem. Now I'm going to switch gears a little bit, and true or false. It's a clumsy sentence, but it's what it is, so we have to go with it. The use of all of the following nutritional supplements is potentially associated with increased bleeding risk and should be discontinued at least 7 to 10 days prior to elective surgical procedure and used with caution with drugs like aspirin, direct oral anticoagulants, or pretty much anything that can cause bleeding, right? The question here, like I said, it's a clumsy statement, but it's really saying is of these 4 nutritional supplements, true or false for each one, can they potentiate bleeding or not? Can ginseng potentiate bleeding? Yes, it's true. How about ginkgo? Yes. Fish oil? Yes. The only one of these that does not potentiate bleeding is vitamin D. So while you fill in the blank, let me explain here. Many nutraceuticals do what they purport to do by acting like natural Plavix, like a natural platelet aggregate inhibitor. And so, not all of them, but the vast majority, they do inhibit platelet aggregation. So, just as a general rule of thumb, if you're not sure, assume that a nutraceutical will promote bleeding and should be used cautiously in these circumstances. It's the rare exception that doesn't. Even fish oil too. I mean, people think it's awesome and it's a wonderful thing, but it can potentiate bleeding. Vitamin D, though, remember, vitamin D is an endogenous vitamin that's really, I mean, it's got a lot of roles in the body, but it's probably best known for its role in the calcium homeostasis cascade. Vitamin D, parathormone, calcitonin, they all regulate calcium and doesn't really have an impact on bleeding, at least as far as we know it. But a general principle to take to your exam is if you get any question that in any way implies that a nutraceutical, a nutritional supplement, potentiates bleeding, the answer is probably yes. If you're not sure, err on the side of yes. The one that I can tell you for sure does not is St. John's wort. But the rest of them, I would just assume they can make you bleed unless you know differently. You see Maria, a 32-year-old well woman of Mediterranean ancestry, who coincidentally has a map of the Mediterranean with her. Hemogram results are as follows. Again, you know what to do. Hemoglobin is 10.6. She's anemic. MCV is 71. She's microcytic. This is a hemoglobin problem. And the RDW is normal, so it's a stable hemoglobin problem. Throw in the fact that she's of Mediterranean ancestry. These findings are most consistent with what? Well, you know it's a thalassemia. So as you look at your answer choices, A is out, the RDW would be elevated. You might not know what B is. C says thalassemia, so that could be good. And it's not acute blood loss. She's not exsanguinating and her RDW is not normal. So you're left with B and C. And the fact is, they are both different types of thalassemia. Thalassemia is very heterogeneous. It comes in many different forms. But there's minor forms and major forms. Cooley's anemia is a major form of thalassemia, and usually the patient is profoundly anemic and has a number of physical findings that will make it clear. Any woman she's 32 years old, she's a 32-year-old well woman with a hemoglobin of 10.5. That has to be a thalassemia minor. Nobody with thalassemia minor is going to have a hemoglobin in double digits, and that makes C the obvious answer to that question. Primary care of Sarah, a 27-year-old woman with beta thalassemia minor, should include what? Prescribing a low-dose iron supplement to counteract microcytosis? And the answer to that is no. We don't prescribe iron to counteract microcytosis, right? We prescribe iron to replace an iron deficiency. So if the patient has an iron deficiency, the microcytosis will correct, but we don't give iron for that reason. How about an evaluation of hemoglobin electrophoresis every 5 years? Well, she doesn't need that either. I mean, I guess it's better than A because we definitely don't want to give a patient with thalassemia iron. But she doesn't need hemoglobin electrophoresis more than once. She has it once, it confirms her diagnosis of thalassemia, and that's that. It's not going to change. Remember, this is a DNA mutation. If you're born with it, it's there forever. How about advising taking a multivitamin with high dose folate supplementation daily? Again, no reason. Remember, we only replace micronutrients that are missing. And she's not missing any. She's got a DNA mutation. And then the last option is offering genetic counseling prior to pregnancy. And that actually is the winner. That's going to be your answer. And the reason is that thalassemia is an autosomal recessive disorder. So she has thalassemia minor. She's not overtly symptomatic, and it's not really affecting her world in any major way, but she has a gene for thalassemia. If she procreates with someone else who has the gene for thalassemia, their offspring might get the thalassemia recessive gene from both parents, and the child winds up with full-blown thalassemia major, and that does have significant impact. You might remember this from good old Mendelian genetics in your Biology 101 class of undergrad. We have 23 pairs of genes, right? Dad has a pair, mom has a pair, and every time they procreate, they each liberate one to the child. So if dad has thalassemia minor, one affected gene, mom has thalassemia minor, one affected gene. Since this is a recessive disorder, you have to have both for the disease to really express itself. Thalassemia minor is usually not a significant problem, but every time they procreate, there's four possible outcomes. Either dad and mom both liberate affected gene and make a child that does not have the thalassemia gene. Did I just say affected? I meant unaffected. Dad and mom liberate unaffected gene, child does not have thalassemia or the trait. Or dad liberates unaffected gene, mom liberates affected gene, child has thalassemia minor like the parent. Or in the reverse, dad liberates affected gene, mom liberates unaffected gene. Again, child like the parent has thalassemia minor. But every time they procreate, there's a 1 in 4 chance that both dad and mom liberate affected gene and the child has full-blown thalassemia major. And it does have major health implications, and that's if the fetus survives. So that's what the genetic counseling is about. Sickle cell is the same thing. Sickle cell, it's autosomal recessive. You have people with sickle cell trait, which is analogous to thalassemia minor. It doesn't have a huge impact in their world, but if they procreate with someone who also has the sickle cell trait, there's a 1 in 4 chance that their offspring will have full-blown hemoglobin SS, and that has many implications for the health and development of the child. So genetic counseling is definitely indicated when mom has one of these hemoglobinopathies. Excuse me. And that takes us to our last topic of this discussion, which is evaluation of the white blood cell differential. And so you may be familiar with this, but we're always asked to go through it in the review program. So that's why we close out this chapter with it. Remember, in the world of white blood cells, we have 5 basic types. We have neutrophils, lymphocytes. Your picture shows 2 different lymphocytes, granular and agranular, but they're both lymphocytes, so it's a single type. Neutrophil, lymphocyte, monocyte, eosinophil, and basophil. These are 5 mature types of white blood cells, and collectively they all come together to protect us and help protect us from things that would try to hurt us, the organism. So the total white blood cell count, the total of all 5 cell types, should be between 6 and 10,000 in a healthy adult. Depends on whose book you read. Some will say 5 and 12,000, etc., but around that general number. And that comprises the total of the 5 types of white blood cells. And this number collectively is referred to as the leukocytes. The leukocytes break down into those 5 subtypes. So if the leukocytes are elevated, well, then we suspect there might be something going on, something trying to hurt us, and we're mounting a response to it. Further, we can look at the types of cells that are elevating and get a better picture of what's going on. So we have those 5 types of white blood cells: neutrophil, lymphocyte, monocyte, eosinophil, and basophil. And if you need a mnemonic to help you remember them, you could remember "nobody likes my educational background," or you could just remember neutrophil, lymphocyte, monocyte, eosinophil, and basophil. And they each have different jobs to do, and this is a simplistic representation, but it's good enough for this discussion. Of those 5 types, neutrophils are most prevalent. They're 60% of our total white cell count in the healthy state, and primarily they target bacteria. So if you get a bacterial infection, neutrophils will be on the scene to try to fix it. If you have 10,000 leukocytes in your blood today, 60% or 6,000 of them are neutrophils, which is perfect because you're more likely to be exposed to bacteria than anything else. And we're covered in this stuff, right? So you get a cut, you don't wipe the wrong way, some way the bacteria gets inside, you got 6,000 neutrophils on the scene to get rid of it. 30% of our total white count are lymphocytes, which also makes sense because while we're not covered in viruses, they're certainly everywhere and there's the potential exposure. So, of our total white blood cell count, our total leukocyte count, in the healthy state, 90% are there to fight bacteria and viruses. The remaining 10% break down the way you see it on the screen. Monocytes are only 6% of our white cells in the healthy state. If you have 10,000 leukocytes on board, 600 are monocytes. Their job is really to go after non-infectious debris. Like they will go after necrotic tissue, they will try to neutralize dysplastic tissue, and you're just not exposed to that nearly as often as bacteria and viruses. Eosinophils, you might have heard the phrase worms, wheezes, and weird diseases. Eosinophils do target allergens, those things that would cause a hypersensitivity response, and also parasitic infection. And then finally, the bottom, basophils are only 1% of the differential. Nobody really knows what they do, but nobody really tries to study it too much because it's only 1% of the differential. There's just not a whole lot of interest in spending millions of dollars to figure out exactly what they do. There's a basophil every time you see a hypersensitivity response or a complement response, but nobody's really totally figured it out. But what you can take away from this is the normal breakdown is 60, 30, 6, 3, and 1. The relative percentages have to total 100 because you have to have 100%. If you have 10,000 white cells, they have to break down one way or another to these 5 cell types. So and that's the average breakdown. But if one goes up, something else has to go down to make it balance. And we're expected to be able to figure that out. If the patient has a serious bacterial infection, the white cell, the neutrophil differential will elevate 70%, 80%, even higher. So if the neutrophils are 80% of your differential, you've only got 20% left for the other types. So lymphocytes will go down because that's all that has much to give. If the patient has a viral infection, a systemic viral infection, lymphocytes will go up because you need more lymphocytes. But if lymphocytes go up, say, from 30 to 40 or 50%, neutrophils have to go down because all 5 types can only total 100%. So, case A, you got a patient with 5,500 total white cells. Okay, not impressive. But the neutrophils are only 40% of that differential. It's a little odd, a little low. Bands are immature neutrophils. Just like reticulocytes are immature red cells, bands are immature neutrophils. And up to 4% neutrophils or 4% bands in circulation is considered normal. So here the neutrophils are low, the bands are normal, but the lymphocytes are elevated at 55%. And reactive forms just mean they are active and working. They're on the hunt for viruses. So case A sounds like a viral infection. Whereas case B, the total white cell count is over 16,000, and the neutrophils are 71% of that 16,500. So there's more neutrophils here than usual, and they are toxic. They have started to show toxic granulation, which means they're working. The band count is a little elevated, which means there's more neutrophils on the horizon. And because the bands and the neutrophils are a little elevated, the lymphocytes have to drop. So the viral infection is case A. The bacterial infection, of course, is case B. And that's how we use our differential. And that, boom, is the end of that chapter. So now, if you're going, oh man, you just looked at your watch and you're like, or your phone or whatever, you're like, oh my gosh, is it really only this time? We still have all these hours to go? Yes, we do. And that's why we plunk ear, eye, nose, and throat disorders right here. Because just when you're starting to feel a little dozy, maybe you had a big lunch and you're tired and ready for a nap, and the sound of my voice is becoming very monotonous, now we have a topic that is just so directly relevant to the way you spend your primary care day, as well as directly relevant to your boards, that you definitely want to take a shot of a Red Bull or something and jump right back in the convo. Because if you work in primary care, you will spend half your day looking in people's eyes, ears, noses, and throats, which I guess is marginally better than where you could spend the other half of your day looking. But however you cut it, this is a very important topic. So, eye, ear, nose, and throat. So, in the world of primary care, because again, we're not studying for board certification in otolaryngology or ophthalmology, we're studying for board certification in family practice. So, when people come to see you with problems in their eyes, ears, noses, or throat, one of the first things you have to ask yourself is it allergic or is it infectious? It's going to be one of the two. If it's infectious, it's either viral or bacterial. And if it's allergic, it's an allergy. And this is going to dictate how we treat it. So it's the first thing you ask yourself, whatever part of the head or neck that it's in. Now, we use rhinosinusitis to illustrate the conversation, but the concepts we talk about here in rhinosinusitis, you can directly apply to the ears, the throat, the eyes, like the whole shooting match. But we use sinusitis because it's a good illustrator. Because in primary care, like we've done a really good job of not giving people antibiotics anymore when they have pharyngitis or URI, but we still give antibiotics way too often with a diagnosis of acute sinusitis, and most of the time it's not necessary. So it's good that we use rhinosinusitis as the foundation here, but please keep in mind that the principles we talk about with the rhinosinusitis area, we can apply anywhere on the head and neck. All right, so rhinosinusitis. You know that we have four pairs of sinuses. On the slide in front of you, you see the yellow ones just above the maxilla. They are conveniently called the maxillary sinuses. And then above those, like at the top of the nose between the eyebrows, you see the thing that looks kind of like a blue butterfly. Those are the ethmoid sinuses. And then at the top, you see the green frontal sinuses. And then off to the right, you see a skull, which is angled a little bit. And you need the angle because behind the ethmoid sinuses, you see the purple sphenoid sinuses. They're here for the sake of completeness. Sphenoid sinuses usually don't cause the kind of problems that we see in primary care. The sphenoids are deep there under the brain. They're very well protected and they really don't get infected for the most part. When they get infected, it is a real problem for the patient. It's way too close to the meninges. They usually get systemically ill and wind up in the hospital. And when the sphenoids get infected, there's usually some significant immunocompromise that allowed it to happen. What you're likely to see in primary care are maxillary sinuses, ethmoid sinuses, or frontal sinuses affected. So again, you can apply this to pretty much any. I mean, we have two eyes, two noses. Well, I only have one throat, but it's got a uvula in the middle. You get the idea. When somebody comes to you complaining of rhinosinusitis, oh, I have green snot, my nose is all clogged, whatever. The first thing you have to ask yourself is this infectious or is it infectious or allergic? And if it's infectious, is it bacterial or viral? Notice on the cutout, the table in front of you, acute rhinosinusitis doesn't have a B in it. There's no bacteria there. Acute sinusitis is inflammation of the nasal passages, the mucosal lining, for almost any reason. It could be environmental irritants, it could be a viral infection, it could be transient bacterial exposure, any number. It could be smoke, it could be perfumes, whatever. Any irritation to the mucosal lining of the nasal passages is sinusitis. When you have a secondary invasion of bacteria, when the bacteria penetrate through the protective layer and manage to get in the sinuses and reproduce, then you have acute bacterial rhinosinusitis. Acute bacterial rhinosinusitis, like your slide says, usually follows some other insult to the nasal passages because, like, really, we're all colonized with bacteria all over our skin, our mouth, our teeth, our sinuses, etc. But we have defense mechanisms that keep them from becoming invasive and producing active infection. They're just colonized, they're not hurting anybody. But if something happens to the mucosal lining of your nasal passages, maybe it's a viral infection, maybe it's really bad allergic inflammation, maybe it's instrumentation, like a rhino rocket because you had a bloody nose or something. An alarming number of people stick things in their nose for, I really haven't figured out why. But if you do anything to penetrate the protective barrier of the nasal mucosa, then the bacteria that line it can get inside and become infectious. And that's what bacterial rhinosinusitis is. It is secondary to some other process that has damaged the nasal mucosa and allows the bacteria to get in and multiply. It is relatively uncommon. Notice that less than 2% of viral URIs are complicated by bacterial infection. And even then, in the otherwise immunocompetent patient, most of those will resolve on their own. The takeaway message here, true bacterial sinusitis requiring antibiotics really is not very common. Of course, the flip side of that is if the patient does have true bacterial rhinosinusitis, then we should medicate it. We should treat it with antibiotics because there's just too close a proximity to structures in the head that it can be catastrophic if the patient has a bacterial infection that spreads. So, test success tip. In order to prescribe antimicrobials, you need to know the causative bug so you can choose the right drug. It's a paradox, really. Most cases of sinusitis are not acute bacterial rhinosinusitis, but when you genuinely believe they are, you do need to prescribe an antibiotic. So, for the next few pages, I will admit it goes a little bit more detail than you really need for your boards. Dr. Fitzgerald just goes into detail here about antibiotics because everyone always asks. It's like a real hot topic for new grads, like how do you know which antibiotics, what do you do, et cetera, et cetera. The truth is, in most cases, a new grad, when you first go to school or first go to work, that first year or two out of school, for the most part, once you decide an antibiotic is necessary for anything, you're going to look it up. There's guidelines out there all over the place. There's guidelines for all occasions. And if you decide that your patient genuinely has acute bacterial rhinosinusitis, Google it. It's what all of us good academics do. Google it, and you will find, among other things, the recommendations of the Sinus and Allergy Health Partnership, and they've done all the decision making, and they tell you which antibiotics are your best choice. But at some point, when you get to the place where you want to genuinely understand, and you don't want to just do a guideline for guideline's sake, or the guidelines don't work, because sometimes that does happen, and you really want to reason through how to decision your antibiotics, then you'll want to understand these principles of empiric antimicrobial decision making, which is what we have here. Empiric therapy really just means that you pick the antibiotic without having a culture. We have to pick an antibiotic when we're not sure what organism we're treating and what it's sensitive to. That's what empiric antimicrobial therapy is. I know your handout says it more eloquently, but it really comes down to picking an antibiotic when you don't have a culture. And there are certain steps. They're listed in your handout and they're right here in the slide. First thing you have to ask yourself is, what is the most likely bug I'm trying to treat? And for the most part, we have a pretty good idea. Like, again, I'm talking about the otherwise healthy patient. An immunocompromised patient, that's a different story, and that won't be on your exam. But the immunocompetent patient, we know which organisms colonize which part of the body pretty well. Like in the sinuses, for instance, all over the head and neck for that matter, we know what the top three bugs are. We know what colonizes the skin all over the rest of the body. We know that 75% of UTIs come from E. coli. I mean, we have a pretty good idea of what organisms colonize what part of the body. So, what are the most likely pathogens? Even if we don't know for sure, we can make some educated guesses. What is the spectrum of a given antimicrobial's activity? Remember, antimicrobials come in three general flavors: narrow spectrum, broad spectrum, and extended spectrum. The narrower spectrum, the greater the efficacy for the bugs it covers. So, like a narrow spectrum drug for, say, gram positives only covers certain gram positives, but it does it really, really well. If you know exactly what bug you're treating and there's a narrow spectrum available, that's the one you want to use. But if you don't know, and there might be more than one, then you will go with a broad spectrum antibiotic. When you go with a broad spectrum, you cover more bugs, but you generally lose a little bit of the punch. So for most people with routine infection, it'll be fine. But, occasionally it'll miss because they're not quite as powerful. And then extended spectrum, like these are really the big guns when you just don't have time to wait for a culture or don't have time to worry about it. Like this is mostly used in the hospital setting. If somebody's in septic shock and you don't have cultures back yet, you can't wait for the culture. So you just hit them with a big extended spectrum drug and try to kill everything. So needless to say, in primary care, mostly what we're decisioning is narrow spectrum versus broad spectrum. Then we have to ask ourselves, what is the likelihood of resistance? Many bacteria have learned that we're going to try to kill it with antibiotics. And so they've developed mechanisms of resistance. They've developed ways to become resistant to those antibiotics. And we have to ask ourselves in any given situation, is it likely? And what do we have to do about it? If we really want to cover a resistant bug, sometimes we have to double the dose of the antibiotic. Sometimes we have to add something else to it. So we just have to consider what is the likelihood of resistance, and then finally, what is the danger of treatment failure? What if we get it wrong? What if we're making our educated guess, but it's just wrong? Well, for a rhinosinusitis or any routine infection of the head and neck, for the otherwise healthy patient, if we get it wrong, they'll probably be fine. They might be sick a little longer, but they'll probably be fine. But maybe somebody who's got like uncontrolled diabetes or, really high blood pressure and they're not perfusing things well, or and people with COPD who have a tendency to be like under oxygenated, and then we throw an infection in to crank up their metabolic rate. Like somebody like that missing the organism, treatment failure can be really dangerous. So we have to consider all of that. So after we look at the likely bug, the antibiotics activity, the likelihood of resistance, and the risk of treatment failure, then we pick our antibiotic. Then we have to decide the optimal safe dose and the shortest effective course of therapy. And I mean, these are all important words that come together. I think I told you before, or maybe I didn't. No, I didn't, because we just started talking today. I'm blurring everything together. One of the biggest problems in primary care is that primary care providers in general, not just MPs, but all primary care providers, tend to underdose. We tend to use doses that are too low and for too short a period of time. And while we definitely don't want to overdo it and give people stuff they don't need, we certainly, if we decide that you need an antibiotic for your sinusitis, we want to give you enough to treat the infection. So optimal safe dose, shortest effective duration. And like I said, there's numerous guidelines out there that have already done this for you. So you don't have to perseverate it in that first year. But when you get a little more comfortable and you just want to learn a little bit more about what you're doing and how guidelines are put together, these are the questions. This is what guidelines look at, and then they put it together for you. So, test success tip. In treating acute bacterial rhinosinusitis, what we're trying to cover are three organisms: Strep pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Those are the bugs. And so, in the spirit of know your bugs, we have a bug table. First bug table shows Streptococcus pneumoniae. And you can see a mnemonic here. COMPS is the mnemonic, and it shows you all the parts of the head and neck and even the chest that strep pneumoniae can infect. Like I said, all over the head. We've got conjunctivitis, otitis, sinusitis, also meningitis, and even the lungs and pneumonia. This is a gram-positive organism. It's the #1 cause of acute bacterial rhinosinusitis in adults. If you think your patient genuinely needs an antibiotic for sinusitis, you need to cover strep. That's #1 that you must cover. And there is a drug-resistant form. It's known as drug-resistant strep pneumoniae. And if you need to cover drug-resistant strep pneumoniae, you really need to crank up the dose of your antibiotic. So it's definitely worth knowing and considering. That's bug #1. Bug #2 is Haemophilus influenzae. So Haemophilus influenzae is a gram-negative rod, a gram-negative bacillus. So now, since we don't have a culture, because we typically don't for sinusitis, we have to cover strep and we have to cover H flu. So already we're looking at a broad spectrum antibiotic. And it can affect all the same parts of the body that strep can. You can see them listed here on your slide. And of course, H flu also has a resistant form, and the mechanism of resistance is different. With H flu, when it's resistant to antibiotics, its mechanism of resistance is known as beta lactamase production. So, beta lactamase, well, let me guess me back up a little bit. Beta lactams are physical properties on many antibiotics that kill bacteria by breaking up the bacterial cell wall. Remember, bacteria have cell walls, whereas human cells have cell membranes. So cell walls are a good treatment target because you can break apart cell walls all day long and not hurt the human. This is a very important point of treating. If you want to kill an organism, you want to do it without killing the human. So destroy a cell wall, great. Humans don't have cell walls. So that's awesome. All the penicillin family, all the cephalosporin family, Those antibiotics work by way of a beta-lactam structure. It's a physical property on the drug, and it breaks apart the cell wall of the bacteria, and the bacteria die. Except that about 30% of them have learned how to produce beta-lactamase. So remember in science, when you put ace on the end of a word, it breaks down the first part of the word, like proteinases break down protein, lipases break down lipids, beta-lactamases break down beta-lactams. So about 30% of H. flu make this enzyme that will break down the beta-lactam in an antibiotic and make it ineffective. So 70% don't. So the majority don't, but about 30% do. So if you really think your patient might have a beta lactamase producing H. flu, then you need to treat them with a beta lactamase resistant antibiotic, right? So again, it impacts our treatment decisions. And then finally, Moraxella catarrhalis is a very distant third. It really doesn't impact decision making very much. It is a gram-negative cocci, and they virtually all are beta lactamase producers. But the truth is, if you need to cover this Moraxella catarrhalis, you will have already done so when you covered the H. flu that produces beta lactamase. In other words, the only reason you even care about Moraxella is if the patient has like some level of compromise or something and you're really worried and you don't want to miss anything, like your fear of treatment failure is very high, you're not willing to risk it, you want to cover every single bug, you will have covered strep, drug-resistant strep, you will have covered H. flu and beta-lactamase producers, and the same thing that covers beta-lactamase producing H. flu will cover beta-lactamase producing MCAT by default. So in its own right, this drug really doesn't decision very much for us. Now, it is important that you be able to distinguish, the difference between sinusitis and bacterial rhinosinusitis. I mean, it's not always that easy, but there are definitely some things that you can look for. One of them, remember that I said it's bacterial sinusitis is a secondary infection. So the time frame involved here is important. Also, with bacterial sinusitis, and you can see the slide in front of you, these are things that are more common in acute bacterial sinusitis. The first bullet point, fever and duration greater than 10 days. Fever is a little bit more likely because you will perceive that there is bacteria threatening the area around the meninges. The body has a really awesome way of recognizing when something bad could happen and preparing for it in advance. So, people with allergic rhinitis or viral rhinitis, they don't typically get fevers. But with secondary bacterial sinusitis, fever is much more common. And the other thing that's really telling is the duration. Patients will have had symptoms for an absolute minimum of 10 days and usually a lot longer. Usually what happens is the patient comes in to see you and says, "Oh, I have sinusitis. I came in to get a Z-Pack. It's really bad this time." And you say, "Oh, well, tell me what's going on." And they say, "Well, usually I get it like every year, but this year, like, I don't know. I had it, and then it was like I had a cold and I had my sinus thing, and then it seemed to get better, but then I don't know. It's just like this one sinus right here just started to get really bad." That takes time. What happened is first the patient had a viral infection, it sounds like. They had a viral infection and they were symptomatic for a while, and then it appeared to get better and it started to go away as the viral infection resolved. But that viral infection allowed a break in the protective mucosal barrier and the bacteria got in. And then the bacteria got in and it started to colonize. And, several days later, it became an active infection. So whether it's a viral infection or allergies or whatever, first, something happens to break that mucosal barrier, and whatever that something is will occur, and then it will seem to get better because the first thing does. But then when the bacteria gets in there and starts cooking, symptoms seem to rebound, typically a couple of weeks later. So that's pretty telling. Some people will actually complain of of what feels like a toothache. In fact, a lot of people will go to the dentist saying they think they have a toothache, and then the dentist will do a, what do you call it? An x-ray and say, well, your tooth is fine, but there's consolidation in your sinuses. Initial symptom improvement followed by worsening. I mean, that's what I was just talking about. The primary problem that messed up the mucosal barrier in the first place, it will be there and then it will get better. And then the worsening is when the bacteria starts to multiply. Um, Cacosmia or a sense of bad odor in the nose, that's very nonspecific. It certainly can occur if there's infection in the sinuses, and it can occur for a lot of other reasons too. And the unilateral facial pain is the sinus. Most bacterial sinusitis is unilateral. It's really unusual that you develop a secondary bacterial infection in both sinuses in a pair at the same time. That just doesn't happen very much. So if somebody has symptoms and then they seem to get better and then they come back and they kind of localize on one side, that's very telling for what do you call it, a bacterial infection. That's a reason to use antibiotics. Now, you got this big algorithm here, figure 4 or 5. I'm not going to go over it in any detail because we don't really need to. It's a great reference when you get your job. Take this book to work and put it in your drawer because when the internet goes out one day, you'll be glad you have diagrams like this. But the thing I do want to draw your attention to on this diagram is on the right, you see a box, the only one that's in that pinkish purplish color. And those are risk factors for antibiotic resistance. Remember, I said one of the things you think about when you're picking your antibiotic is the likelihood of resistance. And those things you see in that box are risk factors for antibiotic resistance. These people are at higher risk for resistant organisms. So if you're treating sinusitis in patients with any of these factors, you do want to cover resistant organism. Excuse me. Of course, we talk about head and neck. I'm going to get all like snotty and sinusy and cough a little bit. It's invariable. As long as I don't have an MI when we get to the cardiac section tomorrow, I don't mind. Okay, true or false? The US FDA advises that the adverse effects associated with fluoroquinolones generally outweigh the benefits for patients with acute sinusitis, bronchitis, and uncomplicated urinary tract infection who have other treatment options. Is that statement true or false? You might be saying to yourself, I don't know, but why is that here? Well, we'll deal with that in a minute. But for right now, suffice it to say, it's a true statement. When the patient has other options, the FDA prefers we use other options. And it's because we have so overused fluoroquinolones, we've developed resistances where they shouldn't occur, and we really have to worry about adverse effects, which in some populations can be really significant. So when you can use something else, you want to use a something else. Now, before we get to drugs specifically, there is a test success tip here that is a reminder not to ask any drug to do something it can't do. And that is, of course, true with antibiotics as well. If you're trying to cover a gram-negative organism, you can't use a narrow-spectrum drug for gram-positives. It just won't work. Like if the drug won't cover the bug, it doesn't matter how much you give, it just won't do it. If somebody is sneaking out the back door and you lock the front door with 5 deadbolts and, all kinds and chains and all kinds of other stuff, it won't matter because the patient's sneaking out the back door. And that's kind of what happens when we bombard a patient with a really high power, high amount of antibiotic, and it just doesn't cover the bug we're trying to cover. So consideration, and like I said, for your first year of practice, there's plenty of guidelines out there to tell you how it's done. But when you start decisioning it for yourself, these are the things that you really do need to think about. So table 4-5 is the antibiotic table for bacterial sinusitis. This really is the summation of the guidelines from the Sinus and Allergy Health Partnership. First off, notice that they tell us flat out the macrolides like azithromycin, the infamous Z-Pak, clarithromycin, all the mycins, as well as Bactrim, are no longer routinely recommended for bacterial sinusitis. They used to be. I remember teaching when they were first line meds, but they're not anymore. And it's because resistance is high and there are other options that are equally safe and more effective. And they begin with amoxicillin. The initial indication, the initial treatment for your average garden variety patient, the Sinus and Allergy Partnership advises amoxicillin. You can use standard dose amoxicillin, which is 500 TID or 875 BID. Amoxicillin will cover strep. At this dose, it won't cover drug resistance, but most people don't have that. It'll cover strep. It'll cover H flu. Amoxicillin will not cover beta-lactamase producers, but remember, 70% of people don't have those anyway. Standard dose amoxicillin is fine for your standard garden variety patient. If you're really concerned about beta-lactamase production, like if this is a repeat infection or something, then you can go right to amoxicillin clavulanate, which is marketed as Augmentin, and that is amoxicillin augmented with a beta-lactamase inhibitor. And it's still the same standard dose of the amoxicillin component. That's what they recommend as initial therapy. Now, if you are concerned that your patient has drug-resistant strep, like those things from that little pink box, like maybe the patient is under 2 or over 65 years of age, or they have had antibiotics for any reason in the last month, or any of the things that were on that slide, you can go right to high-dose amoxicillin component. That would be not 500 TID or 875 BID. This would be 3 to 4 grams a day in divided doses. So, like, you might give the patient 2 grams of Augmentin morning and 2 grams at night. That's a lot of Augmentin, but that's what's needed for drug-resistant strep. Now, it's also going to give them jet-propelled diarrhea for a week. And for the person who says, well, why don't we just give everybody this just to make sure? Let's just make sure and cover it all. Just making sure and just covering it all when there's no clinical reason to do so is not the standard of care these days. That's old school. There was a time when we would shotgun people and just give them everything, test them for everything, and give them everything to cover everything. But those days are long over. Now we medicate based on the evidence. So we only use high dose amoxicillin when there is clinical reason to think that somebody would have drug resistant strep. Now, if the patient recognize that those first treatments center around amoxicillin. If the patient has a beta-lactam allergy, most beta-lactam allergies are to penicillins. If the patient has a beta-lactam allergy, well, then you can't use amoxicillin. So what are you going to do? Well, you ask yourself, was that allergy anaphylactic or not? Beta-lactams are so good for strep that we really want to use them whenever we can. So even if the patient's allergic to amoxicillin, if it's not an anaphylactic amoxicillin, then we can give them a cephalosporin. Cephalosporins are structurally very similar to penicillins. They're not identical, but they're structurally very similar. But we can safely give those, and that's our best bet to cover drug-resistant strep. And there are several options shown here on the screen. Now, if the patient has a history of a penicillin allergy and that allergy is anaphylactic, well, then we don't really want to go there with the cephalosporin because they are structurally similar. Cephalosporins are beta-lactams too. It's just that it looks just a little bit different. But if they've had an anaphylactic history, we don't want to take that chance. So then we can switch it up a little bit, and this is where the fluoroquinolone comes in. And this is why that FDA advisory was mentioned on that last slide. Current recommendations for treating the patient with sinusitis who has an anaphylactic history to a penicillin does suggest the use of a fluoroquinolone. Right now, it suggests the use of a fluoroquinolone, and that's what you would do in this circumstance. But we're really seeing a trend away from fluoroquinolones, and probably when this guideline is updated, the fluoroquinolone will come off of it. But right now, this is what we got. If you're worried about a beta-lactam allergy that's anaphylactic, you can't use a cephalosporin. So we've got 3 options here: levofloxacin, moxifloxacin, or doxycycline. Doxycycline is actually the alternative for the patient for whom you would typically use amoxicillin or even standard dose Augmentin. Doxycycline has a whole different mechanism of action. It'll cover strep, but not drug resistance. It will cover H flu and it will cover beta-lactamase producers. So the only thing doxy won't cover is drug-resistant strep. So if you really, really think your patient has drug-resistant strep and an anaphylactic history to a penicillin, then you've got to go with the fluoroquinolone. The levofloxacin, the moxifloxacin, they're like the big gun. They'll cover all of it. Strep, drug resistance, H flu, beta-lactamase producers, they'll cover it all. But you really only want to use it when you have to. Yeah, this gives you more information about what I just said. The doxy, like without going far afield into antibiotic mechanisms of action because I just don't need to flood your brain with that right now. It's not, it would confuse you probably more than anything else. But Doxy is not a beta lactam drug. So it's just trust me when I tell you that it can cover everything except drug resistant strep. Whereas the fluoroquinolones, they are the big gun. They're very powerful and they have some very powerful side effects too. So when you have to use them, you use them. But if you have alternatives, we use alternatives. Do keep in mind that doxycycline, one contraindication that's really important is that we don't use it in pregnant women and we don't use it in kids under 8 because it has a tendency to concentrate in bones and in teeth and can really discolor the teeth. There is one exception, and sometimes this is a board's question. Although we don't use doxy in pregnant women for any other reason, or little kids for any other reason, we do have to use it for rickettsia or inhalation anthrax because there's just nothing else that will cover it. Just absolutely nothing else. But those are the only two exceptions. And then finally, at the end of this table, what about the patient that you treat and then it doesn't work? So this is the patient that comes back 3 to 5 days later after taking the antibiotic you gave them and saying it doesn't work. It doesn't work. They're back looking for something else. Well, whatever we gave them, it didn't cover the affecting organism. So now we have to change it up. So, like, if you already had them on amoxicillin or standard dose amoxicillin or augmentin, you just go right up to the high dose augmentin. If you had them on a cephalosporin, now you could go to an injectable cephalosporin. If you already had them on any of that and it's severe, then we have to go to the fluoroquinolone. And if you already had them on the fluoroquinolone and they come back a few days later and they're no better, then you really have to confirm your diagnosis. Maxillofacial CT scan to make sure you're really dealing with bacterial sinusitis. And if you aren't, you start from scratch with your diagnostics. And if you are dealing with bacterial sinusitis and a fluoroquinolone hasn't gotten it, chances are they have like a nidus of infection that's stuck in some anatomical area and they need to be referred to ENT. And that's that. And I think that's all I have to say about that. And like I said, that's a little bit far afield than what you need to study for your boards, but Dr. Fitzgerald always includes it in the course because people just always ask us about it. All right, next page, next topic. Knowledge of the most common drug-drug interactions is critical. We overuse the word critical, but is important to NP certification and clinical success. The reason is that drug interactions can be a safety issue, and safety issues are an important thing to address in your review. And that's why now we have to briefly review the concepts of cytochrome P450 drug metabolizing isoenzymes. I will tell you, I have not taken a certification exam in the last 15 years that didn't have at least 2 questions about cytochrome P450 enzymes. So it's definitely worth taking some time to review. And it's a really simple process. When you give a patient a medication and they ingest it, inject it, whatever, when somebody puts a drug in their body, the body recognizes it as not belonging there and it wants to get it out. And the way that the body gets it out typically is to change the formulation, to change the chemical structure of that drug so that it can be excreted by the kidney. It makes the drug water soluble. If you want to excrete something, you have to make it dissolve in water and it just gets flushed right out with the kidney. So there are several ways to make something water soluble, but the most common in the body is a cytochrome P450 enzyme. P450 is like the name of a family of enzymes. There's a bunch of particular isoenzymes like 3A4, 3A5, 3A7, 2C9, 2D6, etc. They're all like first names and the last name is P450. And these enzymes can all just very subtly change the chemical structure of a drug. You just change one little thing, one little element, and it will make it water soluble and be excreted. And so that's how most drugs are eliminated. There are 3 terms you want to be familiar with: substrate, inhibitor, and inducer. And this is the way they go together to make sure patients stay safe. 2/3 of all prescription medications are substrates of one or more cytochrome 50, P450 isoenzyme, meaning that 2/3 of all medications are metabolized by one or more isoenzyme. If a drug is a substrate of a P450 isoenzyme, it is subject to metabolism by it. And there's, like I said, 2/3 of all prescription drugs. Many of them are metabolized by the 3A4 isoenzyme. In fact, half of all drugs are metabolized by that one enzyme alone. And I'm sure you're familiar with many of the drugs. Some examples are shown here. Viagra, atorvastatin, which is Lipitor, simvastatin, which is Zocor, alprazolam, which is Xanax, in case you never heard of it, lots of others. Half of all prescription medications are metabolized by that one isoenzyme. No problem. And then, of course, we have many other isoenzymes, and some of them are listed here, and lots of drugs are metabolized by those too. Some drugs are metabolized by more than one isoenzyme. So if a drug is subjected to metabolism by an isoenzyme, it's a substrate. The problem is that some other medications act as inhibitors of those enzymes. So there are some drugs that will actually inhibit the activity of one or more P450 enzymes. You see where this could become a problem? Say the patient is taking Xanax, right, which is a substrate of 3A4, and then they take another drug like clarithromycin, which is an inhibitor of 3A4. Well, the clarithromycin inhibits 3A4, so 3A4 is not available to metabolize the Xanax. So the next time they take another dose of Xanax, the one they took before is still there, and suddenly they're stoned. So if you give a substrate and an inhibitor simultaneously in the same patient, the inhibitor inhibits metabolism of the substrate can rise to toxic levels. And there's many examples all through the literature and a couple of them given here. So that's not good. But wait, there's more. Other medications are actually inducers of certain cytochrome P450 enzymes. So now it can go in the other direction. Suppose the patient's taking a substrate and the substrate's doing its job. And then they take another drug that induces the enzyme that metabolizes the substrate. Well, now the substrate is getting metabolized too fast. It's getting metabolized at an exaggerated rate. So now the substrate doesn't even get to reach therapeutic levels. It doesn't even get to do its job. So now, like just the opposite, if you take an inhibitor of the 3A4 enzyme, the patient never even feels their Xanax. They never even get relief of their anxiety because they metabolize it too fast. And there's examples of all of these. The one that's here about the inhibition is St. John's wort. So St. John's wort is a nutraceutical that is widely espoused, as a nutraceutical antidepressant. Patients can buy it without a prescription. They can get online and do it, and it induces the 3A4 enzyme. The problem is that 3A4 metabolizes 50% of all prescription drugs. So the patient is taking any other drug for anything, like Lipitor for high cholesterol, or Xanax for anxiety, or Viagra for erectile dysfunction, and then they take St. John's wort that they buy on a website somewhere. The St. John's wort induces metabolism of all those things, and they just can suddenly stop working. Another little factoid is that 3A4 also metabolizes combined oral contraceptives. So imagine the catastrophe here. A patient's on combined oral contraceptive, and then they take St. John's wort without telling you, or worse yet, you advise it, forgetting the reaction. The St. John's wort accelerates metabolism of the contraceptive. They have contraceptive failure and wind up with an unplanned pregnancy. So the thing you want to really, commit to understanding here is the relationship between substrates and inhibitors and substrates and inducers. Give two substrates at a time, who cares? It's like two people trying to walk out the door at the same time. Just open the door wider and let them go out. But if you take a substrate with an inhibitor, it's like the substrate's trying to walk out the door and the inhibitor closes the door in its face. And then you keep taking more doses and they can't excrete and they can get toxic. On the flip side, a substrate and an inducer, well, the substrate might be headed for the door and the inducer just shoves it out too soon, and it never gets a chance to do what it's supposed to do. That's the relationship, and that's the kind of questions that you are likely to see. Little scenario. Mrs. Jones is taking drug X for whatever problem. It is a substrate of the cytochrome P453A4 enzyme. If she were to take an inhibitor, the concern would be A, toxicity of substrate, B, subtherapeutic levels of substrate, C, toxic levels of inhibitor, D, subtherapeutic levels of inhibitor. And the only answer that would work would be elevated substrate. So that's what you need to know for your boards, and you also need to know it for your practice too. When you prescribe things on electronic medical record, it's like you try to prescribe something, and every time you get 5,000 red exclamation points that say "Danger, danger, Will Robinson, don't do it," and you become very quickly desensitized to those little automatic alarms because they just pop up everywhere. So you really do need to develop a knowledge base of things you can prescribe together and things you can't. And it can seem overwhelming at first, but you will very quickly develop patterns. We all tend to use kind of the same stuff. Like most of the patients you see will have a handful of insurance plans that you encounter, so you know who approves what, and you'll very quickly get to know, which antibiotics you're going to use, which ACE inhibitors you're going to use, which statins you're going to use. So it doesn't take long to figure it out. But in the beginning, you do have to develop that knowledge base. There is a table, and I think the link is also in your handout of some just cytochrome P450 interaction tables. I mean, the list is always growing, and don't feel like you have to memorize it. It's certainly not for your boards and not even for your practice. Just know that when a new drug comes into your world, you want to look it up and see if there's any contraindications. All right, so Phil. Phil is a 45-year-old. No, yeah, Phil is. Oh, dear, I turned the page the wrong way. I was going to call Phil a well woman, but Phil is a 47-year-old man, and he's being evaluated for acute rhinosinusitis during an urgent care visit. Which of the following findings would be most indicative of acute bacterial rhinosinusitis? Select two. All right, most indicative of bacterial sinusitis. Purulent nasal discharge, persistent cough, initial symptom improvement and then worsening of symptoms, or unilateral facial pain. I mean, fact is, any of these could be associated with bacterial sinusitis, but the best answer, the ones that are most indicative, remember, initial improvement of the primary problem and then worsening as the secondary problem emerges, and unilateral pain as one sinus becomes infected. Phil has a history of hypertension. This is Phil from the last question. Phil has a history of hypertension, dyslipidemia, and depression. He states, I'm on a big list of medications, but I'm not sure of all the names. When developing a treatment plan for Phil, you consider prescribing the following course of an oral antimicrobial. 10 days of clarithromycin, 5 days of azithromycin, a 7-day course of amoxicillin, or a 7-day course of cefpodoxime. Okay, well, go back to our guidelines here, right? Remember that we start with amoxicillin, augmentin, and then we have alternatives if there's a penicillin allergy. In this case, he doesn't have a penicillin allergy, which right off the bat makes amoxicillin the only evidence-based guideline answer. And just on a side note, you would never give somebody clarithromycin when they say, I'm on a big list of medicine and I don't know what they are. That's like drug interaction waiting to happen. In this case, you wouldn't use clarithromycin anyway because it's not an indicated drug. But just as an aside, when somebody says, oh, I don't know, I take this and that, a yellow pill, a blue pill, a purple pill, you don't want to give them something that is notorious for interaction the way that clarithromycin is. So that's the sinuses. And again, you can take those principles and apply them anywhere in the head and neck. But now we're going to move on, I think, to the ear, the rest of the head, beginning with the ear. All right, so you got a nice picture of a tympanic membrane, and it's nice and clean, and you can see the cone of light and little bones behind the, what do you call it, tympanic membrane. So nice picture. All right, let's talk about Sandra. Sandra is a 45-year-old well woman diagnosed with left-sided unilateral acute otitis media 10 days ago and treated with an antimicrobial. And she is seen today with a report of resolution of ear pain, but with persistent sensation of ear fullness and diminished ability to discriminate speech in the affected ear. Anticipated findings on today's physical include what? Erythema of the ear canal, Weber test lateralizing to the affected ear, discomfort on tragus pull, or anterior cervical lymphadenopathy on the affected side. Well, again, if you know the answer, you know it. And if you don't, we have to take a moment to analyze it here. So the question tells you she had left-sided acute otitis media. She got an antibiotic. The pain is gone, but she has ear fullness and diminished discrimination of speech. So you ask yourself, what does that mean? And the answer is otitis media with effusion. Many times after acute otitis, after the acute infection is resolved, there is an effusion. A serous effusion remains just as part of the healing process. So if we accept that she has an effusion, anticipated finding today include what? Well, all right, so let's just say you don't know. Well, she had an infection, now it's resolved, and now there's a serous effusion. Erythema is expected with acute infection. Like you expect erythema in general when something is acute. Wouldn't expect that today. Weber test lateralizing to the affected ear. Well, the Weber test is that tuning fork test. Remember that you whack the tuning fork and you put it in the middle of the patient's head, and you expect that they can feel sound lateralizing to the ears. And usually it's to both ears because both ears hear more or less the same way. But when the Weber test lateralizes or it's felt more strongly in one side, that usually means that on that side, air conduction is disturbed. Air conduction doesn't work right, so bony conduction is more pronounced. Well, you would expect that with an effusion. When somebody has an effusion, it distends the tympanic membrane from the inside, and the membrane can't bounce those sound waves the way it's supposed to. So air conduction is inhibited, which means bony conduction is going to be louder. So B could work, but we look at everything. Discomfort on tragus pull. Again, discomfort is more of an acute pain or acute infection phenomenon. You wouldn't expect anything to be hurting now. And anterior cervical nodes are a no because with ear infection, with acute otitis, anterior nodes are the first thing to pop out and they're the first thing to go away when you give them antibiotics. So you definitely wouldn't expect it now. So the thing that you'd expect to see now is the Weber test lateralizing to the affected ear. That suggests that the tympanic membrane is distended, interfering with air conduction, allowing bone conduction to dominate on that side. So, Sandra's hearing loss is best described as what? And I mean, it actually can get, these words can just get a little mixed up sometimes, but this is a conductive hearing loss because when we talk about conductive hearing losses, we're talking about air conduction. She has an air conduction problem. Sensory neural is like the cranial nerve. That's cranial nerve 8 inward. Auditory processing is a whole different, I mean, again, that's a nervous system phenomenon. That's in the brain. And mixed origin could be a combination of both conductive and sensory neural, but Sandra's problem is conductive. She had an infection, it got better, now she has an effusion, the tympanic membrane won't bend, and she can't do air conduction for a while. Pretty straightforward. Now, finally, there's going to be a question about treating her, and the reminder is knowing when you shouldn't prescribe is as important as knowing when you should. So when Sandra says, what do I do now? I have a fullness and I can't hear right. What do I do now? Are you going to say she needs a second course of antibiotics? Are you going to say she should have a short course of a steroid? Are you going to say that ear fullness is an anticipated finding or just turf her right off to ENT? And what you're going to do from an evidence-based perspective is educate her that this is part of the normal healing trajectory. And when that effusion absorbs, her hearing and the sensation will return to normal. You will see providers give people steroids for this, and it will help, but the risk of a systemic steroid is not worth the comfort associated with a normal healing process. So it's not advised from an evidence-based perspective. Just reassure her, if it's still there in 4 weeks, come back and see me, but I'll bet it won't be. Now, in your handout is a picture of a big ear, and it's got a line right down the middle ear, separating the outer ear from the inner ear. And it's just a reminder that conductive hearing losses, again, are things interfering with air conduction. And some examples are shown here. And conductive hearing losses are generally reversible. Once you get rid of the blocker, so to speak, the hearing returns to normal. Sensory neural hearing losses are it's a nervous system problem from the inner ear in, and they're usually not reversible. I mean, you can improve hearing in some circumstances with devices, but sensory neural hearing losses are not reversible in the way that conductives are. Now, table 4-7 is a table that I wish I had something to offer you. I just don't. If you've lived in the same world I have for the last 5 years, goodness knows you certainly have been assaulted, especially if you were in school in the COVID era. You know very well the common differences among COVID, the flu, and the common cold. So far, I swear I have not had one person come back and tell me there were any COVID questions on their boards. Like, I just can't believe it. I mean, it has been 5 years now. It's totally time. But I haven't had that feedback yet, but it doesn't mean it's not coming. What I would tell you to an absolute certainty after many years of taking these boards is that they really don't dabble in controversy or things that are not well established. So if you get a question about COVID-19, it's very likely to be making the differentiation on commonly accepted principles, like the fact that unlike the other two conditions here, with COVID, you usually don't get symptomatic until more than 5 days of exposure. That loss of taste or smell are very closely associated with COVID. That COVID is the only one that has any meaningful reports of shortness of breath. The flu and the common cold don't. As far as runny nose and stuffy nose and stuff like that and sneezing, much less common with COVID than the others. So I'm sure that you are familiar with these, but you just might take a minute to go through that. And one of your online chapters also has just some practice questions about COVID. But I am certain that if you have COVID questions, they're going to be like on really commonly accepted, indisputable things. All right, now we're going to switch gears finally to wrap up this general combo with the allergic piece. I said that when you see somebody with eye, ear, nose, or throat problems, it's either allergic or infectious. And we spent a lot of time talking about infectious, but now we need to look at the allergic piece because that's an issue too. And again, these concepts apply anywhere in the head and neck. Now, allergic rhinitis, it's got a distinct presentation, and a bunch of symptoms are listed here. But the one thing that you really can take to the bank is that allergies itch. If itching is a prominent feature of what the patient's complaining of, the nose keeps itching, or even if they don't even know it, but they sit there and constantly scratch it while you're seeing them, it is very likely that they're dealing with an allergy. Allergies itch. And they do tend to be in response to an allergen, whether it's seasonal or environmental in the house or whatever. So when somebody comes to you with allergies, it's because they want to be treated for it. And that's what table 4-8 is all about. They want to be treated. And so the first thing you have to address, even though it's not why they're there, but you have to do it, talk about avoiding the allergen. You just can't get great control of allergies if the patient continues to be exposed to the allergen. And believe me, it happens all the time. People are like badly allergic to cats, but they have three of them because their kids love them so much, or whatever. There's things they're allergic to, and they're in their world and they can't get rid of it. And if that's the case, it probably won't kill them, but it's definitely going to make it harder to get control. So setting expectations is enormous. There are things people can do. We know that outdoor allergens tend to be they hit people hardest in the morning hours. So if they like to do things outside, like I don't know, garden or walk or run or whatever, do it early in the evening. Try to avoid it in the morning. If they have carpet in the bedroom at least and in the house entirely, get rid of as much of it as they can. Get rid of those cloth curtains. Maybe put up something plastic that dander and dust don't have a tendency to settle on as heavily as cloth. Like wash the sheets in hot water at minimum a couple of times a week. There are things that people can do, and they just need to know that if you don't make any effort about environment, you're just not going to control this 100%. But what most people are coming to us for are drugs. So in the world of allergies, and I guess in the world of many things in healthcare, we have controller therapies and rescue therapies. And the goal really is typically control. We'd much rather control something than chase it after symptoms start. And in the world of controller therapy, the intranasal corticosteroid is the drug of choice. Now, I know if any of you are working in allergy and immunology, you're probably cringing because there is controversy in the allergy world about the intranasal steroid. But from a first line primary care perspective, intranasal corticosteroids are the foundational controller therapy of allergies. There's lots of them available. They're available over the counter. They're not rescue. You have to use them every day as directed. And then after a week or so, you start to notice some improvement in your symptoms. Now, antihistamines are typically thought of as rescue therapy, but you can use them as controller therapy when you have a known anticipated exposure. Like, say somebody's allergies are really not that bad, except that every Saturday they go to their in laws for dinner, and their in laws have 4 cats, and they're allergic to cats. Okay, well, an hour before dinner, take a squirt of Astapro and then go have dinner. And that's your controller therapy in that circumstance. They don't have to take Flonase every day of the week for that one time that they're going out for dinner. For the person who needs reliever therapy more often, or the person who's on the intranasal steroid and they still have some breakthrough symptoms at bad times, the antihistamine is considered the classic rescue therapy. And we have oral antihistamines, we have otic antihistamines, we have what do you call it? Nasal antihistamines, we have ophthalmic antihistamines. Remember, least invasive. So if it's just that they have nasal allergies, use that inhaled antihistamine. If their allergies are really, really hitting hard around the eyes, you can use eye drops like, oh God, a Zatador, like those sorts of ocular antihistamines. They're awesome. If the patient has multiple symptoms in multiple areas of the head and neck, then you can use an oral antihistamine. We have one for all occasions. Yeah, and some of the examples, a Patanol, that's what I was thinking of. Patanol, Pataday, these things are great. Zatador is another one. But just keep in mind, the inhaled steroid is your classic controller therapy. The antihistamine is your classic rescue therapy. And less expensive, less invasive, the better off you are. So if it's just the nose, squirt it in the nose. If it's just the eyes, use the eyes. Now, some adjunct options here, like leukotriene modifiers like Singulair, I expect you're familiar with it. It's been around for a long time now, and I mean, still out there. When Singulair first hit the scene, it is a controller therapy. It's not a rescue therapy. So it's not like you say, oh, my allergies are really bad. Let me crack some Singulair. Um, but in the beginning, when it first hit the market, like we just gave it to everybody, even little kids, we have little Singulair sprinkles to put in their juice. But as the years have gone on, we've learned more and more about potential neuropsychiatric symptoms, and they're listed here on your slide. So now it really isn't advised for most people. I mean, people do take Singulair or any leukotriene modifier, but there is a potential adverse effect profile that you should be familiar with and risk benefit. I mean, if you have somebody who already has a psychiatric diagnosis, or even if it's not diagnosed, but they tend to be aggressive or agitated or highly irritable, this might not be the drug for them. The risk often um, outweighs the benefit. But it is very inexpensive, and for people that don't have other options and not a high risk profile, you can totally consider it. Systemic corticosteroids, again, the risk usually isn't worth the benefit. Systemic steroids can do some pretty significant things to the body, like make your bones fall apart and blow up your pericardium and stuff like that. For allergies, it's usually not warranted. There are people whose allergies are really, really, really bad, and they just don't have access to more expensive contemporary therapies. And maybe once a year or something, we'll give them a long acting steroid injection, but it's definitely not routinely advised. It's very much a non textbook case by case basis. If you can't get somebody relief with a combination of allergen avoidance, intranasal steroids, and rescue therapies, then the thing to do is send them to allergy and immunology for targeted immunotherapy. Like there's lots of options in the world of allergy that are really effective for your most severe patients. That's why I said if anybody listening works in allergy, you're probably having a cow at what I'm saying. But again, you see the people that are most severe and that we can't help with these more conservative therapies. But for your boards, inhaled steroids as controller, antihistamines as rescue. So let's look at Hank. Hank is a 58-year-old man who presents with a chief complaint of bilateral itchy eyes occurring intermittently throughout the year. Exam reveals 20/30 vision on the right eye, left eye, and both eyes with corrective lenses. He's got bilateral hyperemic and bulbar and palpebral conjunctiva and a small amount of rope-like pale yellow discharge. These findings are most consistent with what? Well, we're talking about allergy, so it's probably allergies. But even if we weren't talking about allergies, there are several giveaways here. It occurs intermittently throughout the year. It presents as bilateral. It itches. He's got itchy eyes and that ropey, stringy discharge. They all conspire to sound like allergy. It's got allergy written all over it. The most appropriate therapeutic option for Hank is what? Well, if we agree that he has acutely symptomatic ocular allergies, would you think use of an ocular antimicrobial? Or would you think advice on purchasing a lubricating eye solution, use of an ocular antihistamine, or emergent referral to ophthalmology? Now remember, we have agreed that he is acutely symptomatic of his eyeball allergies, and so an ocular antihistamine is what we want to do for Hank. Appropriate pharmacologic management options for allergic rhinitis in a 29-year-old woman who is a daycare provider include which of the following? All right, so yes or no to each thing here. Short-term use of a decongestant nasal spray? Sure. Oral first-generation antihistamine? Nope. Intranasal corticosteroid? Yep. Oral second-generation antihistamine. So here's the story. She's a home daycare provider. She's taking care of other people's children with allergic rhinitis. And the question is for each one of these, yes or no, could they be included in appropriate pharmacologic management? A short-term decongestant nasal spray, absolutely. I know you've probably been told about, oh, don't get addicted to nasal spray. People be scoring nasal spray in the back alley, trying to squirt up. Yeah, we don't want people using it for the long term, but short term for symptomatic allergies, absolutely, it's fair. The first generation antihistamine is the no-no because she's taking care of other people's children. So, we don't want to be making her tired. That's a bad plan. Um, the intranasal corticosteroid is a mainstay of controller therapy, so that's an absolute yes. And an oral second generation antihistamine may very well be part of her plan of care. So, yeah, any of those other things may or may not be used. We're not saying that you must use them, but any of those other things may or may not be used for any given patient. But the thing we must avoid, the no, is the oral first generation antihistamine. Edgar is a 75-year-old man with a 60-pack year history of cigarette smoking and COPD who presents with a chief complaint of a sore on the base of his tongue. The lesion has been present for a number of months, remaining relatively stable in size and is not painful. Physical examination reveals a single, painless ulcerated lesion on his tongue and is accompanied by a firm, non-tender submandibular node. His current medications include inhaled corticosteroids with a long-acting beta agonist. This clinical scenario is most consistent with syphilitic chancre, aphthostomatitis, squamous cell carcinoma, or non-ulcerating oral candidiasis. Well, I'll tell you. Let's take a look at Edgar here. He's got a 60-pack year history. That tells you right off the bat he's got something bad wrong. Your exam does not like smokers. Anybody on your exam who smokes is going to have a serious illness. There's no little benign viral URI for smokers on your test. So look for something serious. That's one. Number two, he's got a sore on the base of his tongue that's been there for months. The size is stable and it's not painful. Any stable, non-painful ulcerating lesion is very concerning for squamous cell carcinoma until you rule it out. The presence of a non-tender, firm submandibular node is even more concerning because cancer is often accompanied by non-tender regional lymphadenopathy. And that's it. So it's not a syphilitic chancre because although they are painless chancres, they do tend to resolve pretty quickly. And if there was lymphadenopathy, it would be acute and it would hurt. This is not aphthostomatitis. Those ulcers hurt. Um, and this is not oral candidiasis because that does not ulcerate. It's just like fungus on your tongue. What this is suspicious for squamous cell carcinoma, and we really need to regard it as squamous cell carcinoma until we rule it out. So the next step in Edgar's care should include what? If you think that his presentation is consistent with squamous cell carcinoma, then clearly he needs to be referred for biopsy. Really, but the real giveaway there was a smoker. I'm telling you, your exam is very prejudiced against smokers. You can read more about oral cancers in your workbook, and you'll see that HPV is a contributing factor in the overwhelming majority of cases. It's like every time you turn around, we find new cancers that are caused by HPV, which is why the HPV vaccine is so hideously, enormously important. All right. Then we have ocular conditions. So an ocular conditions discussion begins with when to measure visual acuity of the eye. Visual acuity of the eye is considered the vital signs of the eye. And although there may be many times when you would do it, there are two that you must have visual acuity on the chart. The first one is any comprehensive physical exam, any age. If you bill a wellness exam, there should be a visual acuity on the chart. I don't know how much you learned about billing in school. Usually there's just not enough time to go into that to any oomph degree, and you pick up what you can from one lecture or your preceptor. But don't worry, as soon as you get a job, you'll learn about it because now you have to generate your own income in the practice, or you have to generate income. So you'll learn about billing. But one of the things you'll learn right off the bat is when you code your bill, it will be either, I mean, in typical practice, you will code either for a wellness visit or a sick visit, right? Sick or wellness visit. Wellness visits pay more. They pay more because they're expected to take longer, because you're expected to do more. You're expected to do a comprehensive history and physical. And that comprehensive physical should be documented, including the eye exam. Sick visits don't pay as much because you don't have as much time because you usually focus on a specific complaint. So any comprehensive physical, and this is from the time like that brand new baby out of the hospital. Like if you work in a real family practice in a rural environment or something, and you do see babies right out of the hospital, they're like 5 days old, come in for their first visit, you do a visual acuity assessment. There are two things you do. You check the red reflex to make sure they have one. If they don't have one, you're concerned. And the other thing you want to do is take like a little cotton swab, like a little cotton ball or a 2x2, and you gently lower it toward their eye and make sure they blink. They can't see a whole lot, and babies can't see very far like neonates, but they can protect their eye. And if they see something coming right at it, they should close the eye. If they don't close the eye, you're concerned about a visual deficit, and it needs to be reevaluated very quickly so that, I mean, with infants, their development so relies on sensory input that you want to identify any sensory impairment as soon as you can and try to get it corrected so that you can support their sensory motor development. So anyways, right out of the hospital, you test their visual acuity by dropping a little 2x2 or a little cotton ball toward their eye. And then, as they hit 2 months old, their eyes should be able to follow you across the midline or follow a toy or whatever. And then, they get old enough where you can put them in front of a pediatric Snellen chart and identify the pictures. Then they go to the real Snellen chart with the letters, and that's for the rest of your life until you're really, really old and have really bad cataracts. And then we do count fingers. You hold fingers 12 inches from the patient's face. My point is, every wellness visit should have a visual acuity. The other time that you should always have a visual acuity on the chart is with any eye complaint. Any eye complaint. And I know that sometimes they have, oh, they seem so benign, it just looks like a little, what do you call it? A little conjunctivitis or something. Because in school, when you learn about serious eye problems, it looks really bad and the pupil won't reconstrict and all that kind of stuff. But in real life, it's not nearly that obvious. Sometimes what looks relatively minor really is a significant problem. And one of the earliest ways you can tease out a serious problem from not is a change in visual acuity. So just you want to get in the habit of having your medical assistant with any eye complaint as they room the patient before you're even involved. They do the vital signs, have them do a Snellen chart. And you know how to do a Snellen chart, right? You have the Snellen chart on the wall somewhere. Every practice has one. And then 20 feet away, there's a piece of tape on the wall or on the floor or somewhere. And that's where you have the patient stand. They cover one eye and read the smallest line they can read. And it's not necessary to start from the top and go down. I've seen people do that too. You know, you don't have to say like E, F, P, T, O, Z. You have them start with the smallest line they think they can read, and they can miss up to 2 items on that line and it's still a pass. If they miss more than 2, they have to go up 1 line. And you're trying to find the line where they can miss 2 or less, and that's their visual acuity in that eye. If the smallest line they can read is labeled 20/40, they can see at 20 feet what the normal eye sees at 40 feet. You have them do each eye separately and then both eyes together. And honestly, you know, a lot of people don't realize they have a visual acuity deficit until you have them do that because eyes accommodate for each other really well. So, you know, if somebody has a bum eye, they think they have conjunctivitis in their eyes, you know, itchy, inflamed, whatever. They're going to walk around with both eyes open, presumably. I mean, most people do. And the other eye will accommodate for it. And they won't realize how poor their vision is in the affected eye until they actually have to cover the good eye and then still try to read something. So, any eye complaint, you want to have that visual acuity on the chart. And we just talked about how to interpret it. When answering an assessment question, yes, you need to apply your knowledge of normal and abnormal. That's absolutely true. So, you see a 55-year-old woman who presents for a health maintenance visit. She has long-standing myopia and newer onset presbyopia, both corrected with eyeglasses. She is normotensive and without ocular complaint. You anticipate the following on today's eye exam. So, what do you expect today on her health maintenance visit? Retinal arteries wider than veins? Then that's a no. That's a no. In fact, the eye is the only place in the human body where you have artery vein pairs, where arteries are thinner than the veins. In the eye, veins are thicker and darker in color, arteries are thinner and brighter. Everywhere else in the body that there's an artery vein pair, the artery is bigger. The aorta vena cava pair, the renal artery and vein, the femoral artery and vein, you know, all of them, the artery is wider except in the retina. So A is not true. You do not expect equal sluggish pupils. I mean, even if it's equal, in fact, especially if it's equal, sluggish pupils is no good. They should be brisk. Sharp disc margins is a normal finding, whereas lid ectropion is not. Lid ectropion might not be dangerous. It might even just be an age-related variant, but it's not normal. C is the only normal finding here, and that's what you would expect on a health maintenance visit. I don't think this is like necessarily the best picture. Let me get closer here and take a look. I mean, for sure, yeah, you see, like here's an artery vein pair, and the artery is thinner and brighter. I mean, it's not what they have arrows to. I don't know why arrows, but right here you have an artery vein pair, and the artery is thinner and lighter. The vein is darker and thicker. Same thing up here. Artery is thinner and lighter. Vein is darker. But I actually like this picture better. This one shows not only nice artery vein pairs, like here it's really obvious that the artery is thinner and lighter, but also you see the optic disc, which is really nicely defined. The optic disc is toward the nasal aspect of the eye, and the margins should be really sharp. You should be able to like take a Sharpie and just outline it like plain as day. And also, what's not as visible here, but there's also a central circular depression referred to as the physiologic cup, and it's created by the pressure of intraocular fluid that pushes on the optic disc and causes a bit of a depression here, like a teacup saucer, you know, where the saucer is round and then in the middle there's a little depression for the teacup. That's what the physiologic cup is like. And it should be depressed because the pressure in the eye should be a little higher than the pressure in the brain, so it looks like it's pushing back. If the pressure in the brain is elevated, like increased intracranial pressure, it'll start to push that saucer out and it's in the wrong direction. And I think we have a picture coming up. So match each vision alteration with the most likely etiology. All right, so we have 3 etiologies here: macular degeneration, untreated open angle glaucoma, and presbyopia, which is a normal age-related decline in near vision. And I didn't read the whole thing to you because I know that You're A, starting to fantasize about your break, and B, you're capable of reading. So, but we've got macular degeneration, untreated open angle glaucoma, and presbyopia. Which one of those is most likely to cause a gradual peripheral vision loss? So, like if a patient was looking at this picture, they really wouldn't see the outer edges of it very well. And that would be untreated open angle glaucoma because the greater pressure in the eye, which is what glaucoma is, increased intraocular pressure, it actually pushes down too hard. It deepens that physiologic cup and it changes the angle of refraction. And so it changes the way light is conducted into the eye and it narrows the vision. And the intraocular pressure is elevated. Whereas gradual onset blurring of near vision, when you get to that place where the cheater glasses from the drugstore, it goes from they help to they are an absolute requirement. Oh, what happened? There we go. Techno problem on my end. Anyway, that's presbyopia. This is age-related decline in near vision. And they say it happens, I don't know, gradually, but it didn't for me. It's like overnight. But you just suddenly get to that place where those cheaters you've been using to help for a while, just boom, you must have them now or it looks all like a blur. That's presbyopia. And finally, central vision loss is due to macular degeneration. Remember, the macula of the eye is that part of the eye that's lateral to the optic disc. It's the part of the eye that's like closer to the ear, the outer edge. It doesn't really have any vessels in it. It doesn't have any obvious nerves in it, but it's got several functions, and one of them is central vision. And when it starts to degenerate, the patient will lose central vision, and so they see best in the periphery. We used to screen for, like in primary care, we used to do a lot of little tests that just have been kind of a lost art. But the Amsler test is like a pack of cards. They're these square cards, and the one on the left side of your screen, the one with just the dot in the middle, used to be like you would put that in directly in front of the patient's line of vision, and then like on the like to the right in their periphery, you'd line up vertically some other cards that have various distortions on them. And you'd ask the patient to look directly at the normal one and then using their peripheral vision indicate what it looked like to them. And people with macular degeneration will often indicate some level of distortion. So they're looking at the one on the left, but they'll indicate that what they see looks like the one you see on the right. And that's called the Amsler grid. I don't know how many of you actually did those in your primary care rotations. And I think, finally, this is our last question, right? During a clinical encounter with a 78-year-old man with presbycusis is age-related hearing decline. During this clinical encounter with a 78-year-old with presbycusis, the NP considers that communication will be enhanced by all of the following except. What's the exception? Maintaining eye contact with the patient, ensuring the patient can see the NP's face clearly, playing soft music in the background, or providing adequate illumination in the exam room. What's the exception to enhancing communication? And the answer, of course, is the soft music. Ixnay on the music in the background. If you see a patient with presbycusis and you want to enhance communication, you will maintain eye contact, you will ensure the patient can see you clearly, and you will provide adequate illumination in the exam room. Those are all must-haves to ensure communication. But what you don't want to do is play that soft music in the background. That's not going to enhance anything. And that would be that. In your workbook, as always, there are a series of tables here at the end that you can peruse in your free time between now and test day. But that takes us to the end of the chapter. So we're going to go ahead and take your 15-minute break. It's 12 minutes after the hour. And so we'll come back at 27 minutes after the hour and pick up with common derm disorders for our last session of the day. All right, folks, it is time to begin our last chunk of time together for the day. I totally can't believe how fast this all went, but here it is. We're going to start off with commonly encountered dermatologic disorders. And if you're counting ahead, which most people do start doing at this time, I will also let you know what we're going to do before the end of the day. I just find that the unknown always has people wandering as we get toward the end. I mean, people will start counting pages and dividing it by how long it takes me to do average page, blah, blah, blah. So just so you know, we got 3 more chapters to do. Well, chapter 5 is, just sort of a regular, sort of a smaller chapter, and then 6 and 7. 6 is the thyroid gland. We're talking about one gland, one set of hormones. And then chapter 7 is the headache chapter all by its loneliness, and that too is a comparatively brief one. So and that's what we're going to do between now and the end of the day. And you can that way know what's going on. You can know the plan. You don't have to start counting ahead and flipping ahead and wondering how long it's going to be. I know, listen, when I'm in your shoes, I do the same thing. So I totally understand how it feels to be sitting and listening to somebody all day, even when you know it's important stuff and you really badly want to be on top of it for your boards. I mean, I know it's hard to sit and listen. So I just figure forewarned is forearmed, and that way you can, as best you can, pay attention to what we're talking about here, which is first up, derm. Oh, I accelerated the slide too fast. First up is principles of derm assessment. Now, again, I always say it because it's true. We're not studying for board certification in dermatology or any other ology. So don't get crazy, with the extremes here. There's a lot in the world of derm, but we're really going to take it from the basics. And derm assessment is an important part of that. I mean, a lot of times in clinical, your exposure to derm is use a steroid cream, and if that doesn't work, use an antifungal cream, and if that doesn't work, send the patient to dermatology. And there's actually some reasons why people do that, but we need to go just a little bit further. Really, assessment is the most important part. If you can get your derm assessment down, then you just look it up in a book and figure out what to do about it. I mean, I hate to sound overly simplified here, but again, entry level stuff. Side note, you will talk about acne in the adolescent section. Statistically, acne vulgaris is much more common in adolescents than any other group, so it's covered in that section, not this one, but it is indeed covered. But we're going to talk, like I said, about dermatology assessment. And the first reminder is that it's really not just about the skin. At least in the beginning of the assessment, you do need to make sure that there are no systemic symptoms. I know when you see a slide that says, oh, assess the whole patient, we always say that, and it sounds, very academic-y and nursey. But the thing about derm is that sometimes the derm symptom or sign, the actual skin thing, is the first symptom or sign of a problem that you can actually see, and that's what drives people in for care. They may have had months of feeling extremely fatigued, joint pain, loss of appetite, and all sorts of systemic symptoms. And they just kind of blow it off and be like, oh, I'm not going to worry about it, or oh, I'll make an appointment later. And then when a skin eruption happens and it becomes visible, that's the thing that drives them in. So it's really important to figure out if the derm complaint is the primary problem or if it's just a symptom of some other underlying problem. So I get that you don't have 5 hours to convene a seminar about their birth history and stuff, but you do want to do at least an abbreviated review of systems to include a true change in energy level, true fatigue, unplanned weight loss, joint pain, recent low-grade fevers, because these are all common indicators of another underlying autoimmune problem or systemic problem of which the skin manifestation could be just one symptom. Also, even if not, if you don't have anything else there, you do want to ascertain whether or not the patient is basically well and has no other signs or symptoms, because if that's the case, it's typically not an emergency. Sometimes with derm, unless you have a lot of good experience, you're not going to know exactly what you're looking at. And so you have to prioritize here. Is it an urgency or an emergency, or if it's not? If you look at a skin thing and you're really not sure what you're seeing, but the patient does have no other symptoms. They feel fine. They just thought they should get it checked out. At least you have a little time to investigate. You do a good assessment, you write a good note, and then you investigate it and tell the patient to come back in a week. When the patient is otherwise well, usually it's primarily a skin problem. And although, of course, you do want to treat it and you want to have a good answer for the patient, you have time to figure it out. Sometimes the patient is symptomatic, maybe not systemically ill, but they do have symptoms that need to be managed. And even if you're not entirely sure what's going on, you still need to manage the symptoms. Obviously, the itch is the most common. Now, what you're looking at here is shingles. We'll talk about that in a minute. But sometimes people will come in with this rash and it really itches and they swear they're not allergic to anything and no new soaps, lotions, potions, creams, or whatever. You're not entirely sure what's going on, but they're really itchy. As long as there are no other systemic symptoms, they're just really itchy. Yeah, give them the steroid cream. As long as you're sure it's not a fungal infection. Give them the steroid cream and then do a good assessment and tell them to come back in 5 to 7 days when you've had time to figure it out. Now, the reason shingles is here is that sometimes people in early shingles eruptions, which is not what you're looking at, by the way, the picture you see here is a classic shingles. You can't miss it. So, obviously, when you see that, it's right down the midline. You know what you're talking about. But sometimes people will come in with like one little vesicle on their arm or something, and they'll say, I know this looks like nothing. I can't even believe I'm here, but man, this really, really hurts. Consider it herpes zoster until you rule it out. That pain, it needs to be addressed. I'm not saying with oxycodone, but if they have a single vesicle or two little vesicles and they look benign, but they really, really, really hurt, assume it's shingles until you're sure it's not. And that means put them on an antiviral right away. And then finally, if the patient is truly systemically ill, there are these constitutional things like there's documented weight loss, fatigue, etc. If you don't know what's going on, this you have to escalate to a higher level, not just, oh, use a steroid cream and come back in a week. Whether the higher level is a more experienced clinician in your office or an emergency room or a dermatologist or whatever, if they are systemically ill and you're not sure what the derm thing is you're looking at, that needs to be escalated immediately. So, there are things that are potentially fatal, and you just don't have time to sit on it. So that's how we look at assessment. In addition to actually assessing the skin thing itself, the presence or absence of other symptoms is really important. Of course, whenever you're trying to make a diagnosis of anything, we have to consider age, ethnicity. This will all impact how things erupt. There are some conditions more common in youth, others more common when we get older. Many times with a rash, you can get a good sense of what's going on. If it starts at the head and moves down, or starts on the trunk and moves out. Like there's lots of things about the patient in general that will help clue you in. So that always matters. The example given here is acne vulgaris versus acne rosacea. They're two different things. I guess they're like cousins, although dermatology doesn't even think rosacea should be called acne rosacea, but it is. So we have to acknowledge it. So acne vulgaris and acne rosacea are both acne form conditions, but acne vulgaris is much more common in the younger population. Rosacea is more common like in the middle-aged population. Acne vulgaris tends to distribute on the outer aspects of the face, the forehead, the cheeks, the chin. Acne rosacea tends to distribute in the middle third of the face, like the nose and the proximal part of the cheeks, like you see here. So, all of these things do matter, as well as what the skin thing itself actually looks like. If you see a skin condition and you don't know what you're looking at, you always have to ask yourself if it's potentially contagious. And if you think it is, if you don't know, you have to counsel the patient that way. That doesn't necessarily mean they need to be quarantined, but at the very least, you want to talk to them about, spread, about sharing blankets and towels and, touching other things and that kind of stuff. You have to consider that something might be contagious until you're sure it's not. And if you're not sure what you're looking at, it's not always so easy. The example given for this concept is psoriasis versus impetigo. So, if you've never seen either one of them before, I can see where people can get confused. Once you see them, I think it's not confusing, but they both tend to appear crusty plaque-like. Psoriasis is classically described as silver, impetigo is classically described as gold, and you can see why when you look at the pictures. I mean, these are legit pretty realistic. But if you've never seen it before and you're like, "Ooh, which one is that?" Well, psoriasis is not contagious, but impetigo is. If you're not sure, consider it contagious until you rule it out. That's just really the point that we're trying to make. And that's the peripheral stuff. Now, when it comes down to the lesion itself, there's also a very important approach to assessment of the dermatologic condition of the actual manifestation. And one of the first things you want to ask the patient when they come to you with a rash or, whatever, you want to ask them where it first started and how it has traveled. I mean, most people don't like get a thing on their skin and come running in the next day. Usually, something will be there, it'll hang out a while, it will often spread. They get over the counter stuff and try to take care of it, and it doesn't work, and then they come in to see you. And because dermal cells turn over every 7 days, it can really change the way that things look. Like by the time you see it, it might not look the way it did when it first showed up, which is important for you to know. So if somebody comes in, say, with a rash on their arm, you want to know where was it the first one? Where did it start and where is the most recent one? Because you're trying to determine whether or not there are primary lesions and secondary lesions and what the primary lesion looks like. What the primary lesion looks like really matters. And in derm, the use of the term can be a little confusing. Primary usually means first, but in derm, primary, we're referring to what the lesion looks like when it first shows up on the patient. So if somebody comes to you with a rash that's been spreading down their arm for 2 weeks, the primary lesion is going to be the most recent one to show up, right? Because that's the newest one. So if I come to you and I say, oh, I figured I better come in, and this rash started up, like it started on my arm, but it just keeps going. I feel like it's going to be my whole sleeve pretty soon. And you look at the patient and they indicate it started up there by their shoulder. And then as the days went on, it just kept going down, down, down. And the last thing that popped out is down here around the wrist. That's the primary lesion because that's what it looks like when it first shows up. It hasn't been subjected to the passage of time or scratching, lotions, potions, alcohol, whatever people do, hydrocortisone, antifungal cream. The last one to show up is the primary lesion because that's what it looks like when it first appears. On the flip side, the one that where it started 2 weeks ago at the top by the shoulder, that's the secondary lesion. That's what it looks like weeks later after it's been exposed to a bunch of different things. There's two important pieces of information here. Number one, the primary lesion is going to be like correct identification of the primary lesion is going to be hugely important to figuring out the diagnosis. And then number two, it tells you how it travels on the body. Like I said, many skin conditions, they have a distinct trajectory. They start here, they go this way. They start down there, they come up. They start outside and move in. They start inside and move out. They don't occur on the arms, they don't occur on the legs. Like how these things move around really does matter. So looking at where it started and where it stopped, or rather, where's the most recent? The most recent is the primary lesion because that's what it looks like unaltered by any other external forces. And this is going to be huge in helping you figure out your diagnosis. So, an example of a primary lesion is here's our shingles guy again, is a vesicle. A vesicle is the classic lesion of shingles, or for that matter, varicella or HSV1, HSV2. It's a classic herpetiform lesion. And a vesicle is just an assessment finding. It's just the name of the primary lesion. A vesicle, by definition, is a serous fluid-filled lesion. In other words, filled with watery stuff that's less than 1 centimeter in diameter. It could be a symptom of shingles. It could be a symptom of herpes. It could be a burn blister. It could be any number of things. It could be contact dermatitis. But what makes a vesicle is it's a serous fluid-filled lesion less than 1 centimeter. That's a primary lesion, and one example is herpes. And then that primary lesion, whether you touch it or not, whether you leave it totally alone or you pick it, poke it, scratch it, whatever, just as a function of time, every 7 days or so, those dermal cells shed and new dermal cells come up. And a week or so later, that vesicle is going to look different. It's going to crust. The outer edge is going to fall off. The fluid is going to dry. Now, I don't know why there's a picture of impetigo here for a crust, but it is I mean, a crust is just a secondary lesion. It's just dried fluid, and it happens later. So the identification of a primary lesion is really an important part of identifying a dermatologic disorder. Learning the language of derm really is important. So many times, when people have rotated through my office over the year in clinicals, I see them going way down the wrong road because they don't identify the primary lesion the right way. What I learned about derm, which was 30 years ago, was from a dermatologist who she taught me to protect herself from me consulting her all the time. When I was first an MP, my first job was in a hospital. I basically functioned like a house resident. And a lot of my patients, like, as soon as they started to feel better, they would start looking at stuff on their skin and be like, "Oh, I never got this checked out. What's this? What's that?" And of course, I had no idea. So I would consult dermatology. And thankfully, she was very nice, the dermatologist. And she would come see the patient. And then after I started consulting her like almost every day, she, like all the other specialists, was like, "Sally, okay, like you can't consult us every day. So let's teach you some things here." And what she taught me was that in order to identify derm disorders, you have to, in addition to the history and the age and all that, when it comes to the skin thing itself, you have to identify correctly what's referred to as morphology, configuration, and distribution. And your book doesn't say it quite this way, but it does say the same thing. Morphology, configuration, and distribution. If you can correctly identify those three things, then you can go to any reference, which now is Google. 30 years ago, it'd be a book with tables in it, and the tables, like you'd look at the labels for morphology, configuration, distribution, and then run your hands down, and where they intersected was a list of your differentials. But now you could just Google it. Morphology is the primary lesion. Morphology is the primary lesion. Morphology, study of shape. So vesicle, papule, pustule, macule, nodule, purpura, whatever. That's your primary lesion. That's morphology. That's the first piece. If you don't correctly identify the morphology, you're going to just go way down the wrong lane. So question 1 in your handout is an exercise in reviewing some morphologies. Not all of them. It's not 100%. But this is a good starting point, and if this is something you really need to study, if you're really, really sort of floundering on morphologies, you probably have a good book or a good lecture from school that you can go back on. But here's a good starting point. So question 1 says, identify the following types of skin lesions with the corresponding description of a classic common presentation. Okay, so you see the 6 of them: macule, papule, bulla, cyst, wheal, and purpura. The first picture in your book: single uniform brown colored, slightly raised, irregularly shaped, defined borders, 6 millimeters in diameter, and this 45-year-old says that mole's been there for years, hasn't changed. What's that? It is a papule. By definition, a papule is a raised, firm lesion less than 1 centimeter. If you close your eyes and ran your finger over this, you'd feel it. You'd know there was something there, and it would not feel like it had fluid in it. Again, this is not a diagnosis. This is just an assessment finding. It's the primary lesion. It's the morphology. A papule can be a benign nevus. It can be a malignant melanoma. It can be a molluscum contagiosum. It could be a basal cell. It could be 100 things. But if it's raised and firm and less than 1 centimeter, it's a papule. Whereas single, flat, non-palpable, irregularly shaped, half a centimeter wide, this is a macule. A macule is a change in color. It could be hypopigmentation, it could be hyperpigmentation, it could be erythema, but the thing is it's not palpable. If you close your eyes and ran your finger over it, you'd never know there was anything there. Like, I don't know that I would advise closing your eyes and running your finger over your patient's cheek. That could totally not go well if you did it. But if you did, you wouldn't know that there was anything any different there, unlike the papule, which you can feel as being raised. Conversely, single, firm, smooth, raised, dome-shaped, fluid-filled, flesh-colored, and it's 1.5 centimeters, and the lady says, "Ooh, a smelly liquid leaks out of this when I push on it." That's a cyst. What makes a cyst is that it's an encapsulated collection of whatever. This is a dermal cyst. That smelly liquid is a bunch of keratin cells that were trapped in there, and because they were trapped, they just died off and started to liquefy, and they sting, like any dead cells would. You can have cysts anywhere. What makes a cyst is that some part of the body becomes irritated, and then it walls itself off from the rest of the body as a protective mechanism, which is actually a very good idea. And so you can have a synovial cyst in your hand or your wrist. You can have a bony cyst like Eberden's nodes or Bouchard's nodes. You can have renal cyst and hepatic cyst. And you can have sebaceous cyst and keratin cysts. They're encapsulated. If you really want to get rid of this, you have to open up the skin, take out the entire capsule, and then put the skin back together. Whereas a single serous fluid-filled lesion greater than 1 centimeter, remember a vesicle is a serous fluid-filled lesion less than 1 centimeter. This is greater than 1 centimeter. This is a bulla. And again, a bulla can be many things. It's just a primary lesion. Flat, non-blanchable, meaning when you push on them, the color doesn't change. Confluent, purple-colored, irregularly shaped lesions, and they're all over the place here. And for this lady, they showed up after chemo. This is purpura. Purpura means something bad is going on. If you see purpura, you need to refer that patient usually to an emergency room. Even if they seem okay just that minute sitting there, take it from the voice of experience. Don't let it fool you. When somebody has a purpuritic rash, something bad is going on. What's really concerning about this are the size of the lesions, because purpura, like petechiae, are when it's less than 1 centimeter. Purpura is greater than 1 centimeter. When you see purpura, it's something is wrong. And it's purpura when it's bigger, and when you push it, the color doesn't go away. The color stays discolored. That means that the blood cells are trapped there. You don't have flowing blood. Sometimes people have like a dark area and you push on it and like the color blanches and the skin pales, and then you let go and the color comes back. That's no big deal. But when you push on this and the color doesn't change, that means blood cells are stuck. And when you got a bunch of them, that's a purpuritic rash, and that usually means something really bad is happening. And then finally, clustered, smooth, slightly raised, circumscribed, pruritic skin-colored lesions of various sizes. This would be a wheal. The lesion is a wheal. A wheal is the classic lesion of hypersensitivity or allergy. If you run your finger, you really can't fully appreciate it from the picture, but if you run your finger over it, it is just raised just above the surface. And if you're really, really talented, I guess you could palpate that the lower edge goes below the epidermis. But this is the classic lesion of allergy. So this patient's allergic to something. Now, this particular person says it started after my antibiotic, so no great mystery there. But sometimes people will show up in your office with these things and they swear they're not allergic to anything, but they are. We just haven't figured it out yet. So those are some primary lesions. You should be conversant in, the typical primary lesions here. Now we're going to go to configuration. Remember I said a few minutes ago that when a dermatologist taught me about derm, she said morphology, configuration, and distribution. Morphology is the primary lesion, what it looks like. Configuration is how it presents on the body, how it shows up. There are several configurations. Some of them are shown here. Annular, scattered, confluent or coalescent, clustered, linear, and discrete. And the configuration also tells you something. Like what you see in front of you is a linear configuration of vesicles. I know you can't really see the vesicles that well. It's not that clear of a picture, but what you've got there are a bunch of tiny serous fluid-filled lesions that are in a line. And that's a classic presentation of contact dermatitis, and it would be described as vesicles in a linear configuration. And then distribution is just where on the body you see it. I guess this is a forearm. I'm not sure, a forearm or a foreleg, but this would be the morphology is vesicles, the configuration is linear, and the distribution is whatever part of the body you think that is. Sometimes you get lesions that occur in like in a distinct group. Like here you've got, I don't know, something like 4 or 5 vesicles right there in that one single area, and we call that a cluster. So these are vesicles that are clustered, and the distribution, of course, is the lower lip. Sometimes a rash looks like somebody just threw it on the patient, and it looks like all over them, and it looks the same all over their body. No primary lesions and secondary lesions. Everything looks all the same, and it's everywhere. And that would be scattered, and this is the classic presentation of rubella. Those rash-producing illnesses of childhood that you'll do in your pediatrics section, that kind of stuff really mattered. Did it show up all at once, or did it start on the trunk, or did it start on the head? You know, that helps you really tease out one from the other. Multiple lesions blend together. You don't always know where one starts and the other one stops. That would be confluent or coalescent. And this too is a distinct type of configuration. There are others, well, I guess we'll look at it in a minute. The opposite of confluent or coalescent is discrete, where everything has its own discrete separate set of borders. And this too can help you distinguish one disorder from the other. This is annular. I mean, like, you know, this round bullseye thing. Now, this is the bullseye lesion of Lyme disease, but you can also see annular lesions with tinea corporis. You can see annular lesions with a brown recluse bite. Again, this is just a configuration. And here's your discrete lesions. Multiple lesions may appear close together, but they are distinctly separate from each other. If you get up close and personal with this, you'll see they have their own distinct borders, and this is tinea corporis. And they are indeed discrete. So morphology is the primary lesion. Configuration is how it presents on the body, and then distribution is just where, what part of the body. And if you can correctly identify those three things, then you research it with a good Google reference, and then you can figure it out. So now we're going to talk about some commonly encountered derm disorders. And you know it, we're going to start with a test success tip. The majority of derm conditions are diagnosed clinically, which means the patient comes in, they give you the complaint, you do a history, you do a physical exam, and make your diagnosis. Most of the time, you don't need a biopsy. There are definitely times when you do, but the majority of time with typical derm lesions, the type you see in primary care, you don't really need a biopsy. You make your exam based on those clinical findings. So again, we've got 4 options here, and the question is, which of the following conditions requires biopsy to confirm? What requires biopsy? Rather than read them all to you because they are rather wordy, let's do it this way. This is actinic keratoses. We have an entire table that talks about actinic keratoses on the next page, so I won't perseverate about it now. But actinic keratoses, ask yourself, clinical diagnosis or biopsy? And you don't need a biopsy. If you ever see a lesion and you're not sure what you're looking at, you certainly can biopsy it, but it's not required. Actinic keratosis is a clinical diagnosis, and the description here in A is a very typical presentation. So this is eczema. And again, the description here under B is also very typical, intensely pruritic, red, thickened patches, anterior lower leg, intermittent itch. This is all very typical. And it too is a clinical diagnosis. You don't have to have a biopsy to diagnose eczema. You can if you're not sure. If you're new, it's the first time you're seeing it, you're not sure what you're looking at, by all means, feel free to biopsy it. You'll get back a report of a cell type, and then that will help you further confirm your diagnosis, but it's not necessary. Now, C is a painless ulcerated lesion, 1.5 centimeters. It's been there for a number of weeks, and the guy is a landscaper. Don't let the landscaping part fool you. It is, you know, it can be a confounding piece of information. You might be tempted to think, oh, he probably got bit by something, but it's been there for a number of weeks and it's painless. That doesn't sound like something that happened on the job. When you have a painless ulcer that's greater than 1 centimeter in diameter, it needs to be biopsied. Period. And finally, this last one here is vitiligo. This is an absolute loss of pigment as a function of autoimmune destruction of melanocytes. And this too is a clinical diagnosis. This does not require a biopsy. So of all of these things that we've seen, and a real good takeaway message here is that ulcerated lesions that are painless, don't seem to be changing, especially over 1 centimeter, they need to be biopsied. Everything else we looked at in this question anyway does not. If we had another 2 days, I could tell you 2 days worth of horror stories about people that did not respect painless ulcers and didn't biopsy them when they should. And by the time anybody did, it had advanced to metastatic disease. So it's a true story. Cancer doesn't hurt till the very end most of the time. All right, I promised you a table about actinic keratosis, and here it is, table 5.3, the actinic keratosis table. It's a pretty simple one. The thing about actinic keratosis is it has this reputation of being the most common precancerous skin lesion. And it is the most common precancerous skin lesion, which is why it always seems to show up on tests for a question or two. But the name can be a little bit misleading. Like you might think, oh, it's very common, and if you get it, you're going to get cancer. And that's really not the way it goes. Actinic keratoses are very, very common. I mean, just like lipomas, if you're over 50, you probably have one somewhere, at least one, if not more. But the majority do not become cancer. Something like only 1%, or 0.1% rather, not 1%, but 0.1% will progress to malignancy. The other 99.9% do not. So they're very common and they can progress to cancer. So they're considered the most common precancerous skin lesion. But the truth is, most of the time they don't. Most of the time, these just hang around. They look unpleasant. People don't like them. And the longer you live, the more likely you are to have one because, long-term sun exposure is a risk. These things are not defined by size. They can be tiny or they can be several centimeters, which is humongoid. And the description is pretty involved there, but what it really comes down to is the way they feel. You almost, I mean, I can't think of a time when you would see these in anybody much younger than 50, but they're more common on sun exposed surfaces. And if you run your finger over it, it feels rough. It feels like an emery board or like, the striker on a matchbook or something like that. That's pretty much what defines them is the way they feel. And they can be the same for years and years and years, or they can resolve on their own, or they can progress to a squamous cell carcinoma. So you just have to keep your eyes peeled. Now, we said already that this is a clinical diagnosis. This does not require a biopsy unless it progresses to the point where you think it's a squamous cell carcinoma. Then, of course, it does need a biopsy. But if somebody just comes in with an AK and they want you to look at it and maybe take it off, it doesn't typically need a biopsy. These things can be cut off, they can be chemoed off, they can be cryoed off. Cryo is typically what you do in primary care. We don't usually treat big, huge areas, but if the patient has a couple small ones, you freeze them. And, if you have the really good cryo stuff that like Derm has, one treatment will often do it for the more simple ones. But if you use, what do you call it? Liquid nitrogen, like those of us in rural clinics with no money do, then usually have to do, several treatments to freeze it and get it off. And that's actinic keratosis. It's almost always good for a question or two, famous for being the most common precancerous skin lesion, even though most of the time it does not become cancer. Speaking of cancer, dermatologic malignancies is our next topic of conversation, and it begins with table 5.4. So table 5.4 is a compare and contrast between basal cell carcinoma and squamous cell carcinoma. In both circumstances, these things need to be biopsied for the diagnosis. If you are comfortable doing it and feel appropriately trained, this is certainly within the purview of primary care to remove these. Excisional biopsy is preferred, meaning the whole thing. We don't do punch biopsies or shave biopsies of a suspected cancer. We do excisional biopsy. The only really time to do a punch biopsy is if the lesion is pretty small, like maybe 4 millimeters, and you can do a 6 millimeter punch biopsy, like you can get the whole thing and a little bit of surrounding skin. And then you could use a punch biopsy to get it out. But other than that, you're best served to excise these with, what do you call it, with a scalpel, and then put the skin back together. So basal cell versus squamous cell, compare and contrast. Basal cells statistically are more common than squamous cells. In terms of appearance, they really can vary. I hate to say anything about generalities. You've got examples of both of them here. They both tend to occur more commonly on sun-exposed areas because, like most cancers, a risk factor is constant insult or irritation to the affected area. You know, if you're exposed to the sun for a long time, the UV radiation is an increased risk for skin cancer, just like repeated exposure to smoke is a risk for lung cancer. Basal cell carcinomas arise de novo or of nothing. They don't have a precursor lesion. What do you call them? Actinic keratoses don't become basal cells. Basal cells start as a basal cell and they just will always be one until you cut it off. Squamous cells can arise from actinic keratoses, like I said, or they can too arise de novo. In terms of appearance, and again, this is very general, but basal cells usually start out going upward, like a papule, remember a raised firm lesion less than 1 centimeter, or a nodule, which is a raised firm lesion greater than 1 centimeter. Early on, especially, they typically don't have any ulceration or central erosion. Now, if they last long enough and you don't cut them out, eventually basal cells can erode whole chunks of body, but they don't usually start that way. They usually start out in an upward movement. On the other hand, squamous cells carcinomas, again, this is very general. There's many exceptions, but squamous cells do tend to, they start out like harder, like your slides suggest. And it says hard lesions with or without ulceration, but they really do generally tend to ulcerate. A very general rule of thumb is that basal cells go up and squamous cells go down. They ulcerate in. Basal cells do tend to be like a shiny or waxy in appearance, whereas squamous cells are just not that distinct. They're more irregular and blend into their environment. Basal cells do not typically metastasize. The only time basal cells really metastasize is if the patient is immunocompromised, and for some reason that facilitates metastases. And then, believe it or not, patients who take Sinemet, Sinemet for Parkinson's disease, Sinemet has this weird secondary action that proliferates dermal cells, and I don't know why, but apparently that leads to an increased risk of metastases. But otherwise, basal cell usually is just very locally destructive. Squamous cells, on the other hand, they do have a greater tendency to metastatic disease. Your slide says 3 to 7%, so I'm sure it's true, but they do tend to metastasize, and they like lingular tissue, whether they start in the mouth or the genitalia or they metastasize there. When you have patients with oral cancer, tongue cancer, or penile cancer, or vulvar cancer, it's usually a squamous cell carcinoma. And yeah, I guess both these folks are getting ready to have biopsies. The one on the left, if you ran your finger over it, it would be raised. That would be a basal cell. And the one on the right does have an ulcerated center. And if that hung around very long, it would get more ulcerated, and that would be the squamous cell. So those are the two cancers that we don't, I mean, we got to respect them. You know, cancer can cause distinct problems and squamous cells can metastasize, but malignant melanoma is the one that has the reputation for being, really very concerning. Um, so the ABCDEs of malignant melanoma. The ABCDEs is a really considered a very highly sensitive and specific screening tool, and it's nice because it's not invasive in any way. It's just about observing and doing a physical examination. If you see somebody that has a lesion that you think is concerning for a malignant melanoma, you should evaluate and document the A, B, C, Ds, and Es of it. And if they have two or more features of that ABCDE assessment, it needs to be referred for a biopsy from the skin cancer people or derm, like wherever you send them to. This is not something that it's appropriate for us to biopsy in the office because there is concern about liberating malignant cells. I know there's some controversy over that, but you don't want to be taking one of these out in a primary care office. It needs to go to a center that really knows what they're doing and has the proper equipment for the right procedures. But ABCDE is considered very, very sensitive. So there's what it stands for. Notice there's two E's, evolving and elevated. And so it's very straightforward. If somebody comes to you and says, hey, can you take a look at this thing? It's kind of, I don't know, it just doesn't look right. I'm a little worried about it. Is it asymmetrical? Yes or no? Are the borders irregular? Are there multiple colors, color not uniform? Is the diameter 6 millimeters or greater, which is actually really pretty big in the scheme of things? Is the thing changing over time? Does it look different? Does the patient talk about how it's changed? It's changed color, it's changed shape, it started itching, it started bleeding, whatever. And is it raised? And this may not be consistently present. This can go up and down. So A, B, C, D, E, and E. If two or more of those are present, then you really do need to send it off to derm. Okay, practical application and selecting treatments. Let's see. Oh, it starts off with a question. Question 4. Match each treatment option with the relevant condition. Okay, so now we're talking about benign stuff. We're not talking about malignancies anymore. So we have 5 treatments: permethrin, a medium potency steroid, topical steroid, imiquimod, ketoconazole, and metronidazole. Which one do we put in the blank here? Which one of these 5 would you use to treat psoriasis? And the survey says medium potency topical corticosteroid. Because remember that the problem with psoriasis is accelerated dermal turnover. Dermal cells just turn over too quickly, and the ones the ones underneath are growing and the ones on the top haven't sloughed off yet. And so the idea is that for small localized eruptions, if you put a steroid on it, you can slow down that turnover. Scabies? Everybody always knows this one, permethrin. In a conference hall, everybody shouts out permethrin. I guess it's because your preceptors always give you the scabies patients when you're a student. Verruca vulgaris, or any other viral manifestation, we would use imiquimod. Tinea pedis, or any other cutaneous fungus, we will use the antifungal. And then finally, there's that nose again, acne rosacea, we will use topical metronidazole or Metrogel topical solution, topical ointment, or whatever. I guess it's a gel, isn't it? Anyway, topical being the key phrase here. All right, now we're going to identify each condition with its classic or common presentation. So we have 5 conditions to choose from. 5 conditions. Ooh, and only 4 things to match them up with. So somebody's going to have to sit out. All right. Which one of those 5 do you suspect? For a 16-year-old with a recurrent history of skin lesions located on the antecubital fossa and forearms and characterized by dry, scaly skin, pruritus, and crusted or weeping sores. The lesions can last for several months and usually are worse during cold, dry weather. Oh, I kind of gave it away. I got excited and clicked my clicker a little bit too soon, but this would be eczema. Again, classic. The pruritus is a big giveaway. The antecubital fossa, because eczema likes those extensor surfaces. It likes folding areas. Worse when it's cold. Recurrent. This is all very consistent with eczema. Whereas, oh, there it is. What can I say? I mean, everybody knows what it is because this is like the 4th time we've seen this nose in this discussion, acne rosacea, and this is a very classic characterization. A 13-year-old with acute onset pruritic erythematous papules and burrows located over the wrists and hands. So burrows are kind of a giveaway here. Very consistent with scabies. Pruritic, now this is not allergy, interestingly enough, right? This is a parasitic thing. But the pruritus, the burrows are really characteristic of scabies and wrists and hands. It also likes areas that have folds and areas that can be subject to warmth and stuff like that. A 22-year-old who reports a solitary salmon-colored patch on a trunk that enlarges over a few days and is followed by a pattern of smaller lesions on the chest, abdomen, and back over the coming weeks. What Well, we're sort of narrowing down the field here, right? But this is pityriasis rosea. Pityriasis rosea, if you've never seen it, is an autoimmune condition. It's considered like a cousin of psoriasis, and it does have this characteristic salmon-colored patch referred to as a herald patch, and then you just get lots of them all over the trunk. Usually, this is confined to the trunk. I mean, there's definitely exceptions. You can see them all over the internet. But this rash just erupts on the trunk really for no apparent reason, and it can kind of freak people out when it happens. I've seen people isolate their patients with this. It is self-limiting. It doesn't require any specific sort of treatment. Lots of people seem to prescribe Lotrazone, the best of both worlds, a steroid and an antifungal in one lotion. But I think it makes the provider feel more better than it makes the patient. You can usually just wait this out and it will resolve on its own, and it's called pityriasis. Okay, so you see Kevin, a 25-year-old man with a BMI of 38 and hyperpigmented plaques with a velvet-like appearance at the nape of the neck and axillary region. He states he states that his skin has had this appearance since he was about 13 and it has not changed significantly over time. He denies itch or pain in these areas. This most likely represents what? So after carefully reading all four answer choices, hopefully you will come back to acanthosis nigricans. This is classic acanthosis nigricans, this velvety-like appearance at the nape of the neck and axillary region. Yep, classic pictures of it, classic presentations. I mean, there are several parts of the body where it can show up, but it likes armpits and it likes necks. So, as part of Kevin's healthcare, consideration should be given for obtaining which of the following laboratory test? So when you see acanthosis nigricans, hopefully you'll recognize that it is a cause, or not a cause of, it's a consequence of hyperinsulinemia. Insulin does many things in the body. It's famous for putting sugar into cells, but it does lots of other things too, and in high levels can precipitate this acanthosis nigricans. So when you see acanthosis, it should make you concerned that the patient is hyperinsulinemic, and if you think the patient might be hyperinsulinemic, then the thing to do is check the hemoglobin A1C, because hyperinsulinemia is your earliest indicator of impending type 2 diabetes. As those insulin receptors fail, the beta cell has to kick out more insulin to get the beta cells to do their job. And it works for a long time, so the blood sugar will be normal, but the insulin levels, if you bothered to check them, would be elevated. And so hemoglobin A1C is one of the first things that's really clinically accessible. Insulin levels, there was a time when it was very trendy to order them all the time, but they're pricey and they have to be done at just the right time of day. Like insulin levels change so significantly, it's really hard to do it right. When the patient gets to the point where they have to have sustained hyperinsulinemia for any period of time, typically the A1C begins to climb up. And so that's the first clinical thing that we're going to look for. With Kevin's skin condition, lesions are most often found in all of the following areas except. So we said you could see it in the armpit. We said you could see it at the nape of the neck. You could see it in lots of different places on the body. But where's the one place where you don't typically see acanthosis nigricans? Bottom of the feet. Don't know why. Maybe because we don't look there. I don't know. But you just don't typically see it on the plantar surfaces of the feet. All right, shifting gears a bit here. Anna is a 22-year-old well woman who presents with a 4-day history of an intense itch with skin lesions on her hands, arms, and right cheek. She has used over-the-counter hydrocortisone with little effect. This has never happened before, and she denies any recent travel or exposure to new creams, soaps, or medications. Physical examination reveals vesicles in a linear configuration along with some crusted areas. Approximately 20% of her total body surface area is affected. You consider treatment with what? Well, you have to ask yourself what you think is going on here and then choose your treatment. She's well woman, 4-day history of these intensely pruritic lesions. No recent travel. Physical exam reveals vesicles in a linear configuration. What does that sound like? Remember, vesicles in linear configuration, and it's on her hands, arms, and cheek. This all sounds very consistent with contact dermatitis. So, if 20% of her total body surface area is affected, what do we need to treat her with? Well, topical application of a medium potent steroid cream, you might use that. Oral antihistamine, you might use that too. Systemic corticosteroid, absolutely. And a topical antihistamine, yes, you might. So all of these things could be used. And in fact, many of them may be used. But if you have to pick one, the most compelling one, the answer is the systemic steroid. If more than 20% of the body surface area is affected, then it's advised that we give the patient an oral steroid because you can't just give them like, 6 tubes of clobetasol and say, okay, every morning and every night, just ointment up 20% of your body. So at that point, it is appropriate to use the hydrocortisone. You can see in your workbook, table 5-6, it's on page 104 of your handout. And the first item there, extent of area affected. And as you compare topical treatment to systemic treatment, it tells you if you have more than 20% or equal to 20% or more, then you want to use a systemic steroid. And you may very well use all or any of those other things that were in those answer choices. But if you're on a desert island with a bunch of people with a 20% affected BSA, and you only could take one thing, it would be the systemic steroid. Yep. So there's the summary of what you see in your slide on page 104. Okay. You are evaluating a new patient who has a long history of psoriasis with exacerbations a couple of times a year that are very distressing. She has tried several prescription creams and ointments, but nothing ever seems to help very much. She saw an advertisement for something called Cosentix. Geez, I really believe strongly that a speaker should be able to pronounce everything that's on their slide. And secukinumab. Secukinumab. Yeah, secukinumab. There we go. Brand name Cosentix, which is, of course, much easier to say. Anyway, she wants to know if she can have a prescription for that. You counsel the patient that prior to beginning any biologic medication, it is important to ensure all of the following except. What's the exception? Documentation of previous therapies, immunizations are up to date, hepatitis screenings are negative, there is no history of eczema. What's the exception? What's the thing you don't have to document? You don't have to document the absence of a history of eczema, but everything else here does need to be, you do need to ensure that all of those have been reviewed and evaluated. Now, finally, I believe we are coming up on our last derm topic, and that would be bacterial skin infection. Yep, bacterial skin infection. So bacterial skin infection, I mean, they are bacteria. The bacteria that colonize the skin in healthy people are strep and staph, and almost all skin infections are strep and staph that have invaded protective mechanisms, just like strep is the thing that invades the protective mechanisms in the nose and causes sinusitis. And there's a couple of different ways that bacterial skin infections can manifest themselves. And one of the big distinctions is purulent or not. In the world of non-purulent skin infections, we have impetigo. So impetigo is shown here. We've seen this picture a few times already. Impetigo comes in two flavors, bullous and non-bullous. And non-bullous is the more benign of the two. This is the one that really does present as that classic textbook honey-colored, golden-crusted exudate. And it really does look like that, although that's a very mild case. I mean, you'll see this sometimes all over people's heads or on big chunks of their body. It's a bacterial infection. And if it's very small and localized, you can usually treat it with a topical antibacterial like Bactroban. More invasive cases do need to have systemic therapy, but this is typically strep. Now, if the impetigo invades the dermis a little bit deeper, then you start to see the formation of bulla. So when bulla forms, it's because the part of the skin that has a highly dense capillary network is now becoming infected. And in an effort to try to shed the bacteria, the little capillaries will extravasate. They like shed serous fluid trying to shed bacteria. And it just doesn't go very far. The serous fluid collects in these little epidermal sacs, and then you have bulla. So when you see bulla, The infection, the impetigo, is more invasive. It's a more invasive, deeper infection, and this always requires systemic antibiotic therapy. And then we have your garden variety cellulitis. Cellulitis, the picture you see on the left is very classic. One of the things about cellulitis is it does not typically have a really clear line of demarcation. I mean, somebody obviously drew on this with a pen just to try to mark resolution. But if you look up close and personal, it's not like there's a real sharp, distinct line between affected and uninfected. It's like somebody took an eraser and tried to blend the infected area in with the unaffected area. That would be classic cellulitis. This is a bacterial infection. It's usually red, it usually hurts, it's painful to the touch, the patient probably has a low-grade temp, and regional lymphadenopathy. On the right side of the screen is a picture of erysipelas, and it's really not the best picture of it. It's usually more dramatic looking than that. But erysipelas is a variant of cellulitis. It happens most commonly on the face. It can, like your slide says, show up in other places, but most commonly and most concerning on the face. And here she's got it in her eye, which is really concerning because it could, become orbital cellulitis. Um, but the thing about erysipelas is that when it is strep, it is always a strep infection. And when you have a strep infection on the face like that, there's really concern about ensuring that it drains downward rather than backward because you don't want the patient to wind up with what do you call it, meningitis. So people that have erysipelas on their face, they need to be hospitalized. They need to sleep with the head of the bed up 70 degrees. I mean, the thing has to facilitate downward drainage of strep, not backwards drainage. And yeah, cellulitis sees, again, another general rule, which can vary, but a general rule is that cellulitis, non-purulent skin infection, is most likely strep, whereas purulent skin infection, like an abscess, is more likely staph. Can't emphasize enough that there's exceptions to every rule, but now erysipelas is always strep. I don't know why, but it just is. But other than that, yes, non-purulent skin infection, cellulitis, impetigo, etc., usually strep, whereas abscessed skin infections, collections of pus, usually staph. There you go. So your typical cutaneous abscess, the kind that you can feel fluid in there, and then when you drain it, all sorts of pus comes out, and it's really fun. Those are usually staph. It's typically something that started out as an infected hair follicle, and then it just collects a bunch of pus. It's an acute infection, very, very painful to the touch, and it needs to be drained. So that's it. You have your purulent and non-purulent skin infections. In terms of what to do about it, that's what you've got this figure for. That's what you've got this algorithm for. So, I mean, you can see whether it's the non-purulent skin infections like cellulitis, erysipelas, or impetigo, or the abscessed ones, the first thing you have to ask yourself is, are they mild or moderate infection? Because if they're severe, the patient's in the hospital. The difference between mild and moderate, and severe for that matter, I know they're very subjective terms, but they have pretty widespread acknowledgement of what we're talking about in medicine for anything, whether it's acne or a headache or abdominal pain or a skin infection. If something is mild, it's there. The patient wishes it wasn't. It's not hugely interfering with their world in any way, but if you can do something about it, that would be awesome. They prefer to have it treated. If something is moderate, it is beginning to have some impact in their world. Maybe there's some systemic symptoms like some nausea, maybe a low or moderate grade fever, keeping them home from work. They don't feel well. That would be moderate. There's localized lymphadenopathy. You can see that there is some systemic manifestation. And then severe means it consumes the patient. It's the primary topic of their lives. Like I said, severe skin infections go to the hospital for IV antibiotics. The difference between mild and moderate is whether it's invasive or not. If something is mild, you treat it more conservatively and locally. So look at mild cellulitis or syphilis or impetigo. Like very mild non-bullous impetigo, you can treat with topical Bactroban. Everything else, PO antibiotics, a PO anti-strep antibiotic like penicillin VK. That's your first choice because it's narrow spectrum for strep. If it is more moderate, there is more systemic involvement, the patient needs IV penicillin family drug. Whereas with abscesses, same thing, mild, moderate. Is it a very localized, not with any systemic symptoms, or is there some streaking and proximal spread, and patient doesn't feel well? If it's mild, the only indication is for incision and drainage and warm compresses. There's no routine indication for antibiotics, even though everybody always prescribes it. The real thing to do is open up that thing and get the pus out. If there's more moderate involvement, then yeah, you drain it, you culture the drainage and then start empiric antibiotics while you are pending a culture. But notice now the antibiotics are intended to cover staph, not strep. So the antibiotics are different. Bactrim or doxycycline is the drug of choice. And then once you get your culture back, you just treat to culture. So they are different things. And that would be the end of that. Unceremoniously. Now we're going to go on to Chapter 6, thyroid disorders. So thyroid disorder, really just talking about one hormone. Endocrine disorders, I think, are one of the easiest things to review because you're talking about a hormone. And if you know what the hormone does, then you can easily reason through what happens when there's too much of it and what happens when there's not enough of it. And if you have a condition characterized by not enough of a hormone, you just have to replace it and give the patient hormone. If you have a condition characterized by too much hormone, well, then you have to um, get rid of the cause. If it's a tumor, get rid of it. You gotta get rid of the thing that's causing the excess hormone. And them's really the basics. So of course we could get a bit more detailed, but in the end, that's really what it comes down to. When it comes down to thyroid hormone, just think about what thyroid hormone does as you reason through your signs and symptoms. What do you expect to happen when there's too much of it or not enough? And then in terms of treatment modalities, we replace the hormones that's not there, or we get rid of the cause of the excess. That's our starting point. That's our framework. So, test success tip numero uno in the thyroid section. The thyroid produces two hormones, T4 and T3. These hormones act as cellular energy catalysts, release catalysts, and influence the function and health of every cell in the body. It's so eloquent. I mean, the bottom line here is thyroid hormone is the hormone that sets the metabolic rate. And incidentally, T4 is mostly what the gland puts out. 90% of what the thyroid gland puts out is T4. Only a very little bit of what comes out of the gland is T3. Most T3 is produced peripherally when T4 is deiodized into T3. That does have some significance later on. So it works in a feedback loop with the anterior pituitary. The anterior pituitary releases thyroid stimulating hormone, and thyroid stimulating hormone binds to thyroid stimulating receptors on the thyroid gland and stimulates the uptake of iodine, the production and release of thyroid hormone. And then thyroid hormone flies around the whole body, setting the metabolic rate. Thyroid hormone actually has receptors right on nuclear membranes, and it catalyzes cellular energy release. It binds to receptors right on DNA and causes the DNA to express its codes so that that cell can do whatever it is that cell is supposed to do. Every cell in the body responds to thyroid hormone. Cardiac cells contract, GI cells contract. The nervous system both processes sensory input and generates a motor response. Everything, I mean, just everything responds to thyroid hormone. So you have to have just the right amount of it. If you have too much thyroid hormone on board, everything goes too fast. If you have too little thyroid hormone on board, everything slows down. And the relationship with the pituitary is a negative feedback relationship in that when T4 levels get high enough, it will shut down pituitary production. So we already said the anterior pituitary releases thyroid stimulating hormone. Thyroid stimulating binds to the thyroid gland and makes the thyroid gland release T4. So then T4 levels will go up, up, up. So as T4 levels climb, the message back to the pituitary is, hey, we don't need any more. And the pituitary is like, okay, I'll slow it down. And it slows down TSH production. So a little less TSH means a little less stimulation of the thyroid gland, which means the gland doesn't produce as much hormone. Circulating T4 levels begin to fall. The feedback to the pituitary is, hey, I need more. So pituitary says, okay, and TSH levels go up. and that stimulates the gland to make more T4, and those levels go up, and that suppresses the pituitary, and it just exists in this trying to balance the seesaw type of phenomenon. But if something interrupts that system, you're going to have either too much of it or not enough of it, and then you have a problem. So first up is table 6.1, hypothyroidism. So this is the patient with too little circulating T4. If you need a mnemonic to help you remember the signs and symptoms of hypothyroidism, there's one on your handout. It says, "Mom's so tired." Or you could just remember that virtually everything tends to slow down. This is most common in women over 50, although it certainly can happen to anybody in the population. But mostly it happens to women over 50, and everything just tends to slow down. It just doesn't function as efficiently. Metabolism slows, so there may be some weight gain. Not a whole lot. I mean, I think 10 pounds is kind of low. You could easily see like up to 20-pound weight gain with hypothyroidism. Not 100 pounds though. Like everybody wants to get checked for their thyroid when they're gaining weight, when the answer is usually they're just getting older and not exercising enough and not eating right. But, a little bit of weight gain, sure. Um, Endometrial turnover tends to be slower, so periods take longer and they're heavy. Yes, mental slowness, delayed information processing. Skin and hair seem dry because they don't turn over as quickly, and all the old dry slough hangs on. They get tired all the time. They tend to be cold intolerant because they're hypometabolic. Metabolism produces heat, and if you're hypometabolic, you don't produce as much heat. Blood pressure does rise a little bit because the heart rate tends to fall, so the blood pressure is accommodating for that. They just have a tendency to feel tired a lot and even sometimes can appear clinically depressed. Everything slows down. The most common reason for this is Hashimoto's thyroiditis. Now, there's a couple of other reasons on your handout, but Hashimoto's is most common. This is an autoimmune condition where the patient makes anti-thyroid antibodies. So remember, the pituitary releases TSH that binds to thyroid receptors. Well, the patient with Hashimoto's makes anti-thyroid antibodies. So the anti-thyroid antibodies bind to those TSH receptors, block TSH from doing its job, so TSH can't work, and you don't produce enough thyroid hormone. So circulating T4 levels will fall. So then quick break for a drink of water. So then, when circulating T4 levels fall, the message back to the pituitary is, hey, we need more. And the pituitary is like, I know, I'm trying. And it puts out more and more TSH to try to stimulate the thyroid gland, but it can't because those antibodies are in the way. So TSH levels go up, up, up. T4 levels go down, 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 and that's your classic Hashimoto's. The patient will also have anti-thyroid antibodies measurable in blood. And that's that. Other less common causes of hypothyroidism, sometimes patients have a history of Graves' disease, a history of hyperthyroidism, and then they had gland ablation, and now it underperforms, but that's usually evident in the history. And iodine-containing drugs, like the few that you see listed here, iodine-containing drugs really tend to bombard the thyroid gland with iodine because iodine, we don't usually have a lot of it in our bodies. In fact, we have to supplement our salt with iodine, iodized salt, right? And so all the iodine in our body usually bombards our thyroid gland because it needs it. So that's a good thing. But if you start taking an iodine containing drug, like any of these that are listed here, it's like all of a sudden your gland is over bombarded with thyroid hormone. Your thyroid gland's like, hey, hang on, too much iodine here. For a minute, I guess it seems like a party, but then it realizes it's being overtaxed, and so it will slow down and then it down regulates and you start to see T4 levels fall. That's why anybody on lithium, amiodarone, or interferon, they need to have their TSH monitored every 12 weeks. And as soon as the TSH falls, as soon as it goes above 4, rather, you need to start them on you need to start them on thyroid hormone replacement. See what happens when your brain goes too fast in too many directions at one time. But you need to have thyroid hormone replacement when the TSH goes above 4. And even if they're not having any signs or symptoms, that TSH above 4 is the indication that thyroid hormone levels are going to fall. And that's hypo. Now, hyperthyroidism Hyperthyroidism is just the opposite. Obvi, you have too much circulating thyroid hormone. So now there is too much cellular energy release and too much cellular productivity. If you need a mnemonic to help you remember, well, I guess you could use sweating. It's kind of a disgusting word. Those wet words actually just kind of gross me out, generally speaking. Sweat, moist, you know. But it's a good mnemonic because people that are hyperthyroid, they are hypermetabolic and they may very well have excess perspiration or excess sweating. But the bottom line is just everything goes too fast. Everything's moving ahead of the game. They tend to be more hungry because they have increased GI motility but are losing weight. The baseline heart rate is typically tachycardic. They will be tremulous, new onset tremor, you notice, like at rest and with purpose. Everything just kind of jacks up a little bit. Patients that are thyrotoxic, they kind of look like they're moving even when they're not. It's almost like they're on sensory overload, like processing a whole bunch of different thought streams and just seem a little bit tremulous. It just seems like everything's kind of going into overdrive. The GI tract is in overdrive, that's for sure. They tend to usually have a couple of low volume stools a day. People with hyperthyroidism rarely get constipated or they rarely get cold because they're hypermetabolic, so they're producing heat. And the most common cause of it is also autoimmune. Thyroid disease is usually an autoimmune phenomenon, whereas Hashimoto's, the patient makes autoantibodies that block TSH receptors. In Graves' disease, the patient makes antibodies called thyroid stimulating immune globulins that actually activate TSH receptors. So it acts like TSH. So these thyroid stimulating immune globulins, they turn on the thyroid gland and make it produce and release hormone and T4 levels go up. And the message back to pituitary is, yo, we don't need any more, slow down. And the pituitary is like, I'm not doing it, don't look at me. And it's true, the TSH levels are dropping. If you measure TSH, it will often be undetectable, but it's because it's something else that's causing this hormonal surge. I don't know if I mentioned this before or not, but autoimmune disorders, they do have a tendency to occur like more than one at a time. I guess they just, kind of like STDs, they like to travel with their friends. And so patients that have one autoimmune disorder are at greater risk for another. And there definitely does seem to be an association between type 1 diabetes and hyperthyroidism, Graves' disease, hyperthyroidism. But again, there are other causes. Some people have, what do you call it, nodules, like a little toxic adenoma, a benign nodule of the thyroid gland that actually just produces hormone for no apparent good reason. It produces hormone totally absent any kind of stimulus. And so there's that potential. That's got nothing to do with antibodies or autoimmune disease. And then there are people that don't have an overactive gland, but the gland just gets usually inflamed. It gets like stimulated or inflamed in some way. It could be an infection, it could be trauma, and it just gets like it gets inflamed and dumps all of its hormone out into the world. And it's like the patient basically gave itself a thyroid hormone bolus. And so transiently, they have increased circulating thyroid hormone and may become symptomatic, although for them, like the slide says, it's usually milder. You usually don't need to do anything about it. I mean, they may come in saying they're having trouble sleeping or, something like that. But when push comes to shove, the levels are often not high enough to have to do anything about. In a pinch, you can just treat them symptomatically and wait for them to metabolize that self-inflicted thyroid hormone bolus. The same medications that will eventually shut down the thyroid gland, they might early on actually you see a transient bump in thyroid hormone, but probably not. I mean, that's a theoretical thing that doesn't usually happen. The vast majority of the time, by the time you see any impact of iodine containing drugs, it's as the thyroid gland begins to shut down. So that's that. That's what we have in terms of symptoms and causation. So let's consider the underlying problem and see what kind of symptoms it can cause. All right, hypo, hyper, or both. Which one causes dry skin, or both? Hypo, because the dermal cells don't turn over fast enough. The outside ones don't slough off, and the old dry ones just stay put. Fine tremor, that's hyper. Hypoactive deep tendon reflexes, hypo and hypo, that's kind of a giveaway. mood or mentation change? Both, actually. People with hypothyroidism, you can definitely see like a delayed information processing. It just takes them longer to think about stuff. And people that are thyrotoxic or hyper, it's almost like they're on sensory overload and you're watching them just try to like process everything that's going on, but they just almost look like, they're overloaded on input and um, trying to normalize it. It's like the seesaw is just a little bit on one way or the other. How about menorrhagia? Of course, that's hypo. And exophthalmos, I don't think I mentioned this specifically, but exophthalmos is not only consistent with hyper, but just autoimmune hyper. Exophthalmos is a consequence of ocular muscle antibodies causing hypertrophy of ocular muscles, and that's why the eyes do that. And you see those ocular muscle antibodies in some fraction of patients that have autoimmune Graves' disease, but you don't see exophthalmos with like an adenoma or any other cause. Yeah, most of you won't know who that is, I'm sure. Old school comedian who is known for his thyrotoxic faces. All right, so you got your symptoms under control. Now we have to talk about laboratory testing, which is really pretty straightforward. Again, studying for board certification in primary care, not endocrinology. So there are 3 labs that matter to us in the world of primary care. And the first one is the thyroid stimulating hormone, or TSH. Normal TSH is 0.4 to 4.0 milli-international units per liter. And this is considered the single most reliable test to diagnose all common forms of thyroid disease in the ambulatory care setting. It is highly sensitive, and the bottom line is this is from the American Association of Clinical Endocrinologists, who really do provide the authoritative statements on endocrine issues from primary care. And they tell us that the TSH is so highly sensitive and specific that if the TSH is normal, the thyroid's normal. You don't need to do any other testing. You don't need additional tests. You don't need other scans or anything like that. If the TSH is normal, whatever disease, whatever symptoms you're working up, just go look somewhere else. If the TSH is abnormal and you would like to confirm your suspicion, you can follow it up with a free T4. Remember I said a little while ago that the vast majority of what the gland produces is T4? So it makes sense if you're trying to firm up your impression of what the gland is doing, you're going to measure T4. T4 circulates mostly bound to protein. So most T4 in circulation isn't useful. It's not free to engage in a biologic response. A very small fraction of it is, and that would be the free T4. Free T4 is considered a much more precise indicator of actual circulating T4 activity, and it's the study of choice. And so TSH, if you have to pick one test, it's a TSH. If you get to pick 2, follow it up with a free T4. And that's it. The only other thing that there's any utility for in primary care is the thyroid antibody. It's like every lab has a different name for this: thyroid peroxidase antibody, TPO antibody, anti-TPO, um, anti-thyroid antibody, ATA. There's all different ways I've seen this. So you just have to figure out what the lab that you use, like how it codes it. But the bottom line is you're looking for those antibodies that would support a diagnosis of Hashimoto's. And that's it. Anything else, T3 levels, thyroid uptake scans, mm, all kinds of fanciness. That's what endocrine's for. I mean, there are totally people that have thyroid disease that's not this straightforward and not this routine. And that's when endocrinology can see them and do all that fancy testing. But for us, TSH number 1, free T4 number 2, and if you want to confirm Hashimoto's, an anti-thyroid antibody. So putting it in context here in table 6.6. Here's a classic untreated hypothyroidism. The free T4 is very low, the TSH is elevated, and this lady who's 62 has a 4-month history of worsening fatigue, worsening constipation, dry skin, hyporeflexia, all very typical. Her TSH is 84. Oh, makes me tired just thinking about that. Her TSH is 84. You can see normal is 0.4 to 4.0, and her free T4 is 3. whereas normal is 10 to 27. So clearly untreated hypo. So what do you do when a hormone is missing? Replace it. Prescribe levothyroxine. It comes in many brand names as well as generics. As a general rule of thumb, when you need to replace thyroid hormone in an adult, on average, they'll need 1.6 mics per kilogram per day. It's not a weird mistake that thyroid hormone replacement comes in 112 mics per kilogram. Remember, there was a time when the PDR thought everybody was a 70 kilogram male. And so 1.6 times 70 is 112. And of course, it's an average. Some people need more, some need less. As we age, of course, the metabolic rate slows and we don't need as much thyroid hormone. We don't make as much. So if you have to replace it, you don't replace as much. You replace 1.1 mic per kilogram per day in an older adult because we just don't metabolize as quickly. And that's it. Your handout talks a little bit about Armour Thyroid. And then there's a comment here that the use is not recommended by AACE. So I really don't even find it instructive to talk about here. I'm not sure why it's in the handout. Certainly for your boards, you just want to be familiar with a typical evidence-based approach to care, which is if the patient is hypothyroid, you want to replace it with levothyroxine, on average 1.6 mics per kilogram per day. And then once you put somebody on thyroid hormone, of course, you have to follow up on it. And one of the great debates always been how long? How long should you wait? Longer is better. Some books will say, I still see books that say 4 to 6 weeks. Others will say 6 to 8 or 6 to 12. Some will say 8 to 12 weeks. Really, longer is better. It truly takes the body time to adapt to having thyroid hormone on board. And if you check it too soon, you're going to feel compelled to act on an abnormal value, and then it's just going to make it much harder in the end. So you're better served to wait at least 8 weeks before you check that TSH and do anything about it. Patients may start to feel better a lot sooner than that, but you want to wait at least 8 weeks before you actually check the TSH. Now, if you wait the appropriate period of time, and their TSH is elevated still, just make sure they're taking it the right way. Remember, thyroid hormone is very quick to bind to other stuff, so you really have to take it on an empty stomach with a big glass of water. And if they're doing that the right way and their TSH is still too high, then they need to have their dose increased. Whereas untreated hyperthyroidism, so untreated hyperthyroidism, you can see what's going on here. Again, the patient is just about the right age range, 44. You can see that her TSH is low and her free T4 is elevated. So like that would be your classic presentation of hyperthyroidism or thyrotoxicosis. And I know I keep using those words interchangeably, and I probably should explain. In literal terms, thyrotoxicosis is the patient who has excess circulating thyroid hormone for any reason. Hyperthyroidism is the patient who has excess circulating thyroid hormone because the gland is overfunctioning. So they aren't really two different things. You can be thyrotoxic because you're taking too much medicine. You can only be hypothyroid if your gland is overfunctioning. So in this case, well, we don't know what it is yet, but we do know that she is thyrotoxic, and we know that she has diabetes. And remember I said that autoimmune conditions, they tend to kind of hang out together. So it's very reasonable to wonder if she has Graves' disease, which, if you want to know, you could check for thyroid stimulating immune globulins. Her TSH is low, her free T4 is elevated. So this is not a primary care diagnosis. Hashimoto's hypothyroidism, there's nothing else to do for it except replace the levothyroxine. There's no reason to send that patient to endocrinology. We can manage that in primary care. But hyperthyroidism, this patient needs to be managed definitively, and that's a specialty consult. So we can put the patient on a beta blocker for symptom control pending their appointment with endocrinology. And endocrinology will work them up and then farm them off to whatever approach they think is appropriate. And yeah, I think that's what I just said. I mean, if it's truly hyperthyroidism, if the gland is overactive, they usually ablate it with radioactive iodine. If they have a nodule, they often operate on it. Antithyroid medications, I mean, they're just really a second line approach in people that are not candidates for curative therapy. But for us in primary care, if they're symptomatic, which presumably they are, which is why we test them in the first place, we put them on a beta blocker and refer them to endocrine. And then the last group here is subclinical hypothyroidism. So this is the patient with an elevated TSH, but a normal free T4. And for years, people used to argue about what to do with this. Like one school of thought was like, well, geez, if the TSH is the most sensitive indicator and it's elevated, we should treat it. And then the other school of thought said, yeah, but it drives the T4. And if the T4 is normal, then we should leave it alone. And all the smart people just argued back and forth about how brilliant they are. And then finally, the American Association of Clinical Endocrinologists, they gave us some guidance. And they said, well, I'll tell you what they said in a minute. First, let's look at the labs. So the lady's TSH is elevated, not nearly as bad as the other one, but it's elevated, and the free T4 is normal. So what you want to do here is check the antithyroid antibody. And if the thyroid antibody is elevated, that confirms a diagnosis of Hashimoto's, and all you can do is replace TSH. And that is what you will do in this circumstance. The AACA tells us that if you have a patient whose TSH is over 5 and they either have a goiter or they have antibodies like this patient did, or they have any symptoms of hypothyroidism, the things that we talked about, mom's so tired, or there are any reproductive issues. Can't get pregnant, trying to get pregnant, are pregnant. I mean, anything like that, then we also have to treat. And then once you put them on thyroid hormone, you follow up, 8 to 12 weeks, just like you would anybody else that you put on thyroid hormone. So then finally, how you monitor that thyroid hormone is what you see on the table in front of you. So you see the patient, you deduce that they need thyroid hormone, and you put them on it. 8 weeks later, you check the TSH. If the TSH remains above 4 and you know they're taking their hormone properly, you have to increase the dose, right? The TSH is too high, increase the dose and reassess. If their TSH is between 0.5 and 4, leave them alone. They're where you want them to be. Continue the current dose, check their TSH again 6 months or a year. If their TSH is less than 0.5 and they're taking it correctly, they are over medicated and you need to decrease their dose and then reassess. So, you see a 38-year-old woman with hypothyroidism who is currently taking levothyroxine 70 mics a day with excellent adherence and states, I take the medicine every morning on an empty stomach with a big glass of water. She is feeling well. Results of today's laboratory test include a TSH of 4.5. The next best step in her care is to do what? All right, she feels great. She's taking it with a big glass of water. Everything is beautiful, but her TSH is 4.5. Remember that diagram we just looked at? If her TSH is greater than 4, we are to increase the dose and reassess in 2 months. I know that's not what you always see in clinical practice. I bet the farm. I mean, sometimes we're just so happy they come back. If they come back and have a 4.5 and feel good, we're like dancing on the ceiling. That's real life. But in exam world, we go the evidence-based route. And really the rationale here is if you're going to medicate the patient, we may as well do it right. If we're going to medicate them, let's get them where they need to be. And that would mean even if she feels fantastic, we are going to increase her dose by 25 mics. Now, Mrs. Lang is a little bit different. Mrs. Lang is a 79-year-old woman with a 20-year history of well-controlled hypertension and dyslipidemia. She is currently taking an ACE inhibitor, low-dose thiazide diuretic, and a statin. She presents today with a chief complaint of a 6-month history of progressive symptoms, including fatigue, difficulty initiating and maintaining sleep, increased difficulty raising her arms above her head, and a sensation of, my heart not beating right. Sometimes I feel like it's going to hop right out of my chest. She denies shortness of breath, chest pain, cough, or difficulty breathing when supine, and she admits to losing weight without even trying. Cardiac examination reveals an irregularly irregular cardiac rhythm without S3, S4, or murmur, and no neck vein distension. Her ECG is as shown, and it's also in your handout. And I'll come back to this screen in a minute. But the question is, the result of Ms. Lang's ECG is consistent with what? So look at your options there: sinus tach, multifocal atrial tach, first degree blocks, or AFib. All right, so you don't have to be like an EKG expert here. This is a rhythm strip. And so let's look at, because it's asking you about rhythms. It's not asking you for a 12-lead interpretation. So when we assess a rhythm, the first thing you do is look to see if the QRS complexes are regular, if they occur at even intervals, the length of the strip. So you can pick any one you want. We'll use V5 just because it's, nice big complexes. Are these regular? Mm, think so. A little off. We could use calipers, but pretty soon we won't need to because look, boom, boom, boom. Definitely not regular. This is smaller than this. This is smaller than this. But this is bigger than this, but smaller than that. And then we got this and we got that. And it's just irregular. There's no rhyme or reason to it. Some beats happen closer together and some don't. And there's no order. It's irregularly irregular. The next thing then that you look at, is there a P wave before each QRS complex? Mm-mm. Sometimes I don't see a P wave. Sometimes I think I might if I squint. Mm, maybe. Maybe there's kind of one. But the bottom line is, when the question is there a P wave before each QRS complex? The answer is no. So already, that's really all we need to know. We have an irregularly irregular rhythm, and we don't have discrete P waves. And there's only one thing here that works, and that's AFib, right? So that makes that easy. So that we are starting to learn a lot about Mrs. Lang. Now we know that the remainder of her physical exam reveals flat affect, fine tremor, hyperactive deep tendon response, mild proximal muscle weakness, symmetric thyroid enlargement without tenderness or mass, and a 10-pound weight loss since her last visit 8 months ago. The remainder of her exam is at her baseline. Which of the following is the most likely diagnosis? So we're in the thyroid section, so it's probably hypothyroidism or thyrotoxicosis. But even if we weren't in the thyroid section, there is so much multi-system involvement here, it really has to be thyroid. Statin-induced myopathy might explain muscle weakness, but it wouldn't explain anything else. And there is absolutely nothing here to support heart failure. So she's got multiple things going on across multiple body systems. Is she thyrotoxic or hypothyroid? And the answer is thyrotoxic. The weight loss, the AFib, the hyperactive reflexes, the tremor, the unplanned weight loss, the whole thing just screams thyrotoxicosis. And so if we can agree that she's thyrotoxic, which of the following results will most likely be noted for Mrs. Lang? Remember what we said about thyrotoxic. We expect the TSH to be low. It's suppressed because the free T4 is very high. So look at choice A. TSH of 9.2. Nope, that's it right there. Can't be that. B has a TSH of 0.11, which is low, and a free T4 of 68, which is high. So B could work. C is a definite no with that TSH of 45. And then D has a TSH of 0.25, so that's low, that's possible, but the free T4 is only 24, which is normal. So for this symptomatically thyrotoxic lady, the best answer of those provided is B. Test success tip. It might be the last test success tip in the thyroid section. In thyroid nodule, the role of primary care NP is to initiate appropriate diagnostic testing and evaluation, then refer for further study. Oh, definitely. Anything that even remotely sounds like cancer, we assess and refer. We are totally not doing cancer protocols on your boards, right? Someday you might work for oncology and then you'll learn, but it won't be on your certification boards. All right. So the evaluation of a solitary thyroid nodule, it's our last concept here in thyroid world. And it's really pretty straightforward. When you palpate a nodule anywhere on the body, you palpate a nodule, which is a raised firm lesion greater than 1 centimeter, the first thing you should ask yourself is, oh, like, is this, could this be malignant? I mean, if you palpate the nodule on the thyroid gland, it's a thyroid nodule. So then you say, oh, well, that's a lump. It's big. Could it be malignant? Well, statistically, no. The risk that any thyroid nodule is malignant is very low, about 5%, which is very comforting unless you're one of the 5%. So then you would say to yourself, like, what are the things that would make me more concerned about malignancy? And these are the same things across the body. Any exposure to risk factors. So for the thyroid gland, it's history of head or neck irradiation. If the patient has a nodule and they've had irradiation of the head or neck for some other reason, yes, that's a risk factor. If the size is larger than 4 centimeters, that's like almost as big as the gland itself. So size does matter. That's concerning. We've already established that non-tender, firm, fixed, and non-tender. This is the cancer mantra, which we don't love. You know, some nodules are like you can get your hands around them and move them around and they feel really smooth. That's not what cancer feels like. So if this thing is on the gland and you can't move it and it's non-tender, and if there are associated lymph nodes, this is very concerning. Finally, if somebody has a lump on their neck and a perpetual hoarse voice, it just makes you wonder what's going on the other side of that nodule. Like, is it extending in and starting to push on the vocal cords? Or if they have a lump on their neck and they start coughing up blood, you have to wonder if it's not eroding into the laryngeal artery. So this is like the same thing of cancer anywhere. Are there risk factors? Is it very big? Is it fixed, firm, and non-tender? Are there associated lymph nodes? And there are symptoms associated with this thing invading underlying structures? And the more of those you have, the more concerning that this is. So when it comes to the thyroid gland, there is again, this is a least expensive, least invasive to more expensive, more invasive trajectory. You may not have always seen it done this way clinically, but on your boards, that's what you want to do. Least expensive, least invasive, escalating only as necessary. If you palpate a clinically evident 1 centimeter or more thyroid nodule, the first thing you do is order a TSH. TSH is easy, cheap, barely invasive. It's a quick peripheral venipuncture, and it can tell you a lot. If the patient has a lump and their TSH is suppressed, that suggests that something is producing thyroid hormone. And thyroid cancer doesn't produce hormone. So if the TSH is low, it tells you that the lesion is producing T4, and that's actually encouraging. Whereas if the T4 is or the TSH is normal, then you're back to worrying, could this be thyroid cancer? If the TSH is indeed suppressed, then you just want to do a nuclear med scan to see if the gland and the lesion are actually functioning. And if they are, if they're taking up iodine and making hormone, this is what we would call a hot nodule. It's not cancer, it just needs to come out. So you have to refer it to the appropriate, place. Actually, endocrine will refer it appropriately. But if the nodule is not working, if it's a cold nodule, now we're concerned again about cancer, and then it is referred for fine needle biopsy, fine needle aspiration. Oh, and that unceremoniously is that. Thought there was more to that, but I was fooled. Okay, last chapter of the day, and it's about headache. Do you have one yet? If you don't have one yet, don't worry. I still have about a half an hour to give you one. But if you do have a headache, at least you'll be really on top of what to do about it tonight so you can prepare for coming back tomorrow for more of the same. All right, one symptom headache, very commonly encountered. You're going to encounter it in your chest, you're going to encounter it in your clinical practice, and you'll probably encounter it in your first year of practice as you give yourself a headache. So, test success tip, common diseases occur commonly. Primary headache, it really is far more common than secondary headache, and differentiating primary headache from secondary headache is really the first thing that you have to do. If somebody comes to you and says, I have a headache, you know that the first thing you need to do is tease out whether this is a primary headache or a secondary headache. How do you do that? Well, that's the topic of the next few pages. But statistically speaking, Primary headache is 99% of the headaches that walk into your world. Secondary headaches, just 1%. Of course, the trick is identifying those 1% so that you don't miss anything. Primary headaches are headaches where the headache itself is the diagnosis. It's not a symptom of something else. And there are a couple of identifiable headache syndromes, and you can often figure out what's going on and make your diagnosis just by looking at the patient's genetics, their family history, the things that trigger their headache, the character of the headache. It's usually pretty easy to figure out. Secondary headaches are headaches that are caused by some other identifiable condition. If you can figure out what the other condition is and treat it, the headache presumably will go away. So the headache itself is not the treatment target, it's the other problem that is. Now, that's not to say you're not going to have to like pop a Motrin or two while you're figuring out what the underlying problem is, but the underlying problem is the primary treatment target in secondary headaches. So here they are. Primary headaches are migraine, tension, and cluster. Those are the big three: migraine, tension, and cluster. And just, a few little pearls of wisdom here. With migraine, tension, and cluster, no matter how bad it seems when the headache is present, between exams, the neurological exam is within normal limits. If somebody's having repeated headaches and when they're headache free, they still have neurodeficits, they need to refer to a neurologist. You're more concerned about an underlying neurological problem. We're going to talk more about symptoms of migraine, tension, and cluster on the next page. So we'll come back to that photophobia and phonophobia stuff. Secondary headaches, there's so many things that can cause them, and the dramatic stuff always makes the top of the table: intracranial bleeding, increased intracranial pressure, meningitis, tumor. I mean, these things are all catastrophic, and obviously we don't want to miss them. But headaches can also be due to things like the flu or the eye strain or sinusitis. I mean, it really can run the gamut. People that have viral influenza, very often the headache is what brings them in because it's just so hard pounding headache and they're like, please, could you amputate my head? So not every secondary headache is like deadly or fatal, but you totally have to keep your eyes peeled to what would suggest that. That's why we have the Snoop mnemonic. The Snoop mnemonic, there's a big table on page 7.2 of your handout that breaks this out. And I'm just going to go through it quickly because this is not the majority of headaches. This is really the safety issue. This is how, when somebody comes to you and says, I have headache, you want to make sure that you're not dealing with a secondary headache. Remember, 99% of the time you won't be, but that 1%, you definitely want to find it. So the Snoop mnemonic, SNOOP, they all stand for things that you want to assess when you see a patient with a headache to help you, like these are red flags for you that you need to further investigate an underlying problem. S for systemic symptoms. If the patient is having headaches and unplanned weight loss, and fever, or other indices of infection, then yes, it's probably a symptom of an underlying problem. If the patient has HIV, if they have cancer, if they are on anticoagulants and they suddenly have headaches, you're worried about a bleed. Even pregnancy. You know how many young women find out they're pregnant because they think they have a migraine? Because the first trimester of pregnancy is like hormone central, like the hormones are just out of control. And for some women, it gives them horrible headaches. Interestingly, some women who have migraines don't have any at all during pregnancy. I can't explain that. Don't ask me to. But I do know that it's not uncommon that women get really bad headaches. They think it's a migraine because it's so bad. They make an appointment and come in and they say to you, oh, I'm having a migraine. And you say, really? How do you know you're having a migraine? How often do you have them? And the patient's like, oh, this is the first one. I never had them before. And then as you go through a review of systems, you find out the period's a little late. And then you do a pregnancy test and boom, there it is. There it is. There's the very first headache that's sure to be one of many associated with this phenomenon. So yeah, there's a secondary headache. There's always another cause, and sometimes it's very dangerous and sometimes it's not. N for neurologic findings. Any newly acquired neuro findings in the setting of headache, the patient must be put in a CAT scanner. Now, if this happens to them repeatedly, like if you walk in the room and the patient's laying there in the dark with a pair of sunglasses on, and you try to talk to them and like half their face doesn't move, and you say, oh my goodness, your face isn't moving. And the patient's like, oh, this happens every time I get a headache. Okay, we're not worried about that one. But any newly acquired neurofinding with a headache must go in scanner. The two O's are both for onset because there are so many things associated with onset. One of them is character of the onset. If the headache is truly just bam, out of the blue, takes over their head, they just go from 0 to just like that. That's called an apoplectic headache, split-second headache, thunderclap headache. Like there's a ton of different names for it. That patient needs to go to the emergency room right in a scanner. If the headache, I mean, it might be really, really bad, but if you ask the patient, hey, did this just come on you like out of the blue all of a sudden? If they even hesitate for a minute, the answer is no. Because like migraines, tensions, clusters, these can be very, very, very bad headaches, but the patient knows they're coming. They don't just bam out of the blue. They get a twinge. Any of you ever get migraines? You know exactly what I'm talking about. You start to get that twinge and you're like, oh God, oh crap. And then if you're smart, you'll take something right then. A lot of us are not because, you hear things like, "Oh, I just don't want to always take meds. I want to try to power through. I just figured I'd go to sleep." You hear all these excuses about not taking medication. And then, of course, 2 hours later, they need their head amputated because they're having 10 on 10 scale pain. That's different than an apoplectic headache. When the headache just bam, oh, like globally, just overwhelmingly boom, right off the bat really nails them, they need to go in a CAT scanner. Also, things like if the headache is worse when they lay down, if like it seems to be exacerbated by things that increase intracranial pressure, that's more of a concern. And then the other O is for age of onset. Tension, migraine, and cluster virtually all start somewhere around adolescence or young adulthood. They torture the patient for the rest of their adult life. And then after the age of 60 seem to back off a little bit. Like you'll see people that have suffered with clusters from what I hear are just the unbearablest of unbearable. And then when they get like that very late middle age approaching old age, they just stop getting them. Who knows why? I mean, could it be because life stressors slow down or is it because the hormonal fluctuations quiet down? Don't know, don't care. This is the way it is with migraines too, and frankly, I'm just looking forward to it. But that's the pattern. They pretty much ruin your entire adult life, and then when you get old, they go away. Whereas if you have a patient who is complaining of headache and they're over 50 and they haven't gotten any sort of regular headaches before, this is concerning for a secondary headache. Same thing if they're very young. You don't really see 4-year-olds running around saying, "Oh, do you have any Motrin? My head's killing me." If they do, they're imitating the parent. But little kids with headaches, every once in a while, if you work with really, really troubled kids, sometimes they will somaticize anxiety as a headache. But for the most part, little kids don't get headaches. And then P, there's 3 Ps here, prior headache history, positional, and papilledema. So you can read through the details here, but if any of these are associated with your headache, this is something that we should definitely continue a further workup, whether it needs an immediate image or a schedule for an MRI. These things all suggest a secondary headache phenomenon. Test success tip. Keep in mind the majority of people with primary headache do not seek care and self-manage. That's so true. Most people with tension, migraine, and cluster, they pretty much just torture themselves for most of their life until finally, for whatever reason, it gets worse. I mean, we know with women around menopause, it tends to get very lost. Very lost. Did I just say lost? Women around menopause, they do tend to get worse. There's clearly a hormonal association there. But many people go years and years without ever seeking professional help for it. And but finally, though, often something will push them over the edge. And then when you start to do the interview, you'll find that headaches have been part of their adult life forever. Table 7.3 in your handout. We don't have slides for this table, unfortunately. I think it's a really good one for you to go over as you're studying for your boards. It breaks down some of the different symptom presentations for primary headache. And just to point out like a couple of things. Number one, tension headaches. Notice that tension headaches classically are described as feeling like your head's in a vice, like it tends to be bilateral. Excuse me. And tension headaches typically are not characterized by associated symptoms. photophobia or phonophobia. Sometimes, just as a vagal response to pain, the patient might get a little nauseous, but usually no significant additional symptoms. If they're present, you're probably dealing with a migraine. Whereas migraine with aura and migraine without, the only difference between those two is the aura. But migraines really do tend to be centered in a unilateral location. Now, but if you see a patient in the middle of a headache, it can just be so bad. They're like, my whole head hurts. But if you can get a little pain relief on board and get a good history, it usually does localize to somewhere. um, these headaches do have distinct associated symptoms. Nausea, vomiting, photophobia, and phonophobia, any combination of the above. Nausea and vomiting are almost always there. And I mean nausea to the extent that they need to be treated for it. Most people having migraines, they welcome the vomit because they know they're like on the downside of that migraine. The photophobia can really be profound. Like they need the lights off in the room and they sit there with sunglasses and stuff. Much more dramatic than associated symptoms with other headache syndrome. Notice also that the male to female ratio favors females. And notice that the family history is almost always there. I worked for a little while in a headache center, and the neurologist there was of the very firm opinion was of that if you had the family history of the biological relatives and there wasn't headaches in it, the patient wasn't having a migraine. Um, now, the relatives may not have been diagnosed with migraine, but there's virtually always a first degree relative with a headache syndrome in patients with migraine. Cluster headaches, not so much. Cluster headaches really are different. They're intensely painful, but they tend to be much more short lived. But the patient will have several through the day with distinct pain free periods in between. And when you have associated symptoms with cluster headache, they're usually histamine mediated, like runny eye, itchy nose, runny nose, scratchy throat, that kind of thing. And all of these things are like actually true stuff that really happens. These aren't textbook distinctions that nobody will have. So sometimes when the patient's in the middle of a bad headache, it's hard to get any meaningful history. But like I said, get some pain relief on board, and then you can usually get a decent history, and you'll find the answer to your syndrome pretty quickly. Now, test success tip is, of course, you will most likely be tested on classic presentations. We've said that over and over, and that the same is true of headache as well. So for that reason, we're going to match the pattern and patient description of tension, migraine, and cluster. Which one of those three do you think it is when a 40-year-old woman says, during a headache, I have constant pressure and pain on both sides of my head. I've had headaches like this since I was about 11, especially when I'm stressed. Classic tension headache. Whereas a 28-year-old woman says, during a headache, I have a throbbing feeling on one side of my head, and it's worse above my eye and at the base of my skull. I feel sick to my stomach when I have a headache. For the last 12 years, I get headaches mostly during the weeks before my period. Mom and sister have headaches just like this. I mean, it couldn't be more of a giveaway. And finally, from a 32-year-old man, during a headache, I have a really strong constant pain behind one eye, along with runny nose and watery eyes. I had my first headache just like this a few years ago. Grandpa had headaches like this too. All right, aside from the family history, which may or may not be present in a cluster headache, it's those histamine mediated symptoms, the pain behind the eye, the runny nose, the watery eyes. That sounds very much like a cluster headache. And that's what we've got. Now, on page what is it, 130 of your handout, you see this table about types of therapy. We've already talked about rescue therapy versus curative therapy. Abortive or acute is the same as rescue therapy. You use it at the time of headache onset to try to get relief from this episode. We have several drugs we can use, and you see them here on the slide. And the important thing is that the patient just be advised strongly to not wait. We know a lot about the trajectory of migraine and how it moves through the cranial vasculature, and you have to get it when it first starts. If you wait for that inflammation to become embedded, it's really, really hard to get it under control. Prophylactic therapy, on the other hand, is preventative. It's controller therapy. This isn't something we take when you get a headache. This is stuff you take on a regular basis to try to keep from getting them. And I mean, everybody still gets them, but it can definitely lower the intensity, the severity, the frequency of your headache. And if people get headaches frequently enough, then it's definitely worth everyday preventative therapy. So, test success tip: the best medication for treatment or prevention of headache is the one that works for the patient. This is so true. There are so many options out there, and they all work differently for different people. One med that like saves somebody's life makes no difference at all for somebody else. Sometimes it's just trial and error and what works for that patient. Now, table 7.5 is also a primary headache table, and also we don't have slides for it, which I totally don't understand. I hope that you will take a few minutes to go through this as you're studying on your own. The bottom line is that we're talking here about controller therapies or prophylactic therapies and rescue therapies. And the real takeaway message is that in the world of rescue therapy, we have the triptans and the gpants. We have Ubrelvy and a couple of others too. But triptans and gpants. Triptans are the older one, the gpants are the new ones. The triptans are contraindicated in uncontrolled hypertension and coronary artery disease because they do cause vascular spasm. The gpants are not contraindicated in coronary artery disease or hypertension, but they are contraindicated in pregnancy. So there's your safety issues. And as far as the prophylactic medications go, the CGRP inhibitors there at the bottom of that column on page 131, they're the newest kids on the block. And the beta blocker is the old school cheap option. And then beyond that, I mean, we just give people whatever they need. People that are suffering with really bad migraines, I mean, it can be most horrendous, and not everybody responds to these new amazing drugs. And sometimes we just have to give them whatever it takes to get them some relief. All right, let's look at Katie. Katie is a 33-year-old woman who reports a 10-year history of unilateral pulsating headache that lasts at least 6 hours and up to 24 hours, occurring 3 to 4 times a month. The headache is typically preceded by gradual onset paresthesia affecting the ipsilateral face and arm, which lasts about 20 minutes. She reports severe photophobia and phonophobia, as well as left-sided cephalgia during the headache duration. She states the headaches appear randomly, and her cousin, mother, and sister have similar headaches. Katie's presentation is consistent with what? Oh dear. Well, look it up in the dictionary. There's Katie. Katie has a migraine. It's just absolute textbook. Family history, character, everything. So as a result of her headaches, Katie typically needs to either call, oh, there she is. As a result of her headaches, Katie typically needs to either call in sick or leave work early at least once a month due to headache. Katie has used over-the-counter medications with partial relief of pain, but continued photo and phonophobia. She is currently headache-free, and neurological exam is within normal limits. Given Katie's clinical presentation, you prescribe which of the following? Choose all that apply. An oral triptan, migraine prophylactic or preventative therapy, an oral NSAID, or a short course of a systemic corticosteroid. Given her current circumstances, does Katie need an oral triptan? And the answer is yes. You know, Katie is having migraines, and every migrainer should have a rescue therapy immediately available to them. Does Katie need prophylactic or preventative therapy? Absolutely. She's like missing days from work every month, so totally she needs it. Should she be on an oral steroid? Yes, oral steroids do suppress inflammation, and so it's complementary to the triptan. The triptans stabilize the pain-sensitive cranial vasculature, and the oral NSAID, if it's not contraindicated, can actually work, what's the word, synergistically with that. So it just from two different directions can help suppress the patient's migraine. The one thing that she doesn't need at this point is a short course of a systemic steroid. That's a second line approach to the world. So first for Katie, we will try all of the first line therapies. We'll give her a rescue triptan. We'll make sure she's on prophylactic therapy. and we will use the oral NSAID. And if she can't get relief with any of those things, then we may actually have to go to tier 2. Typically, steroids are used for migraine that's just unresponsive. I mean, like I said, not everybody responds, and we have to go a step or two further, and steroids can be very useful for that. But for now, we'll start with the first line. All right, test success tip again. Do not do a test that does help that does let me say that again. Do not do a test that does not help. That is a tongue twister. That's really unfair at the end of the day after talking for almost 8, 9 solid hours. Do not do a test. Do not do a test that does not help with diagnosis or treatment plan. Primary headache is a diagnosis made clinically through a comprehensive history and physical examination. And that is a true story. I mean, like I think I mentioned it earlier in some context, we don't shotgun people. We just don't do a bunch of stuff. We do targeted evaluations that will contribute to the diagnosis or contribute to the plan of care. And for primary headaches, it's usually not required. Primary headaches are a clinical diagnosis. So when Katie asks if she needs any test to see what causes her headaches, you respond that she should do what? Should she have a head CT? No, she's been having headaches for 10 years. This is not a secondary headache, right? Nobody has like brain tumors or brain bleeds that are unchanged for a 10-year period. Should she keep a headache diary? Absolutely. Headache diaries are enormously important for people with primary headache syndromes. Most of them have triggers, and the patient won't know what it is until they keep a diary and see how things shake out. Similarly, she does not need a neurologist. She does not need an MRI. This is not a secondary headache. She's been having symptoms for 10 years. It's a classic migraine scenario. So, what she does need to do is keep a diary because she said her headaches appear randomly. So, she doesn't know what her triggers are. So, keeping a diary can absolutely help her figure this out. I mean, it's amazing what a difference it can make for people. They realize that maybe it's a lack of sleep trigger, a food trigger, hormonal triggers, all of the above. So the best answer for her is just to keep that headache diary, and then we will reevaluate. Table 7.6, head MRI versus CT. So when neuroimaging is indicated, well, definitely not with primary headaches, but with secondary headaches, they are. I lost my train of thought that fast. We were just talking about primary headaches and how there's no indication to do imaging. True story. But with secondary headaches, you might need one. I mean, sometimes secondary headaches are due to the flu or sinusitis. You don't need imaging for that. But sometimes they are due to brain bleeds, and you do need imaging for that. So I wouldn't say that across the board you always need imaging with a secondary headache, but definitely be alert like to the apoplectic headaches, those things that are red flags, and consider the type of imaging that will help you. The world of radiology has just gotten so specialized, like there's just so much different subtext here. But as a very general rule, MRI versus CT. The non-contrast CT is easy, cheap, and fast. So like the patient with the apoplectic headache, they need to be in a non-contrast scanner. Yes, it's going to irradiate them, but those apoplectic headaches are very concerning. These are easy, they're cheap, they're fast. They don't give people claustrophobia. The scanner is wide enough that it doesn't make them scared or nervous. The CT scan itself is like 3 or 4 minutes. They're very readily accessible. So for like the acute apoplectic headache, they can show you like gross changes, acute bleeds, stuff like that. The MRI is just the opposite. The MRI is not easy, cheap, and fast. The MRI is expensive, slow, and hard. MRIs, they put that Hannibal Lecter thing over the patient's face and then put them in the magnet, and then they have to lay there for at least a half hour, and the magnet bangs in their head. That's not the thing to do for that acute apoplectic headache. Now, if you have the patient who is having like progressive headache symptoms and maybe they're having some focal deficits between headaches, but it's like not emergent. Yes, then an MRI, it can see much with much more precision. It can see much more subtle changes. So MRIs are harder, they're more expensive, they're uncomfortable, but they can give you a lot more finite information, whereas the non-contrast CT is just a grosser study for the immediate emergency. And then the contrast CT is for when you really want an MRI, but you can't have one, like maybe the patient can't go in the magnet, they have metal or something in their body. The contrast CT does give you a bit more detail, but it also potentially shuts down the kidneys. So it's always six of one, half dozen of the other. Now, I am no radiographic expert, believe you me. My radiographic expertise is I have a friend who's a radiologist. And so from time to time, I might cell phone a picture and take away identifying information and test it over and ask like what I should do with it, especially in the rural settings and stuff where you don't want to send somebody, to a specialty like a day away unless you really have to. So this image, like on the left, you see an MRI, on the right, you see a CAT scan. You can see that this CAT scan is just a more gross picture, although the MRI, like the guy's got a thing the size of a baseball in his head, so you didn't really need an MRI for that. MRIs can find things that are like really a matter of millimeters. But for the most part, when you do imaging anymore, your best bet is to go to the website of the radiology center because they usually have like links to what part of the body and what the problem is, and then they will tell you exactly what to use. Anyway, that's the story on imaging as far as we know it. Now, test success tip number 522, most medication questions are safety and efficacy. Again, true story. You don't have to know all the finite little details and the oddball stuff. It's mostly about safety and efficacy. So, Katie requests advice on family planning. She has not been pregnant in the past. Given her history, which of the following is the least desirable contraceptive form for Katie? So, good job. Katie needs advice on family planning, so clearly her headaches have improved. So, what are we going to do? Or what are we not going to do, I guess I would say? What's the least desirable contraception for migraine Katie? Well, you've got four options there. And you might notice that only one of them has estrogen in it, and that's the least desirable form. Estrogen triggers migraines. We know this. So patients with migraine headaches should not be on estrogen. You can try any number of progestin-based compounds like levonorgestrel or the progestin implant Nexplanon. You can try a copper IUD, but the thing to stay away from is the estrogen. And when you do the family planning module, you'll go through the medical eligibility criteria categories for contraception, and it will remind you no estrogen for migrainers. Oh, look, another test success tip. Just when I was starting to be afraid there were no more. Look for clues in the info in the patient scenario that will steer you toward the best, not just the correct answer. Absolutely. We said this first thing this morning. It's not just about a good answer, it's about the best of those provided. Okay, question 6. From the choices below, match the most appropriate medication choices with the following clinical scenarios where headache therapy is indicated. Each option can be used only once. All right, so we have Aimovig, nortriptyline, and Ubrelvy. Which one of those is most appropriate for a 33-year-old otherwise well woman with 8 migraine days a month? She has failed to improve or not tolerated multiple controller and prophylactic meds, including tricyclics, beta blockers, antiepileptics, etc. She's not tolerating anything. What are we going to use? And it would be the injectable CGRP inhibitor for controller therapy. Whereas a 28-year-old woman who has 6 tension headache days a month, trouble initiating and maintaining sleep, and she has a significant insurance copay, so money is really an issue. For her, the tricyclic. These are old, these are inexpensive. They've gotten a bad name because there are potential adverse effect profiles, and like in older patients or people with lots of comorbidities, they're not the best idea. But for somebody like this, they're very appropriate and can be very effective. And then finally, a 55-year-old woman with a history of acute coronary syndrome. She's tried acetaminophen for acute abortive migraine therapy, and it's not helping. What's left? Ubrelvy, the oral Gpan. It's one of the few that is indicated both as prophylaxis and as acute abortive therapy. But again, the best answer for any patient is the one that works. People are just so variable in how they respond to so many therapies, including migraine. So sometimes you just have to try multiple ones before you get to the one that really does the job for the patient. All right, this is our last patient of the whole world. We have a couple questions yet, so don't get too excited, but this is our last patient for all of today. Mrs. Jensen is an 82-year-old woman with a 20-year history of generalized osteoarthritis and well-controlled systolic hypertension. She also had an episode of ophthalmologic herpes zoster at age 60 years old and a remote history of migraine without aura, stating her headaches have been rare since she was 51 years old. Today, she presents with a 3-day history of right-sided headache with accompanying right-sided jaw pain on chewing. Over-the-counter analgesics have provided little relief. She states she is eating little due to the pain on chewing, but she is taking liquids without difficulty. Mrs. Jensen reports, I can hardly wash my hair. My scalp is so sore. I've never had a headache like this in my entire life. Physical examination reveals the following. Blood pressure is 168/88 bilaterally. Her pulse is 88. Her respiratory rate looks good. She appears uncomfortable with poorly groomed hair on the right side only. Pupils are equal, round, react to light, and accommodate. Cranial nerve function 2 through 12 is intact. Remaining neuroexam is within normal limits. Carotid upstroke is normal, without bruit, and she has a tender, palpable, pulseless structure in the right temple area. If you remember that whole story, because it was a long one, Mrs. Jensen's clinical presentation is most consistent with what? Postherpetic neuralgia, migraine without aura, giant cell arteritis, or angle closure glaucoma. And after carefully reading all 4 answer choices, this is just an absolute textbook recitation of giant cell arteritis. So, if we can agree that this is giant cell arteritis, which is the artist formerly known as temporal arteritis, and a lot of you may still call it that, but the proper name is giant cell arteritis. If we can agree on that, which of the following represents the best choice of initial test to support Mrs. Jensen's presumptive diagnosis? SED rate, enhanced contrast brain MRI, head CT without contrast, or an arterial biopsy? So answer that to yourself, and then we'll just give it a beat, and then I'm going to read the question again. Which of the following represents the best choice of initial test to support Mrs. Jensen's presumptive diagnosis? The best choice for initial test is the SED rate. Many people go right to the biopsy or the MRI, which is a more definitive confirmation study, but the initial test is the SED rate. It's easier, it's cheaper, it's faster. And listen, if the SED rate is normal, this is not giant cell arteritis. The SED rate, like giant cell arteritis or temporal arteritis, is an autoimmune disorder. And if the patient is symptomatic, they're having a symptomatic flare of an autoimmune disorder, that SED rate is going to be very high. And so that's the first thing we check. If the SED rate is over 100, yes, you may have arteritis. Then you can do your biopsy or the MRI if you work in that sort of facility to confirm it. If the SED rate is normal, move along. You have another diagnosis here. And you can see what the biopsy would look like. So this is what the artery is supposed to look like. This is what happens after many episodes of inflammation. As you develop a treatment plan for Mrs. Jensen, you consider that likely. NSAIDs will be helpful in symptom management. Reducing her blood pressure is important to minimize headache symptoms. Long-term high-dose systemic corticosteroid therapy will be needed, or opioid use is contraindicated. What's the best answer here that you consider about her treatment plan? And this is another one that people get stuck on sometimes and just sort of get lost in the distractors. But the answer is hands down long-term high-dose systemic steroid therapy. NSAIDs probably won't help her symptoms because it's that profound inflammation. Reducing a blood pressure of 160/88 or whatever it was is really not going to make any difference. That doesn't cause a headache. And opioid use, I don't know if it's contraindicated here or not. I know we live in such an opioid-resistant society. We always want to say opioid use is contraindicated. But whatever else you do or don't consider, she must go on high-dose systemic steroid therapy. There are immune modulators that are used for giant cell arteritis, but for the most part, what people have ready access to is corticosteroid therapy. We're talking like 60 milligrams of prednisone a day for a couple of months until that SED rate comes down. But we just need to get her on this immediately because which of the following is a potential serious complication of Mrs. Jensen's presumptive diagnosis? Well, you saw the lumen on that artery, and that temporal artery feeds the optic nerve. And if that thing infarcts and the optic nerve infarcts, then that's going to be the end of vision for Mrs. Jensen, and it's not reversible. So the real concern here is blindness. She needs to get on a corticosteroid immediately to reduce the inflammation in that artery, maintain flow to her optic nerve, and make sure we maintain her vision. And that, folks, is the end of the day. As is always the case, there are additional various and sundry, what do you call them, in your handout. You know, there's more tables. You can read about giant cell arteritis. You can read about triggers for migraine. But that's it for us for today. So that takes us to the end of our chapter. I see 5:41 Eastern time, so that means that we're going to be back in, let's see, 5 and that's 12 and 15. We'll be back in 15 minutes, not 15 minutes, 15 hours and 19 minutes. And I do see some questions in the Q&A box, so I'm going to do my best to try and answer them for anybody who cares to stay and listen. And if you don't, I will see you tomorrow in 15 hours and 18 minutes. All right, let's see what these questions are. Can you briefly discuss the TB information provided on pages 40 to 43? If a patient from Eastern Europe has a history of positive skin test, one positive quant gold test, but negative x-rays, is it still appropriate to advise them to treat for TB? Can this patient reliably use quant gold going forward to check for tuberculosis? So, however, regardless of the history and regardless of the x-ray, if they have positive skin test and they have one positive quant, they need to be offered treatment, not for acute pulmonary TB. The negative X-ray really precludes a suspicion of acute pulmonary TB, but they need a prophylactic regimen. It's advised by the CDC that they do have the prophylactic regimen. The problem is it's not paid for by the health department. I mean, we're talking about like 9 months here of rifampin and B6, and it is advised that the patient have it, but it's on their own expense. They're not monitored like they are if they have active pulmonary tuberculosis. And, patients often choose not to do it. So what it all comes down to in the end, if you have positive screening, which is what the skin test and the quant are, if you have a positive screening but a negative X-ray, you are advised to use prophylactic measure that is on your own expense. If the x-rays are positive, obviously, then you have to, notify the health department and they will come biopsy it. And then very often the patient is put on a more curative, directly observed therapy regimen, not at their own expense. But the short answer to your question, and short answers I am rarely capable of, this patient should be offered a prophylactic regimen. At the end, would you be able to review thalassemia again? I can, briefly, because we did talk about it quite a bit this morning, but I mean, in summary, thalassemia is also a hemoglobin problem. So in the world of anemias, if you look at the H&H and the H&H is low, patient's anemic. Then you look at the MCV. The MCV, mean cell volume, is comprised almost entirely of hemoglobin. So if the MCV is low, the patient has a hemoglobin problem. And the two primary hemoglobin problems are iron deficiency and thalassemia. Iron deficiency because they don't have enough iron to make new heme, and thalassemia because they have an abnormality in the DNA code for globin. So when they make hemoglobin, the globin is dysfunctional. It's atypical because of the DNA mutation. So instead of making hemoglobin A1, they make an elevation of hemoglobin A2 or some other abnormal hemoglobin. That's what thalassemia is. And so to diagnose it, you have to do a hemoglobin electrophoresis because it phoresis out the different types of hemoglobin. And if the patient has thalassemia, there's really nothing to do about it except monitor them, genetic counseling, and transfuse if they get low. Thalassemia minor is usually not an issue. Like I said, it's autosomal recessive. If they only have one gene, it really is primarily about genetic counseling. The reason we don't give iron is because they don't have an iron deficiency. Their anemia has nothing to do with iron. So if they don't have an iron deficiency and we start repleting iron, the concern is putting them into iron overload. And iron overload can result in iron depositing in the dense organs, and that's its whole own problem. So, the real difference is thalassemia, it's genetic. You're born with it, you have it all your life, and you die with it. You have a hemoglobin abnormality, but it's not that you can't make it. It's that what you make is abnormal because of the DNA code. And so the patient just has a tendency to anemia through the lifespan. And I think that's like the thumbnail version. That is the difference. The recognition of it is number one, the risk factors, like the racial and ethnic groups, patients of Mediterranean ancestry, Asian ancestry, and African ancestry are at highest risk. And you'd be suspicious for it when you see that the patient is anemic, microcytic, and the MCV tends to be very low. They're microcytic, but the RDW is normal. The RDW is normal because you don't have any variability because the cells are all the same size, they're just too small. And I hope that helps. That's the thumbnail version. Will there be questions on boards about selecting the correct antibiotic? Not to the extent that we went through here. I mean, one thing that I might say you should be familiar with that you might have questions about are for UTI. Now, we're going to talk about this more tomorrow, but there is a real push on for us to stop using fluoroquinolones for an uncomplicated UTI and to use Bactrim. Bactrim is the drug of choice recommended by every authoritative statement for an uncomplicated UTI. I could definitely see a question where you had to choose Bactrim as the correct approach to a UTI. I can't promise you that you won't have questions about antibiotics, but more likely the question is likely to center around, do you need one or not, rather than which one. I don't envision questions where you get a scenario and you have 4 antibiotics and you have to pick one. But I do envision a scenario where you might have a clinical circumstance and it asks you what drug class is appropriate next. And one option is antibiotics, and another one is an antihistamine, and another one is something else. And you have to decide if an antibiotic is appropriate. Believe me, we are totally not done with the antibiotic conversation yet. Tomorrow morning, we're going to talk more about them when we talk about pneumonia. And then we'll talk about them again when we talk about genitourinary phenomenon. I think she may have skipped pharyngitis. No, you have an old book. Pharyngitis, at the very end of chapter 4, there used to be a couple of questions about pharyngitis that for 2025 was moved to the pediatric section. So if you see it in the workbook that you have an old workbook. And usually that happens if you registered for the course like late last year, or you registered for it last year, got the workbook, and then chose to come to this one instead. So if you look ahead, look in chapter 15 in your workbook. At the end of chapter 15 in your workbook, that's where that question is. So Dr. Fitzgerald actually goes over it when she goes over that in your on-demand section. Will we have photos like in our book for boards for derm? That's a good question. Once ever do I remember having derm photos. I certainly don't see them every time I take boards. I don't know if they are incorporated there once in a while or if that was one of those validation questions, but I can tell you that when I saw a picture, it was very obvious. It was actually an easy question. The question was like something like, which of the following requires biopsy? And then there were 4 pictures, and one of them was this ulcerating, horrible looking ulcer, and the other ones were 3 very benign presentations. So it's possible. I'd really be curious to hear your feedback if you do find pictures, but I can tell you in my limited experience with pictures, it really was, they were among, easier questions. They were just very straightforward. And I think that's that. I don't see any other questions here. So I'll wait another minute or two to see if anything pops up, and then for those of you that are gonna disappear, I will see you in 15 hours and 10 minutes. Time's gonna go very fast, I promise. All right, folks, have a good night.
Record.